Good morning, Professor Anders, Ms. Nora, our past president, Rameshwan sir, Professor Ghosh, our University Vice Chancellor, Dr. Mohanan, Dr. Jayaprakash Madhavan, Dr. MKC, Dr. Vasudevan, Dr. Professor Babumati sir, Dr. C.S. Madhu, our former secretary, and all the dignitaries, Dr. Induskan. So we are starting today's CME. Actually, this is the formal conference convention. Yesterday, we had a training program for the student and junior doctors. Today, we are having the main conference. And I request just one announcement. We'll have a tea will be available, tea and snacks will be available between 10 and 11. But before that, going to the tea, I would suggest to have the food coupon, lunch coupon. Sometimes they may ask the lunch coupon just to show that. So that, and the lunch will be from in the main hall, just in front of the old college. I request our scientific committee convener, Dr. S. Vasudevan, to do the formal welcome.
Good morning. It's a great honor to be the convener of this scientific committee of Platinum Jubilee Medical Convention. I have three. Panikar sir has already welcomed everyone. So my job is to highlight certain things. One, we have a very long day of academic programs today. So we need to be very prudent in time management. Our team will tell us what are the ground rules today. Second thing is we have this same thing going in FB Live as well as in YouTube. So the link has been shared to everybody. Please share with your friends so that more people can watch our faculty. Thank you. Over to the announcing team. We will have our Vice Chancellor to formally open this session, which has been named appropriately as the KUHS session. Over to you, sir.
A very good morning to you all. Professor Robert Gallo, Professor Andres Vaughn, Ms. Nora, former Vice Chancellor Dr. MKC Nair, Gagandeep Kang, eminent faculty members, and my dear students. Kerala University of Health Sciences is extremely happy and proud to organize this session on virology along with Trivandrum Medical College Alumni Association. Till recently, all of us thought we have won the war against infectious diseases, against viruses, against bacteria, and suddenly COVID jolted us, shattered us, and now we suddenly realize viruses are here. And they have been here millions and millions of years ago, even before the human being existed. And they are in number, millions and millions in time of the number of human beings. In fact, they are our seniors, and they have the capacity to destroy the human race. We had battle with viruses, and very often we lost many people, but we have won. But now we realize we should have an organized defense against these viral infections. And that's one of the defenses is the global virus network, and which was launched by Professor Robert Gallo and others. And this meeting again is a defense against viral infections. The One Health concept launched by WHO is again another defense against the viral attacks. We have to survive, and we will survive. And this survival can be done through sharing knowledge, creating knowledge. And that's why we are here. And that is the business of any university, and Kerala University of Health Sciences is doing exactly that. Now I come to the formal welcome. Professor Robert Gallo, the man who chased the AIDS virus and who narrowly missed the Nobel Prize from Institute of Human Virology, Baltimore. Unfortunately, he could not come personally because of technical reasons, but he will be talking to us from Baltimore online. And in addition to that, today evening, we are releasing a book written by him, Chasing the Virus, which is translated in Malayalam by one of the most eminent translators of Kerala, Sri Kunjukrishnan. Today evening, we will be releasing that legendary work. Now, we have the other speaker, a living legend on virology, clinical virology, Professor Anders Vaughn. And he has come from Karolinska Institute, Sweden. And Karolinska Institute, we all know, the institute which decides who will get Nobel Prize this year. And he has come from that great institute. Welcome, sir. Thank you to. He is coming to India for the first time, and he has come straight to Trivandrum Medical College. Along with him, in fact, Robert Gallo has sent the coordinator of the global network against global virus network, and Nora, she has come from Baltimore. Welcome, Nora. And she will be coordinating all these programs. And now, India's defense against COVID, Gagandeep Kang is here. She has come from CMC Vellore. Welcome, madam, to this meeting. And this session will be chaired by the eminent virologist, eminent Sri Kumar, Dr. Sri Kumar. Sri Kumar is the director of Institute of Advanced Virology, and Institute of Advanced Virology is Kerala's defense against the viral infections. Welcome, Sri Kumar. And Professor Indu, faculty of Kerala University of Health Sciences, and currently the Professor of Community Medicine. She is co-chairing. Welcome, Dr. Indu. And I welcome all other faculty members. And now the session is open to you. Dr. Sri Kumar and Dr. Indu, please take chair and we will start the program. First, we will have the online talk by Robert Gallo.
Good morning and welcome to a very interesting session on virology. And thanks to the COVID pandemic, this virology has become all the more important in our life. Even though we have been facing these pandemics many times, maybe H1N1 influenza, chikungunya, Zika, and all other kinds of pandemic for the last, maybe we can call this century a century of pandemics. Maybe there are multiple reasons for increase in the number of pandemics now, but COVID has changed all our perspectives on this pathogen. And we had to unitedly fight this organism, or we can say this entity. And now this session is going to be one of the important sessions in the whole program. So I have Professor Indu PS as my co-chair. She is the professor of preventive medicine in Government Medical College, Paripalli. I thank the organizers for this opportunity, and I consider this is a privilege to be here to talk to you and introduce eminent speakers in the field of virology. So we have 3 speakers for the session today. Professor Gallo, Robert Gallo, all of you know him. He has been introduced sufficiently. And we have Professor Anders Wallin. He will be talking on monkeypox and future challenges. And we have Professor Gagandeep Kang. We all know her, her eminent stand on the COVID management and how she has made a very beautiful institution or brought the Translational Health Science Center into the forefront of virology in the wake of a COVID pandemic. So we will listen to all these speakers, and I will not take too much of your time. Let me start introducing Robert Gallo. All of us know about him, and he is a co-discoverer of the HIV-1. And interestingly, his first discovery was on the human T lymphotropic virus, where there was actually a person from Kerala who was as the first author of the science paper that was published. Dr. Sharangadharan was one of the first authors in that paper. So we should be happy that we had a long-standing association with him. And interestingly, he also contributed in multiple domains of the HIV disease per se, like identifying the chemokines, identifying the T cell growth factor, that is the interleukin-2 that we call now. So his laboratory in the NIH, the Cancer Institute laboratory, has played a multiple role in the field of this disease. And he worked for 30 years in the NIH, and now he is extremely active. He has started the Institute of Human Virology in Baltimore. I was fortunate to be in Baltimore in Johns Hopkins for around 9 months as a part of my Fulbright fellowship. But unfortunately, I didn't find time to visit this institute, but I was passing in front of the institute many. And every time I used to think I should visit the place, but I could not get time to visit the place. But it's a very beautiful city, the Baltimore. And I had a very, very interesting time there, and she will vouch for it. And I could not visit the place, but so it is. I understand that it's an excellent institute that is coming up in multiple domains of disease management, viral disease management. And he worked as the member of the National Academy of US Sciences, and also he received the Lasker Award, which we call as the predecessor for the Nobel Prize, 2 times Lasker Award. Maybe because of some unfortunate decisions, he lost the Nobel Prize. But he is extremely active, and the global virus network that he has managed to conceive and trying to organize it in a much better way, or trying to coordinate all the virology activities, is one of the major activity that will take shape in the future. So I welcome Professor Gallo for this meeting, and let us start with the session. Maybe the other 2 speakers, I'll give the okay, yeah, Dr. Indu wants to speak later. So we'll start the session. Thank you for this.
Greetings, my friends and colleagues in Kerala and anywhere else this might be being observed. I first want to say I'm very sorry and apologize to you for not being there. I had promised my friend Professor Pillai I would come to Kerala. I've been there twice before. I've always had a good experience, wanted to come, but I have conflicts at the Institute where I'm director, the Institute of Human Virology in Baltimore at the University of Maryland. I am Robert Gallo, and I am also the co-founder of the Global Virus Network. I also have another conflict for being with you that would have prevented me from going. I just recently had a severe case of COVID where I had to go to the hospital. So under any circumstances, I would not have been able to have made this trip. However, I am very happy to say you have an outstanding virologist with you who is more than replacing me. He might have come anyway. He is Professor Anders Wallin, professor in virology at the Karolinska Institute in Stockholm. In my mind, Professor Wallin is one of the most scholarly virologists in the world. He has a wealth of information. I hope you will take advantage of it. I'd like to start more formally by saying a few words about the Global Virus Network, which Professor Vaughn is also deeply involved in playing a role internationally. Our idea was to create a network of the best virology people we could to cover every kind of virus and have expertise in it in order to be able to advise public health officials throughout the world and to be connected in case there are pandemics, as we are facing two right now. HIV still persists, and the COVID SARS coronavirus 2 pandemic that we all talk about every day. So in a pandemic, we have to be connected. We have to be collaborative because it involves everyone. And if it's left to simmer, to develop in a certain area of the world while the rest of the world is okay, the danger of it coming back for all, if we think even selfishly, it's in our interest to be cooperative. The Global Virus Network has no political or type of political system requirement. So consequently, we have nations from all over, including Russia, including China, and including, of course, the United States, and much of the rest of the world. There are now 70 centers. I think we're in about 40 different countries and growing. When a center is not fully developed, they're often called an affiliate with the goal that they soon become a center with proper collaboration with some of the other Global Virus Network or GVN centers already in operation. I said that our goal was connecting virologists, the best ones we can, in order to respond and to advise public health officials, but it's also for training virologists. Think about it, that there's always a shortage of virologists, expert virologists. Think about this, how do people go into virology? It's always been by chance, just by, you happen to hear a lecture, you decide to go in virology. We think that should no longer be the case. And there should be adequate virologists trained in every place possible, so that we can have the proper dialogue, the proper potential collaborations, and the proper response to new and puzzling virus phenomena causing serious disease. So that is where the GVN is today. It's growing. It's become much larger and much more active in the last, let's say, 2 years. Our president is Christian Brichot, former president of the Pasteur Institute. And the goals of the GVN right now, or let me put it differently, not the goals, is to work by task forces, the pathways. We're involved in task forces. That is, we gather together experts in a given area and have regular meetings. Of course, we have this on COVID, but there's a Zika, there's HTLV1, the human T-cell leukemia virus, #1, a retrovirus causing adult T-cell leukemia and a serious paralytic neurological disease, as well as autoimmune disease. There's a task force on that because it's not understood well enough. There's a task force that relates to HIV. There's a task force that relates to new emerging pathogens. So there are many of these task forces developed as we need. We also are unique in being able to have an outreach to industry, which is difficult for government-sponsored things, difficult for WHO, for example. We need to be interactive with WHO. We need to be involved with WHO, but we are different. The GVN is much more straightaway science. The WHO relates to all nations, necessary, important, public health, but is not close to everyday science. That's maybe the singular most important difference. And the fact that we don't, receive, we're not against receiving government funding, but so far that's not been the case. We rely on funding from a variety of sources, philanthropy, industry, et cetera, things like that. So there's an important role of the Global Virus Network. And there's a great need for a center in India that's very strong. And in this regard, Kerala has emerged through the great help of our friend, Professor Muni Pillai. A center is established in Kerala, where we know there's a lot of interest in medicine and medical science. One has to only visit there briefly to see how many medical clinics there are in a short distance. We believe Kerala has a chance to really be a leader, not just in India, but maybe in Asia, maybe someday a regional center for a good part of Asia. Also, its importance is highlighted by another problem that India, and especially Southern India, face problems there with epidemics, diseases that are caused by pathogens, mainly viruses, that occur regularly. They're not causing a pandemic because most of these things are insect-borne, and as such, they tend to be regional where certain insects are found. But I don't have to remind you of your problems with chikungunya, Zika, dengue, and for the world, we still have HIV floating around, and now COVID as well. COVID is a true pandemic. True pandemics are something new, something unexpected, something that affects the world. When a pandemic first appears, you should think of change. Something changed to allow this to happen. Well, sometimes you can't find a change because it's in the virus. Think of polio when there was a mutation from an enterovirus, a gastrointestinal virus, that was not causing so much serious disease, thought to be in the type of virus thought to be a Coxsackie, but it became, a variant became neurotropic and was able to cause polio. But most of them are changes in some societal way. I don't want to go through the history of this. I've talked before in Kerala and went through it in some detail. But if you stop and think of the ancient periods, the time of the Roman Empire, another big event, the time of establishing contact, these things fanned the flames and made it a pandemic. We don't know what change occurred to allow SARS, the pandemic of COVID. Change still must have been there. Was it in the markets? New sources of animal food? We don't know that yet. Or was it just a certain mutation in the spike sequence of the virus that allowed this to emerge in such a terrible way? Another generalization I'd like to make about pandemics is that we tend, well, not tend, we always forget. I've heard many commentators say we will never forget the COVID pandemic. Well, that may be true because it goes on and on. So that we're here year after year, but with other pandemics, we always forget. After a generation or a generation and a half, say 25 to 30 years, if you look at the history of the pandemics of the last century, they've been due to viruses, they've been all due to RNA viruses, and we forget all the time. We even forget about HIV, even though it continues to infect about 38 million people in the world, a particular problem, as you all know, in Africa. Sometimes pandemics will have positive spin-offs. In other words, maybe a silver lining on a black cloud. We can say that the HIV pandemic brought us closer together between North and South. For example, the United States helping to Africa became very significant for the first time in public health in a way far larger than it had been in the past. It also brought about a greater appreciation and understanding of differences in sexuality. So and it also, certainly in the United States, brought us had to look in the mirror and see that our public health system needed to return to better days, and we needed to be more involved, and to hopefully, and we think GVN will contribute to this, hopefully never forget. And a continued GVN presence will help us never forget. I don't want to go into more detail because this requires slides, it requires an hour's lecture. And I think that this outline is as much as I really want to do. But I want to end with something important. I want to express my personal thanks and appreciation to Professor Pillai for his friendship, for his connections to Kerala, and for the translation of my book, Virus Hunting, for hopefully for people there to become familiar with. It was written more than 3 decades ago, the period of 1988 and 1989. However, there's nothing in there that I would really take out. It's still applicable today, though of course it doesn't have COVID, it doesn't have some of the epidemics in any significant detail that you face. It has a lot of HIV, it has a lot about retroviruses. And I hope you'll get a chance to look at it. And if you do, I hope you'll think it's worthwhile. I wish you success with conference, and mostly I wish great success for the new Kerala Center in Virology of the Global Virus Network. Thank you.
That was Professor Robert Gallo. Dr. Nora Rebecca, please accept our appreciation and gratitude and communicate that to Professor Gallo. We'll take up questions at the end after the 3 presentations are over. Now we move on to the next speaker, Professor Anders Vaughn. He was former chair of Division of Clinical Microbiology and Virology at the Karolinska Institute. He was well introduced by Dr. Mohan R., Vice Chancellor. He was also the Chief Physician at the Clinical Virology Diagnostic Laboratory at the Karolinska. He serves as the Director for the Karolinska Center of Excellence at the Global Viral Network and is a co-chair of GVN's Task Force on Lone COVID-19. He is a member of the GVN Board of Directors and the GVN Executive Committee. He was on the President's Advisory Board for the Irish National Virus Reference Lab at the University College Dublin from 2010 to 2021. For a long time, that's from 1972 to 86, Vaughn's research focused on neuropathogenesis of herpes simplex virus infections. Thereafter, he switched to mainly work on human retroviruses, in particular HIV. In tune with the current monkeypox outbreak, we also had 4 cases of monkeypox from Kerala and around 10 from all over the country. Let's now listen to Professor Anders on the status of monkeypox and the future challenges. Professor Anders.
Well, thank you very much. And first of all, thank you. I'm very honored to be invited here to Kerala and to this conference. I'm also, as you may have heard, this is my first visit to India. Today I will talk about monkeypox. I've not been working on pox viruses, and very few have for the last 4 decades since we eradicated smallpox. But it's a very, very interesting virus. And how do I change slides? Is there? Here? Lovely. So monkeypox is a pox virus, and it's you see here to the left that it's an orthopox virus, and among orthopox viruses is the variola virus, which is the virus that causes smallpox. It's vaccinia virus, which is a cowpox virus, and which the virus we use to produce vaccine against smallpox, but also against monkeypox. Oh. Jesus. Okay. Got stuck. Okay. So here's a cartoon of a monkeypox virus. These are large, linear double-stranded DNA with quite a large genome, almost 200 kilobases. And it has 190 overlapping open reading frames. And this is a electron micrograph of pox viruses. So monkeypox virus was first identified in 1958 in Cymnologus monkeys in Denmark. But then we didn't know of any human cases until 1970, when a child in the Democratic Republic of Congo was identified. Now we know that there are two distinct clades of the monkeypox virus. One is from the Congo Basin of Central Africa, and then the West African clade. And these have always been zoonotic infections, and the reservoirs has been mainly rodents, as you can see here in the slide, but also infection of monkeys and non-human primates. And of course, other species can be infected. For instance, prairie dogs that were infected by imported rodents from Ghana in the US of 2003, and there were like 60 people infected from the prairie dogs. So, as I just said, it's endemic in Central and West Africa. And now, with the new pandemic that started this year, really in May this year, the virus will be renamed. So it has not been so far. But obviously, monkeypox is not a very good name. And so what the new name is, we will not know. And as I said, there are two distinct clades, the Central African clade and the West African clade. Also, these clades will be renamed. And the Central African clade will be called now clade 1, and the West African clade will be named clade 2. And the West African clade, or clade 2, now has two subclades. One is the original clade found in Western Africa, and then another subclade, which is a strain circulating now in non-African countries. And this is a WHO slide just showing where you find now cases of monkeypox outside of Africa and also in Africa, of course, as you can see. And this clade are a few weeks old. Now we think there are about 35,000 cases, or more than 35,000 cases in the world. But you can see the most cases now are in the Americas and in Europe. And the transmission has been by handling animals, for instance, bites or close contact with the animals, and also in abattoirs dealing with animals. The human-to-human infection has not been considered very efficient, and that's why there hasn't really been any pandemic or big outbreaks of human-to-human infections, except now. And now it's believed to be close contact, sexual intercourse. And outside Africa, in this year, close to 100%. In the US, for instance, 98% in one big study are men who have sex with men that are gay or bisexual. So here's a slide showing the transmission route. You can see that there's no pointer, is there? Oh, yeah. So bites, and then hunting, cooking, and so forth. Blood fluids is the animal route. And then you have the human to human, and I just described this. And now with this new pandemic, you can see that sexual encounter is by far the largest transmission route of monkeypox. This year, on July 23rd, the Director General of the WHO declared monkeypox a public health emergency of international concern. And as I said, as from the WHO figures, is that more than a week ago, there were more than 35,000 cases in 92 countries, but only 12 deaths reported then. So when you look at the fatality, case fatality rate, you can see that clade 1, formerly called the Central African clade, the fatality rate has been around 10%, whereas the clade 2, and now clade 2A, found in Western Africa, the fertility rate has been around 1% or even less than 1%. Now with the clade 2B, the good news is that we only have reported 12 deaths in more than 35,000 cases, which would give a case fertility rate of 0.03%. Now for the clinic, there has been increased risk for young children and for immunocompromised persons, including those living with HIV. We don't have any good figures yet on how treatment, on antiviral treatment, and if they're contained, if the virus infection is contained in the HIV-infected individuals, how that affects their infection with monkeypox. But most probably, my belief is that there would be no more risk than other persons. Now, what describes monkeypox, it's a pox virus disease. So you get these lesions in the skin. And here you can see it starts with just a rash, and then you get macules, and then papules, and then vesicles. And the vesicles turns into pustules, and then you get the crust and then scars. Now, if you take chickenpox, which is caused by a totally different type of virus, which is the varicella zoster virus, which is a herpes virus, these different stages appear at the same time. So if you look at the patient, you will see macules, papules, vesicles, and pustules next to one another, and even a crust. And which was the way you actually could distinguish chickenpox from smallpox. Another difference between smallpox and chickenpox was that the chickenpox lesions were on the body, centrally on the body, and whereas smallpox were more on the extremities and the head. Now that was not always so easy to distinguish. I can tell you, in the last smallpox epidemic we had in Stockholm, and this was in, I think, if I remember correctly, in 1969, the professor of infectious diseases demonstrated a typical case of chickenpox to the medical students, and it turned out to be the first case of the smallpox in that epidemic. So here are this slide, it's in the wrong place, but never mind. So here you see the epidemiological curve of the outbreak now, the pandemic that started early May. And you can see that the red is the European region cases, and the blue is in the Americas, mostly in the US and Canada. So early symptoms are fever, lethargy, myalgia, headache, generalized rash, and then lymphadenopathy and development of lesions. And as I told you, 98% or more are through homosexual close contacts. And you can see now that in the distributions of the lesions. So you now have anorectal lesions, and then anorectal pain, proctitis, tenesmus or diarrhea. You have also pharyngitis, odonophagia, epiglottitis, not so common, but still there are a few cases reported. Oral or tonsillar lesions, and also a few cases of conjunctival mucosa. And just to show you here that these lesions, which are, as you can see, here perianally, and they can be also in the rectum or in the inside. Of inside anus lesions, which are very, very painful. And unfortunately, there can be only quite a few patients only have one single or maybe 2 or 3 lesions, which can then be misinterpreted as, for instance, syphilis, and that has happened a lot. I think I'll skip this slide because I can see now it's too busy. There are complications with this new clade 2B, and those are pneumonias, encephalitis, keratitis, as I just told you, and secondary bacterial infections. There is now therapy, and before this new antiviral, tecovirimat, people were using cidofovir, but it's not really used anymore, and it's kidney toxic too. So this quite good effects of tecovirimat. And as you can see, what the the European Medicines Agency, EMA, says in their website, that tecovirimat works by interfering with a protein called VP37 that is found on the surface of orthopox viruses, including smallpox, monkeypox, and cowpox. By interacting with this protein, the medicine prevents viruses from reproducing normally, slowing down the replication, the speed of infection. Now, this drug was actually developed for smallpox and for military use. Other treatments that have been used is vaccinia immunoglobulin, because there's this very, very strong cross-reactivity between the vaccinia virus immune response and the smallpox virus. Now, we have a vaccine, and so we have now also post-exposure vaccination. There are now 2 vaccines really, because after like 1980, there has not been, we eradicated smallpox from the world. But there are smallpox in freezers in the US and in Russia, we know. And we're afraid that it could be used for terrorist purposes or for biological war purposes. So particularly, as we know of, the US military has bought and stocked Vaccinia virus vaccines, millions and millions of doses. But that's the vaccine we use to eradicate smallpox would never have been allowed today because quite a few people actually died from it, particularly those with atopic eczema or immunocompromised patients that were getting a generalized infection with the Vaccinia virus. Now, there has been development of the Vaccinia where one has made it so that it does not replicate in human cells. And the most common modified variant is what we call Vaccinia modified Ankara. And one vaccine against smallpox is Genotoxic by Bavarian company in Denmark. And since the monkeypox outbreak, it really bloomed, and the stock exchange just hit the roof of this small company because this vaccine can also be used for monkeypox. And as you can see, I told you, you can use it for post-infectious, post-exposure prophylaxis up to 4 days, prevents disease altogether, and up to 2 weeks it will alleviate the infection. So why do we have a new current global outbreak, or the first outbreak? And we think we know now that there is changes to the virus. It's a new subclade. Changes in behavior, waning smallpox immunity, because it's like 50 years, or at least 40 years since people were were vaccinated against smallpox. Relaxation now after the coronavirus disease, or the COVID pandemic. Resumption of travel, amplification of transmission through sexual networks, and which we think is one of the major reasons for this outbreak. So, looking into the future, we really learn how to recognize cases. And that was important already on smallpox, like I just told you about the experience we had in Stockholm. So, and not mistake cases for other CTDs like syphilis. Testing of PCR is now still expensive, but there are developed techniques that actually can be done bedside and which are very, very cheap. They have not been approved yet, but I know at Karolinska they are developing such techniques. We know that this virus also will infect heterosexual people by contact with homosexual people without sexual contact. And for those we know are at risk, there could be and should be pre-exposure prophylaxis, and then particularly with the vaccine and not the antiviral. They will be spread to other populations, and we have to be on our toes, and vigilance is required. So, just on time, thank you very much for listening to me. Okay. Questions up?
Thank you, Professor Vale. Please. We'll have the next speaker continuing, and we'll have the discussion after the end of the sessions.
We move on to the most popular phase in Indian virology, Dr. Gagandeep Kang. She is professor in the Department of Gastrointestinal Sciences at Crescent Medical College, Vellore. She's also the ex-officio member of the working group on COVID-19 vaccines established in the strategic advisory group of experts at the WHO. She's a leading researcher with a major research focus on virus infection in children and the testing of rotaviral vaccines. Kang played a very important role in the efforts that culminated in the development of Rotavac, which is now part of our routine immunization. She was one of the 3 principal investigators in the phase 3 clinical trial of the vaccine. She also works on other enteric virus infections and the consequences when children are infected in early life. She was awarded the prestigious Infosys Prize in Life Sciences in 2016 for her contribution to understanding the natural history of rotavirus and other infectious disease. In 2019, she became the first Indian woman to be elected as Fellow of Royal Society. I think among the public also, you're very popular when she was given an option to choose an important topic in virology for the Platinum Jubilee seminar. She chose human experimental medicine in infectious disease. Madam, please, we look forward to a futuristic and comprehensive overview of virology in India.
So good morning and thank you all for being here. When Indu asked me to choose something that would be really forward-looking, I thought about the most challenging things that we could do to really advance research and product development in India. So if we think about human experimental medicine, it has a definition. It's the use of innovative measurements, models, and designs in studying human subjects for establishing proof of mechanism and concepts of new drugs. So really, it's about using humans as guinea pigs. Now, whenever we say guinea pigs, everybody becomes a little bit nervous. And in India, we become especially nervous because, quite frankly, the idea of exploitation is one that we understand well. We have had an understanding globally of exploitation of human beings, even after Nuremberg. These are examples of studies on syphilis that were done in Guatemala and in the Tuskegee cohort that was followed up without treatment for over 40 years. Now, if the Western world can do this kind of thing to their own people, obviously in India, where we have a much more hierarchical society with much more levels of control, then thinking about experiments on humans makes us all quite nervous. But one thing we have to remember is that all of clinical research is treating people as guinea pigs. Every time we give an off-label treatment, the person who is being treated is a guinea pig. Every time we do a clinical trial, everybody who is participating in that trial is a guinea pig, effectively, right? But I think what has changed in the past few years and what makes me really hopeful about the idea of doing more human experimentation is, one, an understanding that a lot of what we learn from animals does not apply in humans. So a lot of virology, a lot of microbiology, a lot of parasitology gets studied in animal models. And then when we bring it into humans, it doesn't work, or our understanding is flawed in some way or the other. Now, I work on rotaviruses, and rotavirus is a virus that infects many species. You can have rotaviruses in horses, in dogs, you name the animal, they have their own rotavirus. And then you have human rotaviruses. So rotaviruses started to be studied in humans in the 1970s. And one of the things we really worried about with rotavirus was the fact that rotavirus is a lot like flu in that there are 2 proteins that are important for determining the immune response, or so we thought. Flu has the H protein and the N protein. Rotavirus had the G protein and the P protein, also surface proteins. So when vaccines had to be made for rotavirus, everybody focused on how many G types, how many P types can we get into the vaccine. After all, nobody uses a monovalent flu vaccine. We put in influenza A, we put in influenza B, we make sure that we have the good coverage of the H and the N types that we think are going to circulate that year. Well, we made the vaccines and we got them into people, and the drug companies came around, and one company said, my rotavirus vaccine is better because it's from a human strain, but there's only one strain in the vaccine. And the other company said, well, actually, our vaccine is better because we have many viruses in the vaccine, so all the G and P types are covered. And everybody was doing a matching of G type, P type, what is circulating in the country, which vaccine should you bring in. And lo and behold, when the vaccines came in, the monovalent vaccine worked very well. In animal studies, it had been shown that you needed to have a multivalent vaccine. Came into humans, one strain was enough. And that was really because we still don't understand a correlate of protection. But in all the subsequent studies that we have done in humans, we have seen very clearly that the immune response that protects in animals is not the immune response that protects in humans. Now that's true not just for rotavirus, it's also true for many other viruses. And we all understand that for most things, we do animal experiments to set us up for human experimentation. When we develop any drugs, when we develop any vaccines, we take them through phase 1, phase 2, phase 3 testing. And that is looking at a lot of safety parameters and then getting to efficacy. But in all of the human studies we do, we follow ethical principles that require a study to be justified before it is done. You can't experiment on humans because you feel like it. You have to demonstrate that there is social value to the experiments that you're doing and that people will be safe. So there needs to be ethical justification, and then when you conduct the trial itself, you have to make sure that the principles of ethics, making sure that benefit exceeds the risk, that people are closely monitored, that when you come into a trial, proper informed consent has been taken, that you are doing a study that will benefit the generalizable population. All of this needs to be taken into account. So exploitation is avoided by making sure that the study is justified and conducted according to the principles of ethics. Now I'd like to come to the last 2 years and what was possible in other parts of the world and what might be possible in India. Everybody knows, in medicine at least, knows the recovery study. The recovery study, this morning's figures are that there are 48,000 participants in the clinical trial in 200 active sites. What did the UK do? They took their entire NHS and converted it into a laboratory. So every patient that came for treatment had the opportunity to participate in the clinical trial. What did this result in? An ability to harness the clinical services that we offer to actually conduct experiments, right? What did we learn from recovery? Well, recovery looked at aspirin, at azithromycin, at baricitinib, at colchicine, at convalescent plasma, dexamethasone, hydroxychloroquine, lopinavir, ritonavir, Regeneron's monoclonal antibodies, and tocilizumab. Has there ever been a clinical trial that has looked at so many different possible treatments and actually come up with answers before? Clear answers. 48,000 participants contributing to the idea that we have robust data now showing us first that dexamethasone worked, then showing us things that affect the IL-6 pathway worked, right? And then the monoclonal antibodies worked, but they worked only in people who had not been vaccinated or not exposed to infection previously. One study giving us these many answers. And the UK is a small country. Its population is less than the size of Tamil Nadu. Can you imagine if we started to do this kind of experimentation in India, the kinds of answers that we could come up with for problems that face us as well as influence global practice? Instead, we have situations where we develop products and then there are controversies about how those products are developed. We had vaccines that were evaluated in India and the vaccines came with controversies. Why? Because we don't monitor enough. Was it true that this was associated with Covaxin or not associated with Covaxin? We don't know. The company says it wasn't. The ethicists that went there say that there wasn't proper informed consent, that the conduct of the trial was inappropriate, and there isn't a final word. The product is something that is licensed, then WHO comes up and says it doesn't have good manufacturing practice, so therefore we are not accepting this product anymore. So in India, somehow, because we don't focus so much on high quality in the clinical research that we do, we wind up with products that only we use. This is true for a number of things. It's true for drugs. It's also true for many of the newer vaccines that have come into India. So since I work on vaccines, I've for a long time been focused on how we hasten vaccine research and development. Usually it takes between 10 and 15 years to make a vaccine. And for SARS-CoV-2, frankly, we got very, very lucky. Even when we started, we didn't think we would have a vaccine in a year. But ultimately, we got vaccines in 10 months. And every vaccine, every platform of vaccine that we have tried seems to have worked. But that is really not the situation for most vaccines. And there are many things that contribute to the delay. I told you that animal models don't work very well, that we don't always have a correlate of protection, how you choose which ones, if you have many vaccine candidates, how do you choose which one to take forward? One of the reasons that SARS-CoV-2 vaccines worked well was because the US threw $16 billion ultimately on the development of vaccines, right? We never have $16 billion to throw at any other vaccine targets. So we really have to choose what we are going to move forward with. So what I'd like to discuss over the next couple of minutes with you is a vaccine that was made in India and then ultimately wound up not being used by the world until it was evaluated outside. Now this is the VI tetanus toxoid conjugate vaccine, first conjugate vaccine licensed internationally. Biomed, the company, had made one vaccine, but they are a small company. They didn't go into large-scale production. This vaccine, called TIPBAR TCV, was made by Bharat Biotech. It was licensed by our regulator based on what was called phase 3 studies, but those studies were really extended immunogenicity. So you knew that the vaccine was safe, you knew that the vaccine induced an immune response, but you didn't know if the vaccine actually protected you from typhoid or not. So what did the people who wanted to use this vaccine but didn't have data on whether it was protective or not? They took it to Oxford. And in Oxford, what did they do? They made people drink typhoid bacilli, vaccinated them and made them drink typhoid bacilli and looked to see whether the vaccine was actually protecting against typhoid infection. These are called controlled human infection models or human challenge studies or human infection studies. So this Indian vaccine was evaluated in about 450 people in Oxford. It was shown to work. It protected people from typhoid. The data was submitted to the WHO, and the WHO approved this vaccine for pre-qualification. This vaccine is now in the national programs of Pakistan, Nepal, and in Zimbabwe. So 3 countries in Asia and Africa are using a vaccine that is made in India in their programs. And there have been larger scale effectiveness studies conducted in India and elsewhere that show that what was seen in the challenge study actually worked in real life also. So the question was, the challenge study used 450 people. When you have to do an efficacy trial, you have to try the vaccine in 60,000, 70,000 people. So if you can get the same answer with fewer numbers of people and a shorter time, what happens in a challenge study? You give the challenge dose to induce an infection and you can time the dose. In an efficacy trial, what do? You give the vaccine and you wait for the person to naturally develop the infection. So the numbers are big and the time is long, and therefore the studies become very, very expensive. So when I heard about this, I started thinking about, why should a typhoid vaccine trial be done in Oxford? Why not in India? The UK does not have typhoid as a public health problem. We have it. And yet we don't evaluate vaccines in our own people. We convert UK people into guinea pigs to benefit us. That seems a little bit unethical, if you ask me. So why should these studies be conducted anywhere outside industrialized countries? Do we as Indians need these studies? What's the goal of these studies? Should we be used to experiment on for a drug in the West? I think everybody would say no. But then we are quite comfortable with people in the West being experimented on for drugs that benefit us. But I think there are a lot of things we need to think about. In India, we have this guinea pig mindset. Will people volunteer? Do we have high quality clinical centers where these kinds of studies can be done? For what kinds of diseases should we be doing it for? So these were the kinds of thoughts that we went into trying to figure out, should it be done in India? And what we found was that it's being done all over Asia and Africa. In Thailand, they're doing studies on malaria. In Kenya, they've done malaria. In Uganda, they're doing schistosomiasis. Only in India, we don't seem to do these studies. And the idea is that if you have a small number of people and you follow them up really, really, really carefully, then you will get data that you won't be able to get from humans at any other time. Fixed time of infection, fixed time of investigation. And then you can do a lot more studies. You can look at genomics, you can look at microbiome, metabolome, pharmacokinetics, pharmacodynamics. All of these can be done. When we started to dive into the history of what had been done in India, we actually found that there was one person working on hepatitis E at PGI Chandigarh who had volunteered himself without his supervisor's knowledge, infected himself with HIV. This was a paper that came out in Lancet in 1993. There are, of course, with these kinds of studies, always limitations. Small number of populations means you may have issues with generalizability, you don't get long-term follow-up, etc. But I think one thing that is really important is that the infection experience of someone living in the UK and the US is not the same as the infection experience of someone living in India. So if we want an infectious disease product for ourselves, then if we want it to be suitable for us, then the fastest way is to invest in human experimental medicine in India. Obviously, there are regulatory requirements. The US FDA has an approach. The Europeans have an approach. WHO has published recommendations in 2016 for human experiments to be done for vaccine production. And in India, there was a malaria vaccine that was developed in Delhi, which has also now gone to Oxford to be evaluated in a human challenge study, because we couldn't get the methods established in India, even though in principle it was approved by ICMR. Now we have the new Drugs and Clinical Trials rules, and the draft form of the Drugs, Medical Devices and Cosmetics Act 2022 is posted on the Ministry of Health website for comments at the moment, and hopefully will become an act in the future. There are lots of lacunae in it. None of them actually address human challenge studies, and around the globe there is no direct addressing of human challenge studies. It comes generally under clinical research overall. So what is required to be done in India, that any biomedical health research has to be conducted in accordance with the National Ethical Guidelines for Biomedical and Health Research Involving Human Participants by ICMR. This again doesn't preclude the studies, but so far such studies have not really been done. We need for an ethics committee to approve the study and then for the regulator to approve this. This is an area that has been in discussion for a really long time, and there are some people that completely support the studies and some people that say, absolutely not, these studies should not be done in this country. We also, of course, have to think about monitoring, governance, anything to do with clinical research in India, we need to think about very carefully. But I will leave you with this one last slide, which is a group called One Day Sooner. It's a group that was established in response to the COVID pandemic. And essentially, it's volunteers from all walks of life who have said that if there is a human challenge study for SARS-CoV-2, we want to participate. And the idea of doing this was that that would result in vaccines being available faster. Now there is a human challenge study for SARS-CoV-2, which has been done in the UK. In people, it has established the infectious dose in people who were not exposed previously, and there's another ongoing study in Oxford that's looking at human challenge of people who have been vaccinated before. So when we think about it, you can see here on the map, there are people from India that have volunteered also and have signed up with One Day Sooner to participate in such studies. So I think lots of potential, and I hope that in India we will step up and, like the rest of the world, begin to do these kinds of studies, because I think they have very real potential to be able to advance the development of products that are relevant to our populations. Thank you very much.
Thank you, Professor Kang, for a very, very thought-provoking speech. And she's always known for her different thinking and radical ways she can challenge the practices that we are following in research and medicine. So we had two excellent presentations today, Professor Valian and Dr. Kang. So they can join, and we have 10 more minutes for discussion, so we can have any questions to discuss with them, we can have it. Professor Valian.
Yeah, please give a mic. So please be brief.
Certainly. Only just. Why is,
so kindly introduce yourself and
I
speak.
am Dr. Thomas Titus, cardiology professor. I want to ask you, why is the monkeypox more common in MSM than heterosexuals?
I don't think it's more cumbersome in heterosexuals than in homosexuals. The spread, it was a new clade, and I think it's because it's a new clade. It's, for a starter, it was a subclade of the Western African clade, which is less serious than the central. The case fatality rate under 1%. So also the previous case fatality ratios were from Africa, and it could be the general health in Africa versus in Europe and in US has lots to do with the case fertility rate right now. So the short answer is I don't know.
Thank you, Professor Anders. Dr. Anil B. Nair is Associate Professor of Psychiatry.
My question is to Professor Kang. Two questions, ma'am. Number one, is there any studies or evidence regarding the comparison between the efficacy of vaccination versus natural immunity in COVID? And number two is, a lot of governments have also initiated alternative medical practices for protection, for prevention of COVID, especially among school students. Is there any evidence base for those interventions, Ayush medications? And is there any study comparing that efficacy with vaccines? Thank you.
Both lovely questions. Thank you. So the first one on comparing responses to vaccination and infection. I think the first thing we need to remember is that most of the studies that have deeply interrogated the immune response in people who were vaccinated or infected have not come from India. So I can't speak to what the evidence is for India. We are doing some of those studies, but our cellular immunity studies aren't quite done yet, so I won't comment on that. What we do know is that in studies from the places that are closest to us, Qatar, for example, there is enough data to show that hybrid immunity, vaccination and infection combination is a little bit better than more doses of vaccine. So as somebody who's been studying viral infections for a long time, I trust my immune system and everybody's immune system to do a good job when we get infected. So having a combination of infection and vaccination seems to give you the best protection, but that's not to say that that you should not take vaccines if you have been infected. There will come a time when all of us are likely to need booster doses, and at the appropriate time, we should be thinking about taking those boosters instead of waiting for still more exposures to SARS-CoV-2. The second one about Ayush, this is always a problem in that the quality of Ayush studies, there are publications, scientific publications on Ayush trials that have been done, but those trials don't always have clearly defined outcome measures. And if you don't have a spelt out outcome at the time that you started the trial, it becomes quite subjective. So even though there are a few publications that for a few products saying that these products worked, they're really not high quality papers.
Good morning. Good morning. I am Dr. John Panika, basically ENT surgeon. Just I want to know how effective, what I understand is all the vaccines are against the alpha variety. And how much effective it is against Omicron to all the faculty. And what we are told is there is a lot of antigenicity difference between this alpha and Omicron.
So if you do antigenic mapping, antigenic cartography, basically beta and Omicron are the ones that are furthest from the ancestral strain of the virus. And therefore, with beta and with Omicron, you seem to see less protection with vaccines that are based on the ancestral strains of the virus. But that less protection relates largely to infection. Overall, it looks like protection against hospitalization, protection against death is maintained even when there is an antigenic distance of the virus. Beta, in fact, seemed to have the most severe outcomes with least protection against vaccine, and Omicron is really pretty good. Doesn't protect against infection, but pretty good protection against severe disease, hospitalizations, and deaths.
Actually, I am also a general practitioner too. I see a lot of, many patients, some of the patients have told me that immediately after taking, 1 week after taking the vaccine, they developed something similar symptoms of COVID-19. So it's because some of the virus are not killed properly or still active in the virus.
So the vaccines that we are dealing with, all of them at the moment do not replicate. So you don't expect to have replication of the virus. What you're doing is inducing an antibody response that hopefully blocks enough of the virus getting in to be then able to replicate, cause the infection, cause severe disease, cause death. What seems to be happening with all of the newer variants is that the incubation period is coming down. And when you've got antibody-mediated immunity and you're looking at making a secondary antibody response, you actually need time to be able to mount that response if you want to prevent infection. So if you have a high level of antibodies, there is some chance of preventing infection. If the antibodies have come down and need to go up again enough to protect infection, you need for that to happen quickly, and it's not happening quickly enough. So you're not preventing infection.
Madam,
One question,
yeah.
especially to Nora. How can we carry forward this collaboration with the Global Virus Network, especially with the university, with the medical colleges, especially with our institution?
Sure. So for those that don't know, the Global Virus Network was co-founded by Dr. Robert Gallo in 2011. And he co-founded it to mitigate and prevent viral threats to mankind. And it really was an idea that came out of his experience with HIV. And he had learned from that there was a great need to have centers of excellence around the world who covered all classes of virus and were connected so that the scientists were talking to each other, and really science was put forward as a solution, and no politics and government were involved in the sense of dictating how science should be presented and move forward. So we're pleased that the Institute of Advanced Virology is an affiliate of the Global Virus Network through our great friend and colleague, Billy Hall. And so one of the things that we can do is connect again with the Global Virus Network President, Christian Brichot, who is of the Institut Pasteur. He's formerly from there. And connect on training and fellowships and on task force. Dr. Anders Vaughn actually heads our long COVID task force. We have started a task force on monkeypox, and we have other task forces. So we can get you involved in that way. And to join our meetings, we have meetings and conferences, and one of which was long COVID, which Anders could actually, Dr. Vaughn could speak a little bit more. It was very interesting with top experts around the world speaking on long COVID. So certainly we can get you connected to our fellowship programs and other ways as well.
Madam, I want to ask you one question. What do you think would be the mortality in one day sooner
For long
project?
So if we look at human challenge studies that have been done so far, about 70,000 people have participated in human challenge studies for a range of things from malaria to viruses. Nobody has died so far.
If we take a question from Professor Sudhendra Ghosh, he was Joint Director of Medical Education.
Madam, this is being an expert in the vaccinology of our country. This question is different from the current topic because we know in our state the rabies death is going up, and people at the social media and the newsprint is finding fault with the vaccine. So how should we proceed to clear the issue? This is a big public health issue. That is why this question.
So I think everything that I do is around that. I think basically what we want is for people to trust the health system. When you say that something is good for you, it needs to be backed with evidence, and if there are questions that are raised about safety, about efficacy, we need to have solid data, and we need to be very proactive in getting it out there to say that we have data that shows that this works in this way or this is safe. No, what you're thinking of is clinical trials that have had severe morbidity. Not in not in any infectious disease challenge studies. I am aware of 6 serious AEFIs that have occurred in the 70,000 participants. None of them have resulted in mortality or in any long-term consequences.
Thank you, Dr. Kang. We are coming to the end. Just one quick comment on what are your views on the 4th dose? Some of the countries are going in for COVID vaccine, and then many companies are coming up with vaccines with the mutant variants, neo-vaccines. And what do you think will be the future of COVID pandemic? That's a question common to both Professor Anders and Dr. Kang.
So in WHO's latest recommendation on 4th doses are being recommended with a minimum 4-month gap for healthcare workers, for people who have comorbidities. So only the highest priority populations to receive a 4th dose, with the caveat that countries can decide for themselves whether they want to use the 4th dose or not. Many countries have different infection histories. In India, we know that 90% of the population has been exposed to the virus now. So we do have a lot of hybrid immunity in India. So right now, from the Indian government, there is no recommendation for a 4th dose. WHO's newest guideline does say that in this very restricted population, you can consider a 4th dose based on your local epidemiology. The second question about bivalent vaccines or new vaccines based on, right now it's incremental protection if you have a bivalent vaccine. I know that Pfizer and Moderna are putting a lot of data out there saying, you know, our vaccines are going to really protect you against these newest variants. But when you actually look at the data, it's not that much more protection. And given that this is likely to be the 4th dose in most people, and we know 4th dose effect wanes very quickly, I'm quite skeptical about the bivalent vaccines. But what I am interested in, I think companies should work on it, because you need to get your methods to be able to make a new vaccine quickly if it's required. So if a new variant comes that's very distant, that we really need protection for, we should be able to make vaccines quickly. The question I have then is, do we need bivalent, or should we have a switch to the new variant vaccine? So right now, instead of Wuhan plus Omicron, how would we do with an Omicron-only vaccine? And that data we don't have at the moment. And
Future of the pandemic, sir. That's the last statement.
Yeah. Well, about the vaccines, in Sweden, people of my age, more than 60, I think now 55, have been offered, and most of them have been given 4 doses. And everybody above 60 now are recommended to get a 5th dose in September. I don't think that, you know that Britain has now approved the Omicron vaccine. and it's up for FDA to approve it shortly. EMA require phase 3 trials, as far as I understand, and so will take a few months before FDA, EMA, the European Medicines Agency, will approve it. And I think that in Sweden it will be available only after the new year. So, and then again, how effective are the new vaccines? Well, it remains to be seen.
Thank you very much, Professor Anders, Dr. Gagandeep Kang, Dr. Nora, and my co-chair, Dr. Srikumar. We place on record our gratitude and congratulations to Professor John Panikkar, Dr. Mohan Kundumal, the Vice Chancellor, and everyone, all the organizers for bringing on board an excellent, brilliant faculty for this KUHS seminar on virology. Thank you all for the brilliant interactions. Thank you very much. Good day.
Thank you, ma'am. Now we invite the Vice Chancellor, Dr. Mohanan Kundumal, the Principal, Dr. Kala Keshavan, Dr. M.V. Pillai, Dr. M.K.C. Nair, Dr. Rajamohanan, Dr. John Panikkar, and Dr. Vasudevan onto the dais for the awarding function. We request Professor Mohanan Kundumal, the Vice Chancellor, to present a memento of appreciation to the speakers. We invite Mrs. Nora Samaranaike to accept our token of gratitude on behalf of Professor Robert Gallo. We invite Professor Anders Swanley to accept our token of gratitude. And we invite Professor Gagandeep Kang also to accept our token of gratitude. We now invite Dr. Raj Mohanan to present our token of...
Ms. Nora Rebecca is receiving on behalf of Dr. Robert Gallo, Professor Gallo. Thank you.
We invite Dr. Raj Mohanan to present our token of appreciation to the chairpersons, Dr. E. Srikumar and Dr. Indu P.S.
Dr. Dr. Say the announcement that don't announce like this. Now, yeah, please, for chairperson.
We invite Dr. Raj Mohanan to present our token of appreciation to the chairpersons, Dr. E. Srikumar and Dr. Indu P.S. Thank you all. Now we are moving on to the next session, the session on immunology.
As professor and head of the department, of Pathology at Government Medical College, Kozhikode. Dr. Jayaprakash Madhavan, former Superintendent of the RCC and Head GI and Lung Cancer Division. He is a Senior Consultant Oncologist and Coordinator at KIMS Health Center at Trivandrum and is a founder member of the Alumni Association. The stage is yours, sirs.
Good morning to you all. This is a very important session on immunology. And to me, personally, it's also a very poignant occasion because it commemorates my very dear friend, Ramdas Pishardi. And it brings a lot of memories because he was my classmate in the 1972 batch right in this campus and brings a lot of memories. Of course, he will be introduced. He was a professor of nephrology here in Trivandrum Medical College as well as in other medical college, particularly Calicut, and retired as principal of this institution. He was always, when people speak of Ramdas, they speak in superlatives, everything which was true. He was one of the most brilliant students to pass out from this campus, an exemplary physician, not only in nephrology, but also as a generalist and general physician. And above all, a great human being, as many of his patients as well as friends would attest. Our memories, particularly relating to immunology, goes back to our days of combined study, which we used to do. Immunology we used to study with the very first, even before printing, Dr. Ananthanarayanan and Panikkar, the textbook, as and when it was being produced, we got the chapters because Dr. Ananthanarayan's son, Dr. Padmanabhan, was our classmate. So we formed a study circle to study immunology. And things were pretty simple. Actually, it's only serology mostly, precipitation, agglutination, and so on. Lymphocytes, just two types of lymphocytes, B cells and T cells. And T cells you detected by sheep cell rosetting. And nobody knew anything about the molecules, the receptors, the various molecules, the subsets of lymphocytes. Nobody even imagined that this cell that looked very simple looking cell in a peripheral smear could be so complex and with so many different families. So this is what we are going to talk about today. And Ramdas, if he had been here, he would have been very interested because one of his favorite pet projects in his life was the Mrida Sanjeevani project, organ transplant sharing project, of which he was the first convener of the project. And literally the first stages, he was the one who really built it up. And you know that in transplantation, how important immunology is in transplantation. So whether in suppressing the immune system for autoimmune diseases or for cancer, we know that we have exquisite molecular knowledge, genomic and molecular knowledge now, that so that we can really act at various levels in these pathways. And the things have become so sophisticated that we have this immune checkpoint inhibitors and other kinds of treatments have been developed. And even we can make lymphocytes to work for us. The patient's own lymphocytes can be re-engineered and made to use as bio weapons, so to speak of. And today one of the speakers will be speaking about the CAR-T technologies. And incidentally, we have two speakers, both of them alumni of this college, and they will be speaking on cancer immunology primarily, how Dr. Hari Parameswaran will be speaking on immunology of cancer, followed by Cancer Immunotherapy, Chimeric Antigen Receptor Cell T cells by Dr. Shabarina Radhakrishnan. Both of them have done MBBS as well as MD from this institution. So I think we'll go on to Dr. Hari Parameswaran. Professor Hari.
Thank you, sir, for that, for introducing me, and I thank all of you for inviting me here. It's a great honor to be standing here, and also to remember Dr. Pishardi, who I had a good fortune of interacting a little deeply when I was a medical student, but unfortunately not thereafter as I left here. But, and the other thing is that when you stand here, you are taken back all the way to your student days. ഇവിടെ ഞാൻ ആദ്യമായിട്ട് നിന്നത് 1985 ഡിസംബറിലാണ്. അവിടെ അന്ന് ഒരു മനോഹരമായ ആചാരം ഉണ്ടായിരുന്നു, ഫ്രഷേഴ്സ് ഡേ. And I happened to be the hapless class rep who had to inaugurate the freshers day for our batch. People who have gone through the freshers day in 80s and 90s will remember how wonderful it was. Not a great experience, but it was fun. And now many people who are in that milieu are here, and very thankful that we all get a chance to reunite too in this nice academic setting. So my talk is about the immune system, and Shabari, who's speaking next, is also, actually, I recently left my academic position to run a biotech research department. So Shabari and I, we were colleagues in our institution, and Shabari is carrying on the work. And it is great to see people come through, and Shabari's work is much more fundamental, so he'll be going into the depth of CAR-T therapy. And my job is to give you all a framework. There is a lot of, as Sir just said, immunology has moved on a lot from where we studied it in the early days. So I'll just kind of give a big picture overview on how much we understand cancer and the immune system and how we are using these technologies. We are using it. Immunotherapy is quite common. In Kerala also people are using these checkpoint inhibitors and all these things. CAR-T still has not come forward so much. So cancer therapy has moved quite a bit from the old days. From about 3000 BC, for multiple millennia we only had surgery. Then came Marie Curie and radiation, and very quickly in the 50s there came the era of chemotherapy. So those are all DNA damaging technologies. So idea is to damage DNA of the cancer cells, prevent them from growing, but then there will always be a cancer cell that survives, and it's very difficult to cure metastatic cancer with just DNA damaging treatments. So we call it genotoxic therapies. So people like me who are big believers in immunotherapy, we call all those treatments genotoxic chemo, but we still use it even now. Then came targeted therapy, because some cancers are dependent on mutations that make them survive. So if you target that particular mutation, the classic example is Philadelphia chromosome, BCR-ABL, which leads to a BCR-ABL mutation in CML. You can actually block the protein produced by that mutation with a simple tablet, and that led to many other cancers where we have specific mutation targeting tablets. Then comes the era of immunology, where we started with checkpoint inhibitors in the 2010s, and now what I'm going to tell you is that the new era is what we call cellular immunotherapy, where we use living cells to establish long-term immune memory that prevents cancer from coming back. So these are the fundamental principles that we talk about. Immune system recognizes and reacts against cancers. So when you have a cancer, it means that your immune system has somehow failed. I wouldn't call it that way. I would say that the cancer has hacked your immune system and found a way to get past the immune system. The immune system is doing a great job, but this particular cancer managed to survive your immune system. So invasion of host immunity and how we restore host immunity is really the topic of this talk. Now, we know that from history. So this gentleman is called William B. Coley. He was a pediatrician. In those days, there was no pediatricians, there were only doctors in the 1800s in New York. He noticed that people who got erysipelas or Streptococcus pyogenes infection, some of these kids, their tumors went away. So he actually created a heat-inactivated extract of Streptococcus pyogenes, with a couple of other bacteria thrown in and created a toxin called Coley's toxin, and he was injecting it into people like that gentleman there. And some of these people responded. And this was actually picked up by a pharma company, Parker Davis, that from the old days, you remember. And that was in use till the 1960s when the FDA finally said this is not, regular treatment, stop it. But it did work in a small minority of people. And what did Streptococcus pyogenes do? It basically created a milieu where there was inflammation. So we know that inflammatory milieus can sometimes reject cancer or attack and kill off the cancer. But we still didn't know what in that inflammatory milieu was doing it. So there comes the major enforcer of the immune system against cancer, that's the T cell. So we talked about Dr. Gallo, and unfortunately, people, whenever you talk about Dr. Gallo, people point out that he should have gotten the Nobel Prize. This is another gentleman who should have gotten the Nobel Prize, Jacques Miller. He's the guy who discovered T cells in one way. T in T cell stands for thymus. Jacques Miller found out that T cells go to the thymus, get educated. So what does a T cell get educated on? So our T cells are produced in the bone marrow from the hematopoietic stem cell, and then they migrate and they circulate and they get into the thymus. What does the T cell do in the thymus? In the thymus, they get educated on differentiating self versus non-self. So if you have a protein that has been with you from your genome from the beginning, the T cell somehow finds out that you cannot attack cells carrying that protein. If that happened, you would get autoimmunity, or life would be impossible. So that is the fundamental role of the T cell. So these educated T cells circulate in the blood, and we have a mechanism by which T cells can be activated. So typically they're activated with a protein that recognizes as foreign, and that recognition happens using a receptor on the T cell called the TCR, T cell receptor. So up at this point, we have T cells that are circulating that do not attack self, that can recognize non-self and get activated through that TCR. And in that setting, they undergo proliferation. And proliferation is driven by chemicals called cytokines. And the hallmark chemical is IL-2, discovered by none other than Dr. Gallo. So Dr. Gallo's fundamental contribution to immunology is the discovery of IL-2. So, and we can actually now take IL-2, expose T cells in vitro, and make them proliferate. So that is what drives all our adoptive T cell therapies, which Shabari and me and people like us do. Once proliferated, they can eliminate the cancer, but in the natural state, when the cancer becomes successful, the T cell becomes weak, exhausted, and unable to survive. So then the cancer growth happens. If the antigen is completely eliminated, meaning like if you have an infection, for example, you get COVID, your T cells will proliferate, they will kill the COVID-carrying cells, COVID antigen disappears from your body, and the T cells will contract and then become memory T cells. So the memory T cells remain for life. So this cartoon basically gives you the enforcement of T cells against either virally infected cells or cancer cells, etc. When cancer happens, it happens through 3 phases. So when you have the first few cancer cells in your body, we all are getting cancer cells in our body because cells undergo mutation. Cell division causes mutation. There is an elimination. So the main job is to eliminate these mutation-carrying cancer cells, and our T cells are doing it all the time. That is why people who have immune deficiency, children who are born with congenital immune deficiency, get cancers more frequently because of that, because the T cell enforcement of mutant cells is not happening at that level. So elimination is what should be happening. But if 1 or 2 of these mutant cells survive, then you get an equilibrium where the cancer and the immune system are in equilibrium. That is not necessarily bad, but that can then lead to the next place called escape. So why does this equilibrium and escape happen? Because the mutations, once a mutation has been induced in a cancer cell, the progeny undergo further mutation. So it's not just one single mutation. Some of these mutations are called driver mutations because that gives the cancer cell an advantage and drives itself. Some of the mutations are called passenger mutations because they are random mutations. They're like having a wart on your skin versus a mutation that causes hemophilia, for example. So in that level, the driver mutation makes the cancer go forward. The passenger mutation is just there. But T cells can recognize both. So the T cell immune response, this is, in the interest of time, I'll go quickly. Say that the main immune weapon is T cells which attack the mutations, and we call these mutations neoantigens. The mutation produces a protein, and that protein is an antigen that was not present in your body before the cancer, so we call them neoantigens. So our hacking this system backwards to restore immunity means we have to restore immunity against neoantigens. And we have also, on the other side, we have also to make these exhausted T cells fight. So the lower right corner, I have a picture which shows you a naive T cell meets an antigen and gets stimulated, and when it can become a highly polyfunctional T cell that can stay around and kill cancer. That's one fate, and that's what we want. But if there's a chronic cancer sitting in the body or a chronic infection, say tuberculosis, what happens to the T cell then? The T cell keeps on fighting and in the end gives up. It exhausts itself. That picture is where the T cell kind of goes down, is called an exhaustogram. So we have terms for that. There is a term called senescence or aging of the T cell. There is a term called exhausted T cell. We can differentiate these in various ways, but that's not germane to what we're discussing right now. Ultimately, the T cell dies. We call it activation-induced cell death. So cancers, when they survive, that's what happens to the T cell. The T cell's kind of getting blocked from working against the cancer. And we can actually see this in tumor pathology. So if there are pathologists among you, if you do a CD3 stain to look for T cells in a cancer, you can see that upper left picture there is a prolific invasion of T cells, infiltration of T cells. That's a hot tumor with a lot of immune cells in there. And right below that, you can see the T cells are demarcated by a boundary. And that is a immune-excluded tumor, where the tumor is in the blue. The T cells have made a wall there because the tumor has put down fibrin and are preventing T cells from even entering there. So the tumor is actually fighting back against the T cells. And there are variations in between. So our job is to get past that. So this is what I told you in summary so far. Antigen-presenting cells patrol the body, and these T cells pick up threats like cancer, COVID, etc. They then evidence, once they become activated by seeing these new antigens or viral antigens, for example, they kill off those cells. So their job is to hunt for these cells and kill them. There are checkpoints in the cancer that can slow down the T cell activity, and over time, the T cells can be made to exhaust and die. One of these checkpoints is called CTLA-4, for which we have an antibody against now, and that's a way of treating cancer. And the other more common one, which we use right now, is called the PD-1 or PD-L1 antigens, which again, we have monoclonal antibodies that will block it. So that's how this thing works. So here you can see that the tumor cell has put up these resistance against a T cell. These checkpoints or these proteins block the tumor from T cell from acting on this, and you can actually attack that point. You can create a monoclonal antibody that blocks that interaction, and that frees up the T cell to fight the tumor cell. So that's one way of fighting back. Another way of fighting back is to take the tumor cell, create a vaccine outside the body, and there are several challenges to making cancer vaccines, but one of the ways is to put them together with a antigen-presenting cells like a dendritic cell, we call it a fusion vaccine, and give it back. So now the T cell can recognize that tumor cell. Third way is to do what we call adoptive cellular therapy, where you take the T cell itself out of the body, re-energize it, put it back in. So those are fundamentally the 3 or 4 ways in which we do that. Now you might ask, what about things like Herceptin, rituximab? These are monoclonal antibodies that we use in cancer. Those are passive immunotherapies. They're basically antibodies that target an antigen on the surface of the cancer. They don't restore immune memory. They don't actually create a cure, except as part of a chemotherapy regimen, for example. Immune checkpoints were discovered by these two gentlemen, Jim Allison and Tasuku Honjo. This was one of the fundamental discoveries of 2000, of the first part of this millennium. And you can see that why they are fundamental is because they can actually restore permanent immunity against cancer by just getting the T cells to go past this checkpoint. So here you can see that this is a T cell. It's trying to recognize this, but recognize this antigen. There is an antigen being presented here, and this would lead to activation. But by putting up this interaction, it is blocking the T cell from going forward. So T cell fails to get activated. That's what happens if you have CTLA4. If you have PD-1, PD-L1 interaction between the tumor cell and the T cell, that leads the T cell to be exhausted. It's still there, but it's just not able to fight the cancer. So these two proteins, the PD-1 protein on the tumor cell and the CTLA4 protein on the T cell, we now have monoclonal antibodies against, so they will come in between that interaction, and that immune synapse will not happen if that monoclonal antibody blocks that, so then the T cell is ready to attack. So that's the treatment called checkpoint blockade. We use it extensively all over the world. In Kerala too, I know many people who are taking nivolumab or pembrolizumab and getting fantastic results against diseases like lung cancer, which for which the natural history of lung cancer has been altered so dramatically by this. This is just a joke, actually. So when these guys got the Nobel Prize on WhatsApp groups, we had a lot of these things. So somebody managed to say that Ekadashi Vradam, the purpose of fasting and autophagy is what they discovered. But it's not true. This is, fasting has, maybe its own advantages, and maybe you should fast to lose weight, etc. But it doesn't give you any immunity against cancer. So on that round, I think one of these things is that I have seen in the last 5-6 years is a lot of fake news that comes in WhatsApp. Every morning you wake up to 20 messages which promises these cures. One thing we can do as modern medicine doctors is to fight back. I do try to fight back, but it doesn't have to be acrimonious or a really bad fight. But I think it's our duty to fight back. Now, finally, what I do in my research and for my career is doing adoptive T cell therapy. So we told you that T cells get exhausted and senescent and inactive against cancer, so cancer survives. So our technology takes these T cells out of the body, and in many ways, through different mechanisms, we can re-energize and redirect them to engage with the cancer and eliminate it. Ultimately, people who believe in this type of technology think that it can give you living memory against cancer cells because T cells are long-lived and they become memory cells once they have successfully eliminated the antigen, and that memory T cells will restore permanent immunity against cancer, and this particular cancer will not come back. So that's the attraction of having living cell therapy against cancer. So this is called adoptive T cell therapy. And there are 3 great technologies that we use. One is a technology that I'm currently using mostly called TIL cell therapy. So what we do is we collect T cells from inside the tumor. So TIL stands for tumor infiltrating lymphocytes. Take the tumor, get the T cells from inside the tumor, expand them, and put them back into the patient. That's the technology. The technology that Shabarina is going to talk to you next is called CAR T cell therapy, where you take T cells from the blood of the patient. So those T cells are not inside the tumor, they're from the blood, and re-engineer them to recognize tumor. So you take T cells and make them recognize a tumor. In the TIL cell therapy, the job is a little easier because they've already recognized tumor, they're trying to be there, so they're coming from the tumor. So it's a little bit more tedious though. And this therapy was pioneered by this gentleman, Dr. Steve Rosenberg, another major pioneer who has not won the Nobel Prize yet. And I think one of the highlights of my career is that I get to talk to him almost on a weekly basis. So, curing a solid tumor that is metastatic is the holy grail of cancer therapy. It's almost like in alchemy when we talk about a base metal being converted to gold. That was the holy grail for chemists for thousands of years. It drove a lot of innovation because people thought it could be done. In cancer treatment, metastatic cancer that has spread to multiple organs, to cure it is essentially impossible. There is a few exceptions, basically hematological cancers, maybe testicular cancer with chemotherapy, but without the rule is that's not even able to be done. And Dr. Rosenberg's group and TIL treaters, we have managed to do that at least in melanoma and in some other instances like lung cancer too. And finally, to summarize, what I just told you is the basic mechanism of immune system fighting cancer and cancer fighting back, and how we can hack that process. And we have 2 basic technologies, restoring the T cell immunity in an active process using adoptive T cell transfer, or other immunotherapies such as cancer vaccines, oncolytic viruses, we didn't even talk about those, immune agonists such as CTLA4 and these checkpoint inhibitors that are used right now. And there are things like bispecific antibodies. Those are antibodies which can on the one hand bind to a T cell, other hand bind to the cancer, so it makes the immune synapse possible. So these technologies are going to revolutionize the treatment, and we will go to a phase where a permanent cure for many cancers, which can only be established by re-establishing active immunity against the cancer. And also, you don't need to eliminate every last tumor cell. So as Dr. Jayaprakash Madhavan will know, he treats a lot of lung cancer patients. You get these immune activations. You can get an equilibrium where the patient is taking the medicine and is going for 5, 6, 7 years without any problem. Because there may be a few tumor cells there, but the T cells are keeping them in check. You just need to re-energize them from time to time. So the potential to cure metastatic cancer can only come from establishing immunity. And now, I think I'll summarize here. Thanks.
Dr. Hari, for the excellent introduction of the topic. He has covered almost the basics of the immunology. Immunology has become a fourth pillar of cancer treatment. And in basic science, we should include cell biology and immunology as a separate specialty, and should we give excellent training to our undergraduates. We'll go to the next speaker, Dr. Shabarina Radhakrishnan. He is going to talk about a very new therapy, which is very new to India. Tata Memorial has just started the CAR T cell therapy. So we expect RCC also will follow the path and soon start here also. Thank you.
Good morning, everybody. Thank you for the invite. Actually, it's a real honor to be here. Because as Dr. Hari said, the only other time that I stood here was completely non-academic. So today I'm going to talk to you about CAR T cell therapy. I'm going to introduce the topic, give you the rationale, why we need to do this, how we're going to make CAR T cells, and give you small snippets about current CAR T cell trials that made these treatments approved, and why it has blockbuster status in cancer immunotherapy. It's really changed the world of a lot of cancer patients. It's changed the imagination of scientists, doctors, and it's really lived up to the legendary status it has acquired. Before we start off with CAR T cells, I just want to recap or kind of refresh your memory on how T cells and also B cells recognize tumors and antigens. So if you look at the T cell, and if you have a virus infected cell, the T cell recognizes small peptides only in the context of HLA molecules. So so they are not going to recognize any surface proteins as such, but it's only small peptides, and also only in the context of HLA molecules that these T cells will recognize. It is a limitation and also an advantage for T cells, and they're designed in this way. In case of B cells, if you look at it, they make antibodies, and these antibodies can bind to proteins that are on surface. I just showed a bacteria which can on the surface, and so they do not require HLA, so they are not HLA restricted. As Dr. Hari said, the immune system is really robust, but still cancer escapes, and there are different mechanisms of tumor escape. I'm not going to go into that. But one major mechanism is where these T cells cannot recognize the tumor cells. Multiple reasons. One is that they do not have the HLA and HLA on the surface, or they do not recognize any unique peptide on the HLA that the T cell can act on. And in case of B cells, because these tumors do not have any unique antigens, which are tumor specific, we do not have antibodies against them, because by nature that is eliminated when we were very young. So how do we circumvent this problem? brilliant scientists from the Weizmann Institute came up with this idea of why not make antibodies against an antigen which is present on the surface of tumor cells, and why not swap the T cell receptor with the antibody. So that was the origin and the birth of the CAR T cell, as it is called. Initially it was called T-body, and it has come through many generations of iterations of the same. And essentially what is a CAR? If you take the variable heavy and the light chain from this antibody and then combine it with the T cell receptor, that is the CD3 zeta part of the T cell receptor, through a hinge in a transmembrane domain, you get a CAR, which is called chimeric. As the name indicates, it's a chimera, antigen receptor. And the most important part is this single chain variable fragment. It's a name given to the combination of the variable heavy and the light chain, which is linked by a small linker. And so this is what is a CAR. And when you introduce this CAR into a T cell, it becomes a CAR T cell. And this CAR T cell still has a TCR because we have not modified it. In addition to it, it has a CAR that's a receptor, and this can actually recognize a tumor or any antigen on the surface of this tumor cell without an HLA associated with it. So how do you make one? So this is what I do in my research. And it's an interesting process that we have established to make CAR T cells. In the next few slides, I'm going to talk to you how we made a CAR T against this particular antigen called CD229, because our lab was focused on multiple myeloma, and myeloma being an incurable disease at the time when we started this discovery campaign. And CD229 as a CAR is present mostly actually on the lymph. So this is RNA expression on these different tissues. I don't know if it is really visible in the backside, but this is RNA expression on these different tissues. So as you see, CD229 is only expressed on lymphocytes and some bone marrow cells, but it really spares the rest of the organ system. This is very important because if you make a CAR against CD229 and this antigen is on, say for example, the heart, then your patient is going to die with heart failure before he's going to die of cancer. So this is a very toxic treatment if it is not done properly. So attributes of good antigens are: one, it should be present in limited expression, that is, it should not be widely expressed all over the body. Second, it should be present on most of the cancer cells that we want this antigen to, when we want the CAR T cell to act on. And it should be expressed on the surface, because if it is not expressed on the surface, the CAR T is not going to recognize this tumor. If you look at CD229 expression on myeloma cells as we want it to be, it is expressed on almost all cells of the myeloma cells of patients that we looked at, irrespective of whether it is newly diagnosed or relapsed refractory. So we set up to make CAR T cells, and we have developed a CAR T cell development platform that we incorporate high throughput systems, which is in this box, and also low throughput system where we identify specific clones that we want to further narrow and have detailed experiments done on. So it starts with antibody discovery, because we need an antibody to make a CAR T. And then you go through multiple screening process where we want to find the best binders that we want to make CARs from. And we test for cytotoxicity to know how good these CARs are. And then after we have some clones that we think are good, then we can go into have low throughput systems where we specifically look at specificity and also toxicity. So I'm just going to go through this process so that there are two aims. One is to actually show that this actually can be done in a regular lab. It doesn't really require very sophisticated instruments. It can be done anywhere in the world if you really want to do it. The crux of the, so I just want to come back to this previous slide, sorry. So the most important part, as you would recognize, is this first antibody selection. So without the antibody, you won't be able to make a CAR. And there are different mechanisms which out there that you can make antibodies from. Most prevalent is injecting mice with the antigen of interest and making hybridomas, and then getting antibodies from these hybridomas. But another very interesting technology is called antibody phage display library. So this is as the name indicates, it's a library where we genetically modify bacteriophages to express antibodies, human antibodies on their surface. So each phage as is represented here, has a variable heavy chain, so human antibody, a heavy and a light on the surface of the bacteriophage. And the importance is that you have a phenotype genotype synchrony when you have a phage display library. That means whatever is expressed on the surface is coded by by the DNA that we can later isolate. So if we find the binder that can bind to an antigen, we can easily isolate the DNA sequence for this, and we can make antibodies, recombinant antibodies down the line. So the phage library has millions of phages on it. So it has a very, very large number of phages. So and there is random combination of this heavy and the light chain, which is not present in our body. So this is random combination. So it can bind to stuff that normally wouldn't bind from our antibodies. We do selection is called biopanning. What essentially it means is you take an antigen, for example, this is CD29 on the surface of this, on a surface of a plate, incubate them with this phage display library. And from the phage display library, some of them are going to bind to it because they have affinity for it. You wash off the rest, elute them, and then amplify them again. And each time you do this, you're going to enrich phages that are going to bind to our antigen of interest, that is CD29. So from this, we get a phage output, and then using the phage output, we can clone these clones into vectors that you can make, you can secrete these SCFEs from in bacteria. So what essentially this is, we took 296 well plates, that is 192 clones, expressed them as antibodies, and then look for binding against the CD29 using an ELISA like an assay. As you see, most of these clones don't bind, and only few of them actually bind, and of them, some of them are unique. And these unique clones, we moved from this format into a CAR format. So the idea is you need to screen in different formats because there is no guarantee that the antibody is going to bind to a particular antigen in all different formats. So from a SCFE, that is just the variable heavy and the light, soluble protein, now we're going to check for binding using a CAR format. And this we use with flow cytometry. So what we do is you take mammalian cells, transfect them with this CAR vector, and express this CAR on the surface of these mammalian cells, and look for surface expression that is on the y-axis using flow cytometry, and on the x-axis is antigen binding. So as you can see, some of these clones, they are expressed on the surface, but they do not bind antigens. But then a lot of them bind antigen and also are expressed on the surface. So from this, we selected one of them to make CAR T cells. So how does that work? So as you see, there should be a way by which we introduce this genetic sequence that is coding for CAR into your T cell. So you want to have stable integration into your genome so that it can be made constitutively. So for that, we use lentiviral packaging. So as like HIV viruses, they get integrated to your genome. So in the same principle, you have CAR plasmid, you make lentiviruses from these CAR plasmids, make lentiviruses, and then transduce activated T cells. So you activate them with CD3, CD28 beads, activate them, and then you get CAR T cells. It's a 10 to 12 day process where you need to culture these cells. But that's how, there are other ways to do it, but that's how we make CAR T cells in the lab. Then the most important test to know for efficacy is cytotoxicity, whether your cells are actually able to kill cancer cells. So the way we test that is we co-culture the T cells, either with the CAR T cells or T cells that do not have the CAR on the surface. So we call the mock CAR T cells, with these primary myeloma cells, and then we co-culture them overnight in different effector target ratio down here, and look for viability of these myeloma cells by flow cytometry again. As you can see, there is dose-dependent efficacy, different effector target ratio for these CD29 CAR T cells compared to mock CAR T cells. And these T cells get activated and makes interferon gamma, TNF alpha, and IL-2. So I say that these are activated T cells that are working against these tumors. And to validate our findings, we use xenograph models. Xenograph models means that you use immunocompromised mice so that they can take in, or you can engraft a human tumor. And what we do is here for myeloma, we specifically use a plasma cell leukemia cell line U266. You engraft them, and then after you sure they are engrafted, we treat them with CAR T cells after 1 week and look for tumor growth by a luminescence assay over time. So on the right is the imaging studies that are done every week. As you can see, the myelomas, so the mice that were treated with these mock CAR T cells develop tumor and they eventually die. But the mice that were treated with CAR T cells clear the tumor and they survive till the end of experiment. We kept them going for about 6 months. So this shows that this is really efficacious treatment for myeloma, at least in vivo models. This particular construct is in clinical development at this point of time. Hopefully, we'll see clinical trial sometime soon. In the next 3 slides, I'm going to show clinical data, just snippets of it, as to what really transformed CAR T cells in cancer immunotherapy. So the first patient was treated with CAR T cell was a patient with B cell acute lymphoblastic leukemia. And she's still alive. It's almost more than 10 years since the first patient was treated in UPenn. So this is mature data from this multi-center trial phase 2, where 75 patients, pediatric and young adult patients with acute B lymphoblastic leukemia, which is relapsed refractory, not responding to any current treatment, was treated. And so as you see, the median blast percent was 74. That means these patients were teeming with disease. And the response rate is just unimaginable at the time, at this time when this study came out. Usually patients live weeks once you have relapsed refractory, non-responding BALL. And these patients survived, overall survival was 81%, unheard of. And some of them are still alive, and they could detect CAR T cells even 2 to 3 years after treatment. Similar in multiple myeloma, again a large study, 97 patients, again with relapsed refractory disease. Almost all of them responded. So these are patients who have no response, who actually got CAR T cells. They all responded. 97% response, and the plots here, all the people on this graph are the ones that got a stringent complete response. That means that they did not have any evidence of disease at the time. And then some of them had very good partial response, and so very, very few people did not respond, and the median duration of response has not reached yet. B-cell lymphoma, again, the third one that has been FDA approved, again, phenomenal responses. Like most people who treat patients with B-cell lymphomas will appreciate that they don't really survive months once they are relapsed and refractory. These guys have survived for like 18 months with 52% response rate. But there is still work to do, right? Because we only have 54% complete response rate. So this is where Dr. Hari pioneered one study at MCW. So the idea was, okay, so you have now 54% response with CD19 CAR. So what if we add another CAR on top of CD19? So we added a CD20 CAR. And so it has 2 CARs on the surface, CD19 and CD20, targeting diffuse large B-cell lymphoma. And if you look at these PET CT scans before and after treatment, the response is just phenomenal. It's just mind-boggling that patients can actually respond when there's so much of disease. And the other really important thing that I want to highlight is that the point of care CAR T cell production that MCW pioneered under Dr. Hari, which really democratized CAR T cell treatment. It's not restricted to any few centers in the US. Anybody who has a reasonably sized department can actually do that. This is a machine, there's a Clinimax Prodigy that is from Miltenyi Biotech, where it's a closed system. Once you put your cells and your reagents in, you don't have to do anything. You'll have your CAR T cell ready in like 10 days of production. And this is really, we do treat our patients in our hospital. We have our patients come in and we take their cells, make cards and give it back to them. And we see the response. And I think that's something that many people would want to see all over the world. I would like to end with where this field is going. I know it's in its infancy in India, but all over the world it has made quite a lot of progress. I think where we're going to go is with off-the-shelf CAR T cell, because it takes about 10 to 12 days or 2 to 3 weeks to produce, and the whole process takes about a month from the time you're going to get CAR T cells. But the off-the-shelf one, you probably can get it like any other monoclonal antibody. That's probably where it's going to go. And then, armor CAR T cells, where you can make, in addition to CAR, it makes antibodies or cytokines that can augment CAR activity. But I think the most important thing for all over the world is the point of care CAR T cell. I think that and the global collaboration that is required so that this becomes available to more and more people who actually need it. And these are my acknowledgements. Really, I'd like to acknowledge my family and my friends, my mentors, and my funding agencies. And last but not the least, my dear friend and friend of a lot of people here who we lost about 13 years ago. It probably was my first mentor, and probably the reason why I stand in front of you. Thank you very much, and open for questions.
Thank you, Dr. Shabarina. Talk. Yeah, it is because of the paucity of time. We'll have one or two questions. You can ask.
So all the monoclonal antibodies that we talked about are B cell made. So they are made from B cells. Is that your question, or? Yeah, my topic was specifically CAR T cell therapy. So that's why it was, so there is no CAR B cell therapy, if that's what you were asking. No, it's only for T cells, because the effector function is T cell function. The B cell only makes antibodies.
Yes, so the natural role of B cells is to, B cells can recognize antigen that's floating around. So if you have a bacterial toxin, that's a chemical, the B cells make antibodies which then bind to that. To kill a cell, for example, a cancer cell, you need T cells. So B cells really, except for a supportive role, they don't have a real role in eliminating cancer. But these B cells' ultimate fate is to become a plasma cell and make an antibody. Antibodies, it's like T cells recognize bits of protein from inside a cell and then kill that cell. So it can kill COVID infected cells, it can kill TB infected cells, cell mediated and cell to cell killing. B cells don't do that.
Thanks to both speakers for keeping to time.
Can we extrapolate these techniques to antiviral therapy also?
You mean CAR T cell therapy? So there are clinical trials, CAR T cells against HIV at this point of time. So there is extrapolation to viral infections too.
How optimistic you are in the cancer immunology to get defeating the cancer in near future?
Yeah. So I think the data speaks for itself, right? So, like 10 years ago, to have a B-cell ALL patient live 10 years down the line without treatment was unheard of. They would die in weeks. And somebody being alive at 10 years is really phenomenal. It's a cure, right? But we won't be able to cure everybody with one. So we will have different modalities of treatment that are required to actually get to there. But I think there is hope for it.
I think
Thank you.
we have exhausted the time almost. So one more question, one more. Yes, Kashi sir.
Acting on the T cells, can the T cells be down-regulated or modified in a transplantation scenario?
Thank you for that question, sir. Yeah, we can actually, so basically the one way of looking at it is you can introduce genes into T cells to either redirect them and making more potent or also reduce them. So where we do it in kidney transplant specifically is we can actually do, so there is a donor, especially when you have a living donor kidney, you can actually do what we call a reduced intensity bone marrow transplant first, and after about day 7 of that, you can put the kidney into that patient. Then there is no need for immune suppression. So we have done quite a few like that. I have personally done about 5 of those.
I think we can end this session. It's been very, very informative. And you can appreciate at what level immunology has reached today, what minute kind of knowledge that we have today. And particularly what Dr. Hari said was very important. Even at this time, we have one of the most selling products is general immune boosters, What he said, all these WhatsApp messages and all you have about immune boosting. And at a time when we have so much knowledge, we also, side by side, we have this kind of very spurious pseudo medicine also along with us. So it's all of us have to really fight against it also, as he very rightly said. Thank you very much, both of you.
We humbly request the chairpersons to present the certificate of appreciation to Dr. Hari Parameswaran and Dr. Shabarina. We request Dr. M.B. Pillai to present our token of appreciation to the chairpersons. To Professor K.P. Aravindan. To Professor Jayaprakash Madhavan. Thank you all. Now we are moving on to the next session.
The next session is the Professor P. Ravindran Memorial Session, remembering a doyen of respiratory medicine. The chairs of this event are Dr. Aravind R. and Dr. Sudhindra Ghosh. I invite the chairpersons to take the stage. Thank you.
So, a very good morning to all of you. First of all, let me thank Dr. Pranikar and the organizing committee at the chairmanship of MKC Nair for dedicating this session on behalf of our beloved teacher, Professor P. Ravindran. As you know, Professor Ravindran was a doyen of pulmonary medicine in our country. And we have to see that the contributions made by Professor Ravindran in the field of academics as well as research is something that our institute will cherish till its end, because the contributions were so great, not only for the benefit of the patient, but also for the students as well as the faculty. You know, he joined the department of TB medicine when it was a primitive department in Pulanagota. By the time he retired in 1997, it has become one of the most prestigious training center of pulmonary medicine in our country. So such was the contribution, because you know, he's the person who started from DTCD to MD and made the necessary framework for starting pulmonary DM, because our current HOD, Patagoni, is happy because he is going to admit DM in pulmonology students from next academic year, provided our VC give every support for that. Dr. Mohan, we see that pulmonary medicine students are admitted for the DM next academic year from our own department in our institute. You know, the contributions, because he is the person who started the first respiratory, asthma, and applied immunology clinic in our institute. This was the first in the South India. And in that center, he used to care patients with asthma and allergy and used to impart personalized patient care first in the country, you know. And he's the person with the collaboration of the College of Pharmacy. College of Pharmacy, he started the first antigen manufacturing units, which supported thousands of patients suffering from asthma. Then he became the vice principal of this institute. He focused his attention on developing the institute itself. You know, under his leadership, with a tough competition from various medical colleges in our country, we could get into the England-trained clinical epidemiology unit in our institute. You know, he was the director of the first CU in our college. And this is meant for training faculty in research methodology, clinical economics, social science, and biostatistics. We know currently we have so many faculties trained in these areas, and this is Dr. MKC is one good example, Professor Narendran, Dr. Shenai, Dr. Bishar, all are trained under his leadership. You know, these are our pioneers of research in our country, in our institute, and we owe a great deal to Professor Ravindran for helping us. You should also realize the next generation faculty, he did many things because there was a tough competition under the England means International Clinical Epidemiology Units. They want to establish a training center for clinical epidemiology in India. See, they were searching for the different CU at that time. You know, the CUs were established in the All India Institute of Medical Science, Delhi. Similarly, Vellore Medical College, then the Lucknow Medical College, and there was a tough competition for getting this clinical epidemiology training and research center. Because of the leadership and vision of Professor Ravindran, the England accepted Trivandrum Medical College as the first clinical epidemiology training and research center, and we got it. And under that center, we were able to train many of the faculties for MPhil in clinical epidemiology. Currently, this is taken up by the university, they are conducting it. So we owe a great deal for Professor Ravindran for his visionary and helping us to establish that. So when we talk about Professor Ravindran, we should see that the contributions made by Professor Ravindran has a distinct place in the history of development of Trivandrum Medical College. With these few words, I again thank the organizers for dedicating this session on his behalf because he really owes it. And he left us in last year, 3rd April, but leaving behind a great legacy which we have to cherish. Thank you. Now I hand over the mic to my co-chair, Dr. Aravindan, to introduce the speaker as the topic.
Good morning. We will have two talks in this session on COVID-19. Of late, actually, monkeypox has sort of garnered the limelight away from COVID-19. But we should know one thing. This year itself, around 1 million people have died because of COVID-19 across the world. And the indirect effect of COVID-19 is obviously the lingering effects on multiple systems, of which the most important system affected is going to be the lung. And today morning, Gagandeep Kang madam did clearly mention that the recovery trial platform, the multiple investigational modalities were tried out against COVID-19. So majority of the interventions which had a mortality benefit, surprisingly, were the immunomodulator drugs. Previously, only for tuberculosis, we knew that the immunomodulators did have some mortality benefit, especially for tuberculosis meningitis. So it was really surprising to see that for an infectious disease, the drugs with mortality benefit happen to be the steroids, happen to be the tocilizumab happened to be the JAK inhibitors, etc. So these two aspects, that is the immunology of the COVID, as well as the gamut of clinical presentations with, pertaining to the lung, that is the lung syndromes, will be dealt with in this session. And for the first talk, I would like to invite Professor Fatauddin sir, the HOD of Pulmonary Medicine in Medical College. Okay, sir. So he'll be introduced by sir.
I am very happy to introduce the speaker for this session, my colleague, Dr. Fatauddin, who is currently the professor and HOD of Pulmonary Medicine in our institute. You know, when it comes to COVID-19, Fatauddin has got a distinct place in our state. Because, you know, during the first phase, we were not knowing anything about the virus. We are not having any diagnostic test at that point in time. And we are unsure about the therapeutic measures. At that time, Fatauddin bravely took up the leadership as a leader of the Korean COVID warrior team and managed many national as well as international patients in his institute at Kalamassery. And the world recognized, even the BBC reported the successful management of Dr. Fatauddin in that institute. So he is such a person who has got a deep clinical knowledge with reference to diagnosis as well as management of COVID-related problems. And today, he is the current HOD, and he will be telling us his experience with reference to COVID-19 and what is the future that we have to expect with reference to this pandemic. Dr. Fatauddin, please.
A very good morning, distinguished delegates, my senior teachers, professors, my colleagues, and my chairs, Professor Ghosh and Professor Aravind. Thank you, sir, for your kind words. I am greatly indebted and in fact honored by the organizing team to allow me to present this important Professor Ravindran oration. And I take this opportunity to thank the VC, Kuhas, Dr. Mohan sir, MKC Nair sir, former VC, and the convener, Dr. Vasudevan Potti, Dr. Vishwanathan, Kavita, and the entire team who worked hard for the last so many months to make this event happen. So, my tribute to my professor, Dr. Ravindran sir, a great teacher, researcher, and clinician, and founder of INCLAN, MCH Trivandrum. And you heard the legacy that he left behind from our chairperson, Professor Ghosh. Now, you know that we have been hit by an unprecedented pandemic, a fatal one. A lot of water has been flown under the bridge. It has never come to a grinding halt. As Dr. Aravind was saying, the death continues to occur. But there is a lackluster attitude, and we think that we have conquered this disease and we take it as very, very casual. Frankly speaking, a hell lot of research has gone in the last 2 years. Still, we fail to understand the exact long-term effect of this virus. We are yet to see what is going on. Nobody knows. A lot of papers have come. Since a lot of developed nations have been damaged by this disease, quick responses and vaccination has come. Otherwise, it wouldn't have come. So that is a good thing. There's a brighter side of it. But did the vaccination actually help us from eliminating this disease? No. If you look at this hall, including myself, we are not wearing a mask. We take it for granted that COVID has now become a very mild disease. So my talk at the end of this lecture would be on what happens if you get repeated round of reinfection. First, I will just concentrate on the lung syndromes, which is my specialty, and day in and out I am seeing a lot of patients even now. What I found was that this disease has now become orphan in the sense that the post-COVID issues, many have it. They are not probably presenting to the clinicians or doctors, and they are suffering it silently. Or they know that this is due to COVID, we are unable to help them. Now, quickly going through the very basics, if you look at the last 2 years, the first COVID X-ray when I saw, I was surprised. And it was coming only at the periphery. I did not know why it happens, only why it is gravitating towards both the subpleural peripheral patches as consolidation or ground glassing or whatever you call it. And this is the classic pneumonic presentations that we have seen in hundreds of patients in the first wave and the second wave. And now we don't know whether it will come back again with more predilection towards lung. Now again, with treatment, the lesions will come down, or many patients at presentation will have an X-ray like this. Now, what are the characteristics of patients who had COVID with lung infiltrates in terms of its long-term lung changes and the performance of the patient? So what are the people who are at risk of developing this persistent inflammatory lung changes? I wouldn't specifically use the word interstitial lung because it is not a ILD-like pattern. It was a misnomer. Initial literature said it can produce interstitial lung disease, but that is entirely different. This is a post-viral, post-infective inflammatory lung change. And who are the ones who are likely to get it? Predominantly male patients, obese, patients with diabetes, asthma. And the higher the inflammatory response, initially if the patient has got a high, what you call the COVID inflammometry, those patients are the ones who are more likely to have residual lung problems. Higher levels of CRP and interleukin-6 during acute illness might lead to the formation of fibrosis and other lung issues. So even now you must be seeing patients coming and telling you, I had COVID last year, or during the first wave, or during the second wave, or I had COVID 3 weeks back, or 4 weeks back. So when to consider the post-COVID change as significant? Most of the time, it will take nearly 4 to 6 weeks for the patient to settle in terms of clinical as well as its radiological presentations. If the symptoms as well as the radiological lesion persist even after 6 weeks since discharge, then we have to consider this as significant. Or another scenario, which we have seen during the second wave, the patient continues to progress radiologically and clinically despite all the interventions with continuous NIV support and remain oxygen dependent for a long period of time, beyond 4 weeks in the hospital in the absence of any pre-existing parenchymal lung disease, then this patient is also should come under the umbrella of post-COVID lung. Now, what are the, do all the patients who develop a COVID pneumonia will have all these problems? Not all. There are some predictors of post-COVID lung changes. One is advanced age, people above 60 years, severe COVID pneumonia, who are recovered, those who had gone to ventilators, NIVs, those presented with ARDS, and those who developed the classical cytokine storm and survived by treatment with tocilizumab, steroids, and ventilatory support and oxygen and anticoagulation. They are the ones who are likely to have more symptoms. And prolonged ICU or hospital stay also is a risk factor following COVID, and also ventilator-induced lung injury can also produce a persistent, long-lasting effect on the lung. And of course, alcoholism found to be a very high risk factor for persistent hypoxemic respiratory failure post-COVID. And this is also one of the causes of high mortality. Diabetes, diabetic ketoacidosis, initial phase, most of my diabetic ketoacidotic patients died. Alcoholics died, despite intervention. So how to evaluate the patient when you sit in your OP? Timeline since onset of infection is important. As I have told you, 6 weeks after discharge, it becomes more significant. Usually this patient should be seen 6 weeks after discharge. And they usually present with exertional breathlessness, which is non-quantifiable. If you put them into various tests, you run on all the tests, everything is negative. X-ray is normal, ECG is normal, echo is normal. But the patient complains of exertional breathlessness. I'll come to it a little later. And they have oxygen dependence and fatigue. And The only thing is make sure that these patients are not suffering from any pre-existing lung disease like a bronchiectasis, tuberculosis, interstitial lung disease, or other congenital abnormalities. And assess the severity of the COVID illness during the acute phase and then go back to the current presentations. So you can just review the radiology images. Probably you can have a fresh X-ray to see. Then you can also repeat the inflammatory markers like CRP, CBC, D dimer, and an X-ray chest PA view, and resting SpO2 and heart rate. Then you can also subject the patient for a 6 minutes walk test, simple test which you can do bedside or in your OP, and a pulmonary function test if permissible. How often should one repeat the HRCT chest in the follow-up clinic? This slide I have put basically because post-COVID you have seen many patients coming with unnecessary CT chest, which is not indicated at all. That is why I have put this slide. Most patients might have taken HRCT chest for acute severe COVID illness, which is probably justified for the clinician to see how the patient responds to treatment. Most of those patients are in the ICU. And need to repeat CT in the post-acute COVID setting only if there is any acute worsening in the current X-ray or the chest radiology or significant worsening of respiratory failure, whether you want to see what is going on or is there any new other diseases have actually overlapped. If the patient do not have a baseline CT and the X-ray chest currently showing worsening, then you are justified in taking a CT chest. A repeat CT test is indicated only to assess the response to treatment in a small percentage of patients who continue to deteriorate. So what are the most common CT findings in post-acute COVID lung? Radiologists are sitting in front of me, VC, and more than 50% of previously hospitalized survivors of SARS-CoV-2 infection will have some abnormalities in the CT, which is expected, and it will go with time. And if it remains even after 6 weeks since the onset of infection and more prominent CT changes in those with severe acute infection, then only you need to intervene. The most common CT abnormalities are ground glass opacities in the subpleural location, subpleural bands, interstitial reticulations, fibrotic changes, which those are all basically specialist jargons. Now I will just discuss a couple of real-life case scenarios which I have dealt with and the outcome. Now, I have a 53-year-old bus driver with no non-respiratory illness, non-smoker, unvaccinated for COVID-19, had SARS-CoV-2 infection in July 2021 with fever, breathlessness, cough, and fatigue. On 4th day of symptom, he was admitted in a private hospital. Initially was on oxygen and later was on NIV and was in the hospital for 5 weeks and discharged. But again, he was hospitalized after 2 days since the discharge and was in the hospital for 3 more weeks on oxygen and was prescribed some inhalers because of his relentless breathlessness. But he continued to have breathlessness and cough and came to our hospital with continued breathlessness and cough nearly 3 months after the onset of infection. This is the classical scenario where the patient is coming back to you again and again for breathlessness, most of them exertional breathlessness. So this is the X-ray. Initial X-rays were not available. In our hospital, I have taken this X-ray which shows only some marginal lateral infiltrates you can see on either side of the X-ray. But then the symptoms are disproportionate. And this is the X-ray taken 3 months after COVID. Most of the X-ray lesions appear, normal. You probably can just pass it as normal, but the patient continued to have symptoms, but the lesions have actually disappeared. This is the CT which was taken 3 months after COVID, minimal ground glassing, few reticulations only. The classical pictures are not there. Very few ground glassing and one single gaze, you probably say that this CT is apparently normal. But what is his problem? The problem is he continued to have breathlessness. X-ray taken after that, almost normal. This is the X-ray. The symptoms persist, but is coming down. Treated with inhaled steroids and graded exercise, no features of fibrosis on the CT or X-ray. PFT shows a reversible small airway disease. So the learning point is the reason for his continued breathlessness on exertion was COVID can induce an obstructive lung disease, which can only be visible on the pulmonary function testing. So you prescribe a fellow with bronchodilators, inhaled steroids, and graded exercise and reassure him. That is the only thing that we can do. And remember, this guy was not a smoker. So this can induce, per se, small airway obstruction. Now, another lady, a 42-year-old housemaid who never had asthma or allergic rhinitis, had COVID 2 times at an interval of 40 months, repeated round of infections. Following which, she developed exertional breathlessness, rhinitis and cough, and thinks that she became asthmatic after COVID. She never was an asthmatic before. She never had asthma history, no family history of asthma as well. She had 2 emergency room visits in the last 3 months for breathlessness and wheeze. She feels better after inhaled steroids, but has breakthrough dyspnea in between. Her D-dimer level and PFT are normal. This is the X-ray chest. Normal D-dimer. Beyond 9 months, she continues to have wheeze and cough and breathlessness. So the point is, this can produce asthma. Post-COVID, first time somebody can develop asthma. This is because it causes non-specific inflammatory changes and bronchial hyperreactivity, which usually respond to inhaled steroids, but when you stop it, again the patient can have it. So if you have a post-COVID exertional breathlessness with no radiological abnormality and presence of desaturation, what is your diagnosis? Patient has breathlessness, X-ray is normal, but patient has desaturation. D-dimer should be checked, we all know. If it is high, CTPA should be considered to rule out pulmonary embolism. Hypercoagulable state may persist for a variable period of time up to 3 months after SARS-CoV-2 infection. Venous thromboembolism can occur during the recovery period after discharge from the hospital. Any patient with unexplained dyspnea with normal chest imaging post-acute COVID, you should rule out pulmonary embolism. So that is the learning point. Many a time, patients do not have any history of hospitalization. They just remain COVID positive, but after 4 weeks, 6 weeks, they either develop pulmonary embolism or they develop some regional thromboembolisms, either in the axillary artery or femoral artery or veins, or they may come to you with an acute coronary syndrome. Now, COPD, case scenario, post-COVID COPD worsening. This is the last slide that I'm going to show you. A 80-year-old gentleman, smoker, diabetic, and CAD patient. He was treated at multiple hospitals. CT taken last month had shown significant improvement in lung lesions, but his perceived COPD status worsened. With his breathlessness worsening, with his MMRC scale progressed from grade 1 to 3 or functional class from 1 to 3, and he's on LTOT, long-term oxygen supplement. So this is a CT. CT shows some amount of emphysematous changes, not much radiological changes consistent with COVID, but he continued to have breathlessness and hospitalization. So post-COVID, COPD worsening is a major issue, and most of the time it is difficult to control. Now coming to how common is this post-COVID ILD. This is the most reported. So many antifibrotic agents have been put in the Indian market. So many physicians and doctors have used it even before 6 weeks, thinking that it is a COVID-induced pulmonary fibrosis. So the idea of this talk is to just convey a message that there is nothing called a post-COVID interstitial lung disease or fibrosis, and they do not respond to any antifibrotic agents, and there is no place for any antifibrotic agent. So what is the normal, natural history of COVID? Most cases improve. Most of the cases that I have shown you, initial CTs were abnormal, but with time they improved. Even after the radiological improvement, they continue to have exertional breathlessness. Most cases improve. Very few cases remain static, and very rarely progressive fibrosis occurs. So the term post-COVID should be precise with significant radiological findings, which has to be diagnosed and reported by a radiologist, with traction bronchiectasis, bronchiectasis, and honeycombing. Now, this is the classical CT of a 42-year-old female in TRIVANDRUM Medical College in October 2021. She came and she was in the ICU. She had gone into cytokine storm, treated well, This is a very, very frightening CT. This is after almost 6 months. The improvement has remarkable. And this is the X-ray in May 2022. So the message of this CT scan is that most of the time the lung lesions would disappear. So take home message, I'll tell you, almost all cases will improve with time. Now, a few words about a repeated round of reinfections. Many of my delegates sitting here must have had COVID for more than one time. Now, this is the health advisory coming from Canada. What they say that each COVID infection put you at new health risk. People who get reinfected with SARS-CoV-2 have more health risk with each round of reinfection. So that is why I'm saying it is not benign. It is not good to have a second round or third round of infections. Each time your immunity, your what you call the acquired cell-mediated immunity will come down. Your T-cell mediated immunity protection will come down. The immunity wall will be evaded, and the patrolling of T-cells will be diminished. Remember this. He's a US Health Secretary. He had COVID last month 2 times in a span of 28 days. 2 times. So there are many who gets COVID repeatedly. And there are multitude of long hauler syndromes, anxiety, chest pain, memory issues. Nobody is addressing all this problem because you don't have any objective evidence. But they are the silent sufferers. That's why I said this is an orphan disease. You have new onset diseases like diabetes mellitus, new onset, unmasking of asthma and allergic rhinitis I have shown you in the previous slides with case scenarios, worsening of pre-existing mild asthma, sleep apnea and fibromyalgias. Sleep disturbance is very common in up to 40% of cases. I had very bad sleep disturbances for running for 8 weeks. Brain fog, memory issues, depression and anxiety. So how do you treat all this? Exertional breathlessness and fatigue, brain fogging, not much treatment is available. But there are some interventions now coming in the literature, like you can actually treat these patients with molecules like inspiritol, pyridostigmine, and oxalacetate, which are the substrate energy supplying to the mitochondria. So now people say that your exertional breathlessness and fatigue is due to the poor energy supply to the mitochondria. So probably we'll have some impressive molecules in future to treat these symptoms. Why this topic is still relevant is because many patients are still getting repeated rounds of reinfection. And those who get repeated round of reinfection, what will happen to their memory issue? What will happen to their memory level? What will happen to their performance status and their fatigue needs to be seen. Thank you so much for your patient hearing.
Thank you, Fatadin sir. Please join us. For brilliantly taking us through the multiple manifestations of the post-COVID lung syndromes. Now the floor is open for discussions. We can have questions now.
Chairpersons, kindly note, we have time only for 2 questions.
Definitely. We'll take 2 questions. Sir, please.
The patient has no dyspnea, but the saturation is very low. Oxygen saturation is very low, but the patient has no dyspnea or no symptom.
Unless the patient has any other pre-existing lung disease, we cannot say. And the one situation where the patient do not have much dyspnea, where the saturation is low, but if you look at the ABG, that is normal, is some dye poisoning, a textile dye poisoning, and otherwise I have not seen anybody who is having no symptoms but desaturation. It occurs only in patients with congenital heart diseases, cardiac failures and things like that, to explain that. But they will usually have symptoms. Or a host of patients who are what you call hypoxemia adapted patients, like COPD patients. Their perception of dyspnea is different, and they have been exposed to this high level of carbon dioxide and low level of oxygen. They appear not much dyspneic at rest. But if they put them into exertion, they will definitely have symptoms and worsening of that desaturation. The only thing is desaturation occurs without much symptoms in a post-COVID setting. That is what I have shown on slide, wherein you have to certainly rule out a pulmonary embolism. Pulmonary embolism, when I say it is hemodynamically stable, subacute pulmonary embolism where the major pulmonary artery are normal. If you do a CTPA, till the last branches, it will be normal. Then why this guy is dyspneic? It is basically because there are recent papers coming in saying that it is due to umpteen number of amyloid fibrin clots. It's called amyloid fibrin clots in the peripheral, hair-thin like pulmonary vasculature, which may not be, visible on the classical contrast-enhanced CT pulmonary angiogram. That is why usually we treat them with 4 to 6 weeks of newer anticoagulants like apixaban or rivaroxaban. No, he was not. Happy hypoxia was a term which is originated in the Indian subcontinent, which is definitely not true. That is why during the second phase of COVID, when large number of patients are affected in Kerala, many died. Many of them are put on quarantine. They have been asked to stay inside by monitoring with a pulse oximeter. See, please remember, by the time a patient has a significant desaturation below 90, his lung has been affected extensively. So they are the not one who should be kept on quarantine with a self-monitoring of pulse oximetry. It was not true. So by the time they reach, it is too late. So the happy hypoxia is a misnomer which has actually caused many doctors to keep the patient either in their clinics or in the hospital and did not push them into the COVID care centers for further monitoring, evaluation, and higher interventions. That is not true. And you know that patient who has got extensive bilateral lung lesions on NIV, talking over the phone, suddenly dies. Suddenly they are dying. They may be alert. The same thing happens in H1N1 pneumonia, where the patient is alert, talking till the last minute. That is the agony of this disease. So hypoxia, when it occurs, it is always significant. And early intervention is more important than late intervention. Late intervention may not be effective at all. So early intervention in the sense that when we have learned a lot from this virus. Initially, we did not know when to intubate. And the patient is talking like, as you said. The bystanders are asking, my patient is talking to me over the phone, why do you want to intubate? So you just, take their side. You also want to play safe. You put them on NIV. They pull on with the NIV for 3 days, 4 days, 5 days. Suddenly, you decide that the patient is significantly hypoxemic and you put the patient on ventilator and he pops off. So late interventions, late intubations are another reason why we initially had a lot of deaths. Then we learned that earlier the better. If the patient is fine with all other parameters, there is no acute elevation, the patient is not in cytokine storm, then you may wait. Otherwise, you don't not only look at the hypoxemic status, you take the patient's entire status, whether his patient is diabetic, obese, any other comorbidities, post-angioplasty status, coronary artery disease. These patients, they die very fast, renal disease patients. So early intervention is the key and not late intervention. And there is nothing called happy hypoxia, which is an Indian subcontinent terminology. Not true.
Sir, what is the biological explanation of decreasing immunity with repeated infection with T cell? So we expect more and more immunity to develop, but why is it decreasing?
What they say is that each infection, each round of infection will put at least one of your organ more weak. More weak. Maybe at the heart level, or maybe at the kidney level, or maybe at the brain level, or maybe at the lung level. So the first 1 or 2 infections will actually shake your primary organs of involvement. And the second infection make that organ more susceptible to complications. It may not be the classical pneumonia. It may be some other issues.
Now, is it because of increased inflammation and increased response, or is it decreased response due to decreased immunity?
No. So ideally, when your T cell, as Dr. Hari was very elegantly pointed out, that the T cell mediated immunity is the is the cornerstone of protection against COVID, not humoral response and antibody. So there is no point in looking at antibody level after taking two COVID vaccine, or I took the third one, let me see, my antibody level is better than my friend. No, absolutely no use. So it is your cell-mediated immunity, which is the immunity wall that protects. It is the cell-mediated immunity that is getting weakened by repeated viral infections. The exact etiology is not known. A lot remains to be seen with COVID immunology. I think we should have a talk on COVID immunology by...
Sure. I think we will take up during that session. Thank you very much, sir, for the excellent discussion. Thank you.
The audience should remember that there are a lot of millions of people are infected by COVID-19. The percentage of people who may have that post-COVID syndrome, you see, that is very important. Is it 5%? Is it 10%? Is it 20%? The literature says between 10 and 20%. So you know the bulk of people who may be suffering from post-COVID sequelae in our country as well as globally. That is why this session. Thank you. Yeah, we can take up the rest of the questions after the...
Delegates, kindly note, we will be resuming this session with the second
It
speaker
will,
after...
across all strains. Thank you.
Thank you, Dr. Panikkar and the organizing committee. We as chairperson, thank you once again for giving us an opportunity, and also thank Dr. Fathahuddin for the excellent presentation of the topic. Thank you.
We request the chairpersons to hand over the certificate of appreciation to the speaker, Dr. Fathahuddin. We also request Dr. M.K.C. Nair to hand over the certificates to the chairpersons, Dr. Sudhindra Ghosh and Dr. Arvindara. Delegates, kindly note, we will be resuming this session with the second speaker, Dr. Nijil Haroon, after Professor P.P. Joseph oration. Thank you. Now we have a memorial session of Professor Dr. P.P. Joseph. This session will be chaired by Professor Shaji Prabhakaran and Dr. Thomas Ibe. The oration award has been conferred to Dr. Rajashekaran Nair, inviting the Vice Chancellor, Dr. Mohan Kundumal, Dr. M.K.C. Nair, and Dr. Vasudevan onto the dais. We humbly request Dr. Mohan, Vice Chancellor, to kindly adorn the medallion to the speaker, Dr. Rajashekaran. We humbly request Dr. M.K.C. Nair, sir, to present the scroll to the speaker. We are moving on to the session, inviting the chairperson, Dr. Thomas Ibe, and the speaker to continue. To you, sir. Delegates, kindly note, the car registered number KL01BJ4000 is creating a traffic jam. If the owner is here, please remove this car from the place it is parked at. Kindly note, the number is KL01BJ4000.
Very good. afternoon, everybody. It is my great pleasure to welcome my guru, Rajan sir, who was my professor and director of neurology at Government Medical College, Thiruvananthapuram. We have already heard about him. He did his DM from AIMS, New Delhi, and he is the person who initiated the DM course at Government Medical College, Thiruvananthapuram. He is a prolific writer in Malayalam, and we have always cherished his classes at Government Medical College, Thiruvananthapuram. He is going to talk about creativity, which all of us have. All of us have creativity. It is not confined to only artists or anything. Everybody has creativity to a lesser or a larger extent. And it is interesting to note that our creativity is increased by taking holidays. Some of the people who have brain damage develop more creativity, and intelligence is not related to, it's a good thing that intelligence is not related to creativity. An important point, but if you are intelligent, you can work on it, that is all. And I think it all depends on your brain network. The default network where you don't think of anything, just that is called the default network. And it is the interaction of default network with the executive network and the salience network in the brain that is really going to improve your creativity. And we will hear from Rajan Shain sir about creativity. Over to you, sir. Do you want to stay there?
Well, I'm indeed happy that I am giving the Professor P.P. Joseph oration. Had he been in Trivandrum Medical College when we were studying, he would have been my teacher for MBBS as well as for MD medicine. But our camaraderie started in 1982 when I returned after my sojourn abroad. From 1982 to 2011, till he passed away, we were close friends. He was my, next slide please. He was my, next slide, go to the next slide please. Can you move it? Oh. Yeah, okay. Yeah, fine. You can do it. Now, even after our retirement, we worked in the same hospital, Cosmo. He was my senior colleague, exceedingly good clinician, a great chap, and then indeed I'm very, very happy that I could do it. This is one of the last pictures where we went together for a public function that we were given an award by the hospital where we were working, the Life Achievement Award, and I'm indeed happy that I could collect this picture. Next slide, please. I think without wasting time, I'll go to my topic which is given to me, the neurology of creativity. Next slide, please. Now, actually, you heard very high-flown medicine in the last few hours. From the high-flown stuff, let me bring you down to the very common place. The common place is the most uncommon thing. Brain. It's a lovely poem written by Emily Dickinson. The brain is wider than the sky. For put them side by side, one the other will contain with ease, and you besides. The brain is deeper than the sea. For hold them blue to blue, the one the other will absorb as sponges buckets do. The brain is just the weight of God for half them, pound for pound, and they will differ if they do at all, as syllable to sound. Next slide, please. Now, I'll come back to this. It's surprising that the amount of information which most of the medical graduates have about medicine, about brain, is rather not very adequate. It's about 1,350 gram weight only, but it contains 100 billion neurons. 3 times or 4 times of that glial cells. Thing which most of us even do not know is that 80% of these neurons are not in the cerebrum, but in the cerebellum. If you take the axons and the dendrites together, the total length of that would be about 8.5 kilometers, 8.5 lakhs kilometers. The word synapse is something funny. Initially, when it was discovered, the man who did it did not have a correct word. He called it as syndom. Later on, it is moved on to the word synapse. The synapse is hardly 20 to 40 nanometer in size. You have no idea the number and all when you say these abstract figures. I'll give you an example. 100 billion neurons. We have no idea how much large it would be. The world population as of now is only 7 billion. If you take 1 million seconds, that would be 11.5 days. If you take 1 billion seconds, that would be 32.5 years. That is the largeness of it. Now coming to the synapse per se. The synapse is 20 to 40 nanometer. Old man like me, my hair is comparatively thin, and even that is about 80,000 nanometer. If you take a 80 GSM paper, the thickness of that would be about 1 lakh nanometer. That is the size of it. It is so complex as structure. It is unbelievably complex. Next, now I go on to the word creativity. The word which is used in Malayalam is Sargatmakata, but unfortunately that word, that translation is not really adequate. The term is usually reserved for artists, writers, etc., but not at all so. It is defined as the production of something novel and useful. Believe me, this applies much more for science rather than for art, even though in art it becomes so much of, what should I say, illustrative, productive. Next slide, please. Now I'll go to this man, the man who did so much of work. A thing which is not really known is that a fairly large amount of work of Einstein is really that of his first wife, Mrs. Myeloma Marek. And as luck would have it, in those days, women did not have any place in science, and hence she was taken back to the sidelight, and her name is not really known. It is not the Einstein which is important here, but Einstein's brain. When Einstein died, a pathologist told his brain, run away. He was asked by the office, by the hospital, return that brain, where he just left with his toe. He lost by that his job, his medical degree, his everything. Tom Harvey. And finally, sick of everything, he cut off the brain in so much, 240 sections or so, and didn't find anything seriously abnormal. He sent to every major center in the US to find out whether there is anything significantly normal. There are people who said that gland cells are too many, some particular region is a little more bulky, etc. But that is nothing. Structurally, it need not be so. That is the point that I want to say. In creativity, there need not be a structural abnormality. Next slide, please. Now, creativity can be broadly divided, as my friend said. Every one of us is creative in various degrees. The lowest is the dull form, the low working memory, low IQ. There may be psychopathology and brain damage. They have a dull output. Still, they are creative in their own way. I will tell you after some time, even in those groups, where is the pointer there? Yeah, fine. You keep it. Now, even in those groups, there can be wonderfully great artists. And the second group, I think most of us form in the middle, the little C group. We have adequate IQ, cognitive flexibility is there, we have better working memory. This is a really important thing, working memory. The big C, only a very tiny few people categorize to this. They have hyperconnectivity to a great extent among the neurons, among all cells. They have high IQ, they have cognitive inhibition, about which I will come. We come to the term normalcy. We all consider normal as a great thing. At least in neurology and in cognitive science, normal is the average or the mediocre. It looks rather ridiculous, but it is true. Long back, I wrote an article about one of the great Indians, and I said that whatever he brought out was because of his temperament. My teacher, a man who took his DSc in embryology in those days from Rochester, he asked me, tell me, how do you define normal? We really do not teach people the hypernormal states. It is the hypernormalcy which makes the people genius, workaholic, creative, etc. Normal is the humdrum of activity practiced with the majority of the scientists, the bricklayers rather than the architects. This is from one of my friends. His name is very, very familiar to all of you. A great writer, one of the best neuroscientists of the world now, V.S. Ramachandran. With the passage, the mask became the man and the ingenuity is beaten out of them. Next slide, please. Next. Now, all young kids, our children also, they were geniuses. To a terrible way, most of us knock them down also. At the time of birth, the synapses are only 2,500 per neuron. One becomes in a year or so 15,000 to 20,000. Then they go on asking questions which you can't answer most of the time. You say Chumairika. This Chumairika means goes on and on, there's about. Even otherwise, the unnecessary proliferation of the synapses come down by the age of 8 or 9, then they become within inverted commas, the normal, the average or the mediocre. These windows of opportunity, we knock down, the adults knock down to a great extent. Next slide, please. I come back to some medical history. Actually, this gentleman, the one in the middle, John Fulton, he should have got a Nobel Prize, but he lost it. I'll have to go a little previously also. Wilder Penfield, the man who did a lot of temporal lobectomies, temporal lobe studies, temporal lobe stimulation, for the epilepsy study, finally decided, after about 1,000 surgeries and 1,000 studies, he said, look, I do not know what exactly makes the mind of a person, what exactly makes the thought of a person, what exactly makes the soul of a person. This is not the place, this is not the place where we study. It is in the time, a little before that, there is a chap by name Abraham Flexner who was asked to go around all the medical colleges of America and find out what's wrong with them. As a result of it, 31, except 31, all of the medical colleges had to be closed because he wrote a report saying that all of others are useless. So, big universities, including Harvard, Yale and all, they went on looking for bright youngsters. And Yale got this guy, the middle guy, John Fulton. It was he who started a great work in Yale University when animal experiments did not have much of, what should I say, restriction. He removed the dorsolateral prefrontal lobe, that is this part, or the frontal lobe, that is this part, of two chimpanzees, Becky and Lucy. It was so surprising. Those chimpanzees were so aggressive, so much, what should I say, active. They became subdued. All the people who saw his chimpanzees, read his papers, were amazed at it. He was the greatest figure during the time. In 1935, in London, the International Neurological Conference in London, he presented the paper. By the time he had some problem which I will come to. Fortunately for him, he had a very good colleague, very good assistant by name Carlyle Jacobson, who would do whatever he is asked. He was as good as John Fulton. And John Fulton and Carlyle Jacobson presented a paper on these two chimpanzees whom they ablated the dorsolateral prefrontal lobe. Everybody was so much happy to see that those aggressive chimps became so much docile. But then, most unexpectedly, a person sitting on the back got up to ask a simple question. You have created docility for these aggressive chimps. After all, we have nothing to give to the insane persons. Why can't we do the same sort of surgery for the humans and make them docile, make them comfortable as much as we can? This gentleman never ever thought that this investigation, this study could be replicated in humans. He did not have an answer. In between, he asked who that questioner was. To his horror, he was told, he is the greatest man from Portugal. He ought to have got a Nobel Prize even long back for his carotid angiogram. For the first time in the history of neurology, somebody did the angiogram intracranially and got the cerebral angiogram. He did not get it. His name was Igas Moniz. On the top of it, he was a politician par excellence also. And Igas Moniz did not stop there. After the lecture and all, within about few months' time, he decided to do the ablative studies on the insane people. According to him, the results were brilliant, beautiful, etc., etc. And I'd like to say one more word about this. After about a few months' time, Igas Moniz found that is one of the most brutal surgery one could think of. But by the time it spread to US, a chap by name Walter Freeman took up it. And the story goes 50,000 people were submitted for this surgery all over US. Everyone became so docile, they just sat there like a living, what should I say, corpse. Next page, please. Now, in the undergraduate and graduate days, and possibly even for the DM days, we are taught about the, what should I say, the nice fascicles going here, there and all. But it is not so. It is all over our brain. It is interconnected so much. Now that the diffusion tensor tractography has come, it has come to understand the beautiful one. I like to stay here for a second more. John Fulton, I told you, unfortunately, he was a tragic hero. He had his own personal problems. He lost the Nobel Prize, which ought to have been given to him, but given to Igasmonis for this work. And he became sick, and he died too early. Yale University did not have a correct person for a long time, and then they searched and found a great person whose name I want to repeat at least twice, thrice, any number of times, Patricia Goldman Racky. When she took over the work, it was brilliant. Next slide, please. When she took over the work, the animal experiments were practically not banned. It was made really difficult. Nobody could do it in a hurry. And by the time, fortunately, the MRI studies and other neuroimaging studies started coming. What Fulton left, Patricia joined. Fulton thought for a second that for the monkeys whom he ablated the dorsolateral prefrontal region, they're a very funny thing. Keep something in front of them. They see, they understand. Hide it or take it away. The chimps forget everything. According to them, out of sight, out of mind. It was he who pointed this out, and he had no idea what he was leading to. It was Patricia's work which continued this, and she said that the frontal lobe is the place for the working memory. If you take the memory as a whole, you have at the one region the sensations which are perceived by the eye, ear, etc. That is one which lasts for about hardly 250 milliseconds. Then you have a shorter term memory, of which a part of it is working memory. There are people who differentiate it so well, but most of the people say that working memory is to be considered. That too lasts for about, less than about a minute or so, maximum a minute or so. Surprisingly, the number of things which can be kept in your memory for that short period is also limited. Miller, at a later time, John Miller has put the number as 7 plus or minus 2, that is the number which you can keep at a time. That is why most of the telephone numbers are still 7 here. You can remember them. In fact, it was Patricia who continued the work of Fulton, and it was she who said that the connection to the frontal lobe is not restricted from the ancillary region around, but from far away places, all the way from occipital lobe, temporal lobe, parietal lobe, etc. It is she who said, who started defining thoughts. What are thoughts? I will come to the definition later. They do not know how many thoughts could be had. There are people, the people in neuropsychology, neuropsychiatry, neurology, hardcore neurology, they all join together. 86,400 seconds per 24 hours, of which 7 hours you sleep it off, you have still about 61,200 seconds. According to the neuropsychology people, that you have one thought a second. Make it one thought per 2 seconds, 3 seconds. Still the number can be abnormally high, unbelievably high. What happens to them? 90% of the so-called thoughts, they go like the milkweed fluff, appu pentadi. They go, lie down and get lost. Some are different, a few of them. They are like the nuptial flight of the white ants. They fly, 99% of them perish. But a few of them, they lose their wings. They go to the hiding places they made, and they make the life miserable. And the next one is, some of the other thoughts are like magnets. They go on catching everything. Whatever that is happening, they catch. And in fact, from the neuropsychology point, certainly it is important. The magnet business is equated with OCD, obsessive compulsive neurosis, and all the other way around, multiples of thoughts coming simultaneously, one after the other, one before forming, one before perishing. They all come together, jam these things, and make it worse. In fact, according to neuropsychologists, it would be at the schizophrenic one. Next slide, please. Next slide. Definition of thinking, possibly many might not have been thought of it, is manipulation of information to form ideas, concepts, problem solving, reasoning, and making decisions. Then intuition is an ability to understand anything instinctively without thinking too much. Imagination is faculty of forming new ideas or images of external objects when you don't get the stimuli for this. The imagery is visual images collectively. Now comes the last one, aphantasia and hyperphantasia. I ask you to shut your eye for a fraction of a second. Think of the people whom you love. Whether you can make their mental picture, or your house, the place from where you are coming. To the horror of you, that is about 10%, 15%, or 20% can't make the future. This is called aphantasia. This aphantasia, nobody believed that such a thing would be possible, but it is. In contrast with that, you have hyperphantasia. You close your eye and start worrying, start thinking about so many things. All of them you can make the images. Next slide, please. I have shut the eye and found that I could imagine so many things simultaneously without any difficulty. I can remember my teachers, the one above would be Professor Pai in America, our dear Ayya, Anantachari. And this one who is half there is one of the most brilliant teachers Trivandrum College had, G. Kavaria. And the background story is Hotel Chola in Tamil Nadu. And below that, any number of people, even name, where they have met. Everything I can remember in a second. This is hyperphantasia. It is good. I believe it is certainly good. It makes me happy. At least remember these things. Next slide, please. Now, if you ask anybody what is thinking, The first answer which is going to come is, you are talking to yourself. That leads to talking, whether the language is there. According to Einstein, words or language, as they are written or spoken, do not play any significant role in the mechanism of my thought. He's right. The next is another great psychologist. The limits of my language limits my world as well. Let the angel of creativity be freed. Next slide, please. This is what Dr. Thomas Ipe has touched on. There are three major realms, three major networks. The frontal attention network, comprising of the dorsolateral prefrontal cortex there, and from there the cingulate gyrus and the parietal lobe, right up to the occipital lobe. From there, the language area, Broca's and Wernicke's, what happened? Yes. Can you make it? Yeah, I will continue. The second network is, next one please, yeah, is the default network and the salience network. Salience is a switching network. It is the one which switches between the default network and the attention network. You let the default network do the trick. You become creative. The content that is in the medial frontoparietal network, medial prefrontal cortex, posterior cingulate cortex, insular and angular gyrus. Now the thing is, when your first network is active, you don't have the default network going on. When you are tired, when you are sick, when you enter in a jungle of confused thoughts, you suddenly feel that all the ways out are blocked, darkened. You do not know how to proceed. Still, you get a feeling, you get an innate feeling. A lovely little damsel of an angel is not even not anywhere out of you, but right inside you, who keeps you happy, who makes you feel that, look, there is a way out. I am going to tell you. It is the salience network between the attention network and the default network. Next slide, please. When you are sick of all these things, when you are tired, you find that you could answer the questions which are cropped up in your mind, or somebody has asked you, you have no way to get it. Ideal thing, go back home. Sleep it off. Ideal. Or go to your spouse, help her out in her kitchen, cut vegetables, cut meat, cut anything. Or go a little more further back. You make her, you cut the wood, set it out. Or better, make a walk, take a walk. And suddenly you will find you go out of the place. It's a lovely poem written by a great poet in Malayalam. Onna എഴുന്നേൽക്കൂ വരൂ മുറ്റത്തോടവും മന്നി വെണ്ണിലാവായിടുമി വെൺപുഴയ്ക്കകം മുങ്ങൂ. Go out. Suddenly you will find that you get newer ideas, unbelievable, unthinkable ideas. I agree. The part of it is genetics, part of it is intuition, part of it is imagination, imagery, and much more important, you must have tons and tons and tons of experience. You must have gone out to the world to find out people, find out experiences, places. You get experience. Mixed with that, you have. Now, I told you, sleep is an exceedingly good way of getting it. And one of the diseases, narcolepsy, where you have a lot of sleep problems, including quick REM sleep, they do have a lot of what should I say, capacity for creative thinking. There are people who purposely slept it off and then brought out. I think Salvador Dali, Elias Harvey, and Mary Shelley. Next slide, please. I think I'll move very fast. This is about, again, the REM sleep, the breath of an angel, like a cool breeze, the fragrance lingers. You know that it is coming, and you don't feel, you do feel, but you certainly have no vision of her. Next slide, please. Now, the amount of work which you need to bring out such a creative work is so much. I'll give you two examples only. I don't know how many of you have seen the MRRs with the cat's eye inside. What you get is rough stones. You take so much of work to polish it to bring out the cat's eye. This is a dove picture drawn by Picasso. He asked a man to pay him so much of money. The poor fellow asked, "Sir, you draw only a small sketch in a tissue paper and you are charging me." He said politely, "Look, for drawing such a picture, I spent 40 years of my life." Next slide, please. I'll come back to the last part of it, creativity in brain diseases. The one which a man who never had any creative activity may get abruptly creative thinking in frontotemporal dementias, and more so in autism, in GPI. Next slide, please. This is about syphilis, bringing out the creative part of the artist. Next slide, go to the next slide. Yeah, I think I am coming to the last part of it. You know, this is a schizophrenic Louis Vane who went on drawing the pictures of cat. It is interesting that you can find the degree of deterioration of his mental capacity by looking at the cat's picture, first row and the second row. Second is Seraphin Louis, Richard Dare, and Alfred Brooke. Next slide, please. Same picture of these three people. Next slide, please. I know that I have taken a little more time, but then can't help it. Thank you very much.
Thank you, sir, for the fluent narrative. And since this is an oration, there are no questions, I believe. There are no questions for oration. We will have a standing ovation. Thank you all.
We are humbly requesting Dr. Krishna Prasad to hand over certificate of appreciation to the chairperson, Dr. Thomas Ibe.
Sorry, sir, I have a little difficulty in walking, so.
We are now moving on to the next session. Dr. Joy Philip Oration. The Joy Philip Oration has been awarded to Dr. Matthew Thomas. We invite Dr. Matthew Thomas, the Vice Chancellor, Dr. Mohanan Kunnumal, and Dr. MKC Nair to the stage. We also request the chairpersons, Dr. KP Ayyappan and Dr. Suma TK to the stage. The Joy Philip Oration Award has been conferred to Dr. Matthew Thomas. We humbly request Dr. Mohanan to adorn the medallion on Dr. Matthew Thomas. We request Dr. MKC Nair to present the scroll to Dr. Matthew Thomas.
Actually, we have an apology. Yesterday, Matthew Thomas was in the list of distinguished alumni, but unfortunately there was some confusion in the list. And now I request our Vice Chancellor, Dr. Mohanan, to, along with, I request Ramakrishnan sir also, please come as the past president to present this Distinguished Alumnus Award. As you all know, Matthew Thomas sir was 1966 batch, 66 batch, and he was there. Yeah. Sir was the head of medicine, Department of General Medicine, as well as the superintendent, and right now he is working as the head of General Medicine in Kim's Hospital. We once again apologize to sir for our mistake yesterday. Thank you.
Namaste. First of all, I would like to thank the Trivandrum Alumni Association, its chairman, Dr. John Panikar, Dr. Vasudevan, Dr. Bindu, and all, for permitting us to start the oration on our friend Joy Philip right away, this year itself. I remember it is in this hall in 1965 September, myself and 181 aspirants of medical profession assembled in this hall in front of Dr. M. Thangavelu to take oath. That was the first function we witnessed in this hall, and this hall remains the same, and we are all here to Joy Philip Memorial Oration today. As you all know, we were 182 plus 2 or 3 added later, and of which 50 of our friends have lost their life. Joy Philip to the last. Joy Philip was a good student. During our journey through the medical school, you could find him as a brilliant student, one among the most brilliant of our batch, passing through, learning through, collecting all the syndromes every day. And he could get more than 12 gold medals during this journey of MBBS. And he married to Jilly Trisha, Jilly, our own classmate, and they have 2 children. Both are doctors, one is here in RCC and one is abroad at US. Joy Philip joined this medical college itself to take up the teaching profession, and during his journey, he passed the MD from here, and then he went on to UK for a fellowship in rheumatology. In 1983 or so, he returned and started clinic in rheumatology also. He was a very good friend of mine, our batch, very good, loved person of the society at large. He was very empathetic, very sympathetic, very loving, and ever smiling person. We could all remember him, and even now his legacy, the smile and the love is there in front of us. And for the oration, we are getting our junior, Dr. Matthew Thomas, a very brilliant person, hematologist, and former HOD of this institution, now working in Kim's Hospital, and he will be formally introduced by my co-chairperson, Dr. Suma. Over to Dr. Suma.
Thank you, Dr. Hypen. To introduce Matthew Thomas, sir, to this audience may be superfluous. And you have just seen that sir has also received the Distinguished Alumnus Award from the Alumni. Sir has did his MBBS in 1966 and MD in Internal Medicine in 1975 at this institution. And he has also received the Sri Padmanabha Memorial Gold Medal for Surgery and also Rotary Vocal Excellence Award in 2002, and he also has received the Best Doctor Award by the State Government of Kerala and Kerala State Award for Crisis Management. And he is now a very good worker in the member of the APA Kerala chapter, and there also he has received the Lifetime Achievement Award. And he was mainly focused while he was working in the medical college as assistant professor, associate professor and all that. His main interest was in hematology. And here the topic is systemic lupus erythematosus, my journey. So we know that when we started listening about the systemic lupus erythematosus, it used to be told as a triad of fever, joint pain and rashes. Then a lot of things have happened, a lot of manifestation, a lot of diagnostic points and investigations and management. And sir has worked from 2008. Professor Matthew Thomas has worked on systemic lupus erythematosus. I think without wasting time, I am inviting Matthew Thomas sir to give us a good picture about his journey with the systemic lupus erythematosus. Over to you, sir.
Respected chairpersons, senior alumni, and my dear friends. I first of all thank the organizing committee for choosing me as the orator for Dr. Joy Philip Memorial Oration. Everything about Dr. Joy Philip has been told. He was our dear friend, close friend, just 1 year difference. 1965 and 1966, we followed the same path, MD Medicine, and then we joined the Faculty of Medicine, Trivandrum Medical College. He retired in 2003, and I've retired in 2004 as the head of the Department of Medicine. A unique teacher, unique way of expressing things to the students and to the audience. Let his soul rest in peace. Now in 1980s, people with SLE, rheumatoid arthritis, we considered that as an orphan disease because there were nobody to take care of them. Only the specialties, major specialties like cardiology, neurology was coming up. So somebody in medicine had to take up their suffering and go with them. So I thought I would choose, and that is how my journey started with SLE. It was really an orphan disease, nobody to take care of these people. So I thought I will take, and the journey has started then, and it's continuing even after 40 years, though my primary interest is in hematology. And has the incidence of SLE increased? Maybe it has slightly increased, I think. A unique disease with a sex ratio of 9:1. And this is a drawing of a SLE patient in 1918. Lupus means wolf and erythematous means reddening. The name was coined in 13th century and resembles wolf bites. So I'm not going into the details of SLE, but I'm mainly focused on the work we have done for SLE in 2009, bringing out an epoch, a curricula or treatment-changing drug called belimumab. That's my main center of the talk. So you know it's a chronic autoimmune disease with unknown etiology. And almost all the organs can be affected, and it's typically termed as a multi-system autoimmune disease. A thyroid disease, a uni-organ, where you have autoimmune thyroiditis, and you can have even a unicellular autoimmune disease like ITP, where a single cell is involved. And immunologically, it's characterized by presence of anti-nuclear antibody. Very heterogeneous disease. On the one hand, you have very mild disease with skin rashes and joint disease, and on the other, you have severe life-threatening disease where kidney and nervous system is involved. And luckily, this type of presentation is not very common. And with lack of pathognomonic features and characteristic diagnostic findings, sometimes diagnosis may become a challenge for many other physicians. Clinical features, I'll just rush through. It is termed under constitutional like fever, fatigue, arthritis and arthralgia found in many of the people. Mucocutaneous lesions, facial butterfly-shaped rash, skin involvement in the form of discoid, photosensitivity, recurrent oral ulcers, everything. This is the typical malar mash and joint involvement and the discoid lupus. Cardiac involvement seen in about 25%, involving every part of the heart, like pericardium, myocardium, endocardium in the form of valvular lesions, conducting system, especially in neonates who are born to SLE mother, it can produce heart block. Coronary arteries, we have got several patients with coronary artery disease. The small vessels are involved, not like the major blood vessels. Raynaud's phenomenon, vasculitis, thromboembolic disease. Kidney involvement in about 50%, and this is a single cause of mortality and morbidity in SLE. Gastrointestinal, 40% with mainly produced by drugs. Esophagitis, hepatitis, enteritis, and pancreatitis. Pulmonary involvement is not common. Neuropsychiatric involvement, many patients have been referred from psychiatrists after treating them for a long time and seeing no results and finding a high ESR, they refer to us. Hematological, that's very common. That's one of the reasons why I took up SLE, because all the three cell lines are involved. You get anemia. Leukopenia is one of the earliest manifestations in SLE, and also the platelets in the form of thrombocytopenia. And ophthalmological lesions are also there. Association, so many conditions like antiphospholipid syndrome, fibromyalgia, these are all associated with SLE. How do you evaluate a proper history is up in the list. Clinical findings which I have described and investigations, especially the antibodies, anti-DS antibody and the anti-Smith antibodies are very specific. And diagnosis is based on American College of Rheumatology guidelines, SLIC criteria, EULAR criteria, and they are classified into definite, probable, and possible. Differential diagnosis runs into many diseases like rheumatoid arthritis, systemic sclerosis, Sjogren's vasculitis. And the main principles of management is under the following headings. Ensure long-term survival, which we have achieved, as you will see later. The lowest possible activity of the disease by measuring the ESR, anti-dsDNA, C3, C4. These are the markers of activity. Prevent organ damage, one of the important things. And decrease drug toxicity, increase quality of life, which we have also attained, and patient education. SLA treatment is mainly non-pharmacological sometimes, where we give skin protection, diet and vaccination. Pharmacological, it's different according to the severity of the disease. From mild to moderate, we use hydroxychloroquine, NSAIDs, corticosteroids, not a high dose, lower dose, methotrexate, mycophenolate mofetil, and the drug which I am going to talk, which we have worked a lot, is belimumab, and the newer drug, anifrolumab. Severe conditions, when that involves the kidney or the brain, we use cyclophosphamide and mycophenolate mofetil. They are found to be useful in that situation. And the prognosis has changed a very great extent in the these decades. If you say a SLA with a bad prognosis, if the renal nervous system are involved, male sex, when it is associated with antiphospholipid syndrome, 5-year survival has, in the 1950s, it was just 40%, and it has come to 90% after 1980s. So there's a great change in the life of SLA patients with a very increased 5-year survival. Mortality, though increased, it is about 2 to 5 times than the general population. And the causes of mortality are the organ involvement. Now, I come to the main part of my talk, where we had a very important drug introduced into the treatment of SLE, and our clinical trial was published in 2011 Lancet. Efficacy and safety of the drug belimumab in patients with active systemic lupus erythematosus, a randomized placebo-controlled phase 3 trial. What did the trial tell us? Researchers on SLA found that in SLA, the B cell activity is increased. So we were hearing all along B cell and T cell. So here also the B cell is very active, and it start producing autoantibodies like anti-nuclear antibodies, anti-dsDNA antibodies, and they have also found another cytokine-like substance which they termed as B lymphocyte stimulator. So probably this will come in the later physiology books, how B cells are controlled. This is an agent they found out, and they also found out a fully humanized B lymphocyte stimulator specific antibody, and that is belimumab, our drug we used in the clinical trial. It was a randomized placebo-controlled phase 3 trial. It was a global study throughout the world, 867 patients, of which we contributed 40 patients from our site in KIMS, and the maximum number was by the first author, Navarra, my friend, who is in Philippines. She contributed, or she recruited 60 patients. And in the trial, finally we found that there was a significant improvement in mild to moderate active SLE patients with statistical difference. So this was a pivot study, just changing the thinking about the treatment of the SLE for the first time after we heard about SLE for a long time. So after this pivotal study, FDA approved this drug belimumab, and now it is called Benlysta. That is the name of the drug. And it is acclaimed as the first targeted biological treatment very specific to SLE. Before that, all the other drugs were non-specific, like corticosteroids, chloroquine. And this breakthrough study was presented in the annual meeting of the American College of Rheumatology in Philadelphia in 2009. Later, this drug was again approved for even lupus nephritis later on, along with the other drugs. Now, we analyzed our cases and we found that very important findings still. What were the important findings? It was found that by analyzing this 800 odd patients' records and study material, this drug reduces the autoantibodies. There were decrease in the, they normalizes the complement levels and reduces the select B cell population which were hyperactive. And these were the important studies which was published in Arthritis Rheumatologica in 2012. So this really told us that it could really reduce all the autoantibodies, and some of the patients' anti-dsDNA completely disappeared. And the Smith antibodies, antiphospholipid antibodies, all this disappeared. So this was the finding with the analysis of the patients. A significant reduction in anti-dsDNA and the Smith anticardiolipin antibody. Normalizes the complement levels. But the good thing is that it did not affect the memory B cells and T cells. Their functions were continuing. And also, there are definitely good antibodies in our body, and they were not affected, like the pneumococcal antibody and the anti-tetanus antibody. So this was a very important finding, that it affected only the cells which produces the autoantibodies in lupus and erythematosus, but not the normal antibodies that we have. Then we continued the study for about 8 years, and we asked the company to provide us drugs for the patient, and they were providing the drugs till it was approved and available in the market. So we were able to get this. This drug was given by an intravenous infusion every 28 days for 1 year. That was the initial study. Then we continued for another 8 years, but the number of patients decreased. It came to about 730 patients, and we continued for about 8 years trying to see what happens during this period. So this is the findings of this study after 8 years, which was published in Rheumatology, Oxford. Long-term safety and limited organ damage in patients with SLE treated with belimumab, a phase 3 study extension. So what happened is that 738 patients were in this study, and some of them dropped off, probably seeing the good effects. They do not want to come under the clinical trial again. And monthly assessment was done for 8 years. And belimumab displayed safety, stable safety profile with no safety signals, new safety signals. That means the drug was very safe and it was very effective. Minimal organ damage progression over 8 years, but the cost of the drug is the one which is the limiting factor, which is probably a single injection is costing over 1 lakh rupees. So that is why many of our patients cannot get it. But probably in the future, we will be able to get it free or a little more less costly. And this is another study we did in pregnant ladies with SLE, what happened to them. So this was published in the Journal of Obstetrics and Gynecology. And the study was 73 patients we had. Mean age was 29, and 86 were diagnosed before the conception. And we found that though we had 33% of them were active in their active disease, it did not cause much damage to the patient during the pregnancy. SLE activity had no impact on fetal demise, and fetal loss was only 14%. Now we come to the last slide. So this girl was seen 13 years back. She came to us with an acute abdomen in a very serious situation, and we found that she had a mesenteric ischemia, and which was blocking all the blood vessels and veins in the abdomen. We did an immediate surgery, and she became better. And then she was diagnosed as SLE, full-blown SLE, all of a sudden. And then we were able to make her better. She continued engineering studies, undergraduation, post-graduation. She got married, and now she's with a child. And one thing we advise the patient who plan to get married is the better half should know about the condition. So we tell them, unless you tell that, your married life will not be a good one. So many of them come back to us and ask us, is it a serious disease? Can she undergo pregnancy and childbirth? So we have got so many families who are doing well with children, going back to work. And so there's a great change in the treatment of SLE. And I'm happy to be with this treatment, and I'm still continuing my journey, and probably we'll have more people cured or more people better with this, with a good family life. Many of them are leading the normal life and normal jobs. So it is not a condition to be feared. It is a condition to be properly diagnosed and properly managed. Thank you very much.
Thank you, Professor Matthew Thomas, sir, for the excellent presentation about your trials on the baby boom and the advantages and also the effect of it on the pregnancy and the usage of it. I don't know whether the question is allowed in the oration. No, thank you. Not thank you. Thank you, sir.
The organizing committee would like to place its deep appreciation to Professor Matthew Thomas, sir, because he postponed his journey to Australia by 2 days to accommodate us. We are very grateful, sir.
Just one sentence is that I loved receiving this from the previous Vice Chancellor and the present Vice Chancellor rather than yesterday. Thank you so much for giving it to me.
We request Dr. Ramakrishnan Nair to hand over our certificate of appreciation to the chairpersons, Dr. K.P. Ayyappan and Dr. T.K. Suma. Thank you, sir. We now disperse for the lunch. Delegates, kindly note, we will resume the next session exactly after half an hour. Kindly assemble back soon.
We are about to resume the Professor P. Ravindran session. The delegates, kindly join us in the old auditorium. Inviting the speaker, Dr. Nijin Haroon, onto the dais.
So good afternoon. So we will start with the post-lunch session. So this session will be a continuation of what we had in the morning. That is, we talked about the post-COVID lung syndromes. And then a lot of questions during that session was pertaining to the immunology of COVID-19. And we told that all these questions will be addressed by you during the current session. So my pleasure to introduce the speaker for this session, this immunology of the COVID lung. Dr. Nijil Harun is a 1993 MBBS pass out from Trivandrum Medical College. He is the Associate Professor of Medicine and Rheumatology at University of Toronto. Chairman of AKMG Convention Toronto. He has received many awards, which includes the Breckel Award for Spondylitis Association of America, Young Investigator Award from Canadian Rheumatology Association, and he has extensively published in the field of ankylosing spondylitis. And we all know that what COVID-19 has taught us in the last 2.5 years is that even for infections, targeting the immunology is very, very important. As we discussed, majority of the medications with mortality benefit are the immunomodulators. And one thing that struck us during the treatment of COVID-19 in the initial days was that even though majority of the patients who used to die happened to be those with comorbidities or elderly, there used to be a subset of youngsters without any comorbidities who used to succumb to the disease or who used to develop severe pneumonia. And then since COVID-19 was there not only in the neglected parts of the globe, it was there in Europe as well as USA, there are a lot of studies which went on and told that it was due to missense mutations in toll-like receptor 7, etc., which predispose the youngsters to develop the severe COVID-19. So to enlighten us about the immunology of COVID-19, I would like to invite Dr. Nijil. Over to you, sir.
Thank you. Thank you very much, Dr. Arvind, and a pleasure to be here always, and always thankful to the organizers for giving me this opportunity to come back to the place where you learned the basics of medicine. And trust me, I never thought I would be here standing along with the giants of medicine when I was doing my medicine and just trembling to go into the clinics. So it's, I'm really humbled and feel so blessed to be here. Thank you for the opportunity. We've been dealing with COVID-19 for 3 years now, and almost everybody, even my son who is 11 years old, knows a lot of things about COVID-19. Some of the things he knows I don't know, because there's a flood of information coming out from many centers in the world. So my idea is not to be really exhaustive, considering the time constraints. It's just to, give you a few snippets here and there, which I thought were interesting. And we'll end up with a focus on lung, but we'll start with maybe a few introductory thoughts on the immunopathogenesis of COVID-19. And hopefully, if we have time for discussion, we will try to bring all the concepts together. So this is very familiar for all of us, and when it comes to immunopathogenesis, it is the spike protein that is most interesting for all of us. Although there are immune responses to different parts of the actual virus, but it's the spike protein that is really of interest to us, and we will see, and we all know why. This is an electron microscopic picture of how the SARS virus enters the dendritic cells. You can see very well how the virus particle goes to the surface of the cell, and then over a period of time it gets into endosomes, and now we know that you don't really need an endosomal pathway to get in. It can get in without being through an endosome. A direct invasion is also possible. You can see the viral particles within the cell very clearly. So these were very early days of our understanding. And we realized that the spike protein connects with the ACE2 receptors as the binding molecule, and then we need a protease. Once the binding happens, we need a protease that helps cleaving this S1S2 site so that the virus can enter it. And our earliest understanding also was that TMPRSS2 was the protease, but now we know that there are TMPRSS2 independent pathways to get in. Furin is a good example. Another important molecule that may be important is cathepsin, which helps in the spread of virus from one cell to the other. So a lot of progress has been made there. The other interesting thing also which we noticed very early on is the humoral immune response to COVID was not like most other infections that we see. We usually see an early on IgM response to a viral infection or a bacterial infection. A little bit of time passes, and then the T cells get activated through the CD40 ligand interaction, and then the class switching happens to IgG. And with the IgG, our stronger antibodies, they're much more helpful for us in protection against further spread and in further infections. As opposed to, if you look at this figure, you'll see that IgM and IgG responses start on almost very similar timelines. And if you look at, if we take a large cohort of patients, a large bulk of patients would have IgM and IgG coinciding. And in some, you may even have IgG preceding IgM formation, which is, if you look at this, think about the basics of immunology, it doesn't make sense. But what is immunology other than just a rearrangement of a few small genetic components? So perhaps SARS-CoV-2 is driving a recombination in a way that IgG comes up earlier than IgGM. So that's another interesting observation that we have seen very early on itself. And as Dr. Arvind was alluding to earlier, one of the major features of SARS-CoV-2 infection is that the severe complications and mortality are not primarily due to direct viral invasion of cells, but rather due to our own immune responses that go overboard, and in the process of trying to protect us actually ends up being detrimental. And we had these 4 different stages, and these 4 different stages are very closely associated with the immune processes that are happening in our body. And as you can see here very clearly, the mild and moderate symptom phase is when the virus actually enters. When you go into the severe symptom phase, you will see that the primary, the Th1 responses, the interferon responses are actually lower when it gets to severe manifestations, which is not what you would expect with a viral infection. You want the body to pump out a lot of interferons to get rid of the virus. But here, when the patients have severe symptoms, you have lower interferon levels. You see a lot of chemokines being pushed out. The chemokines are key for bringing in all the immune cells into the target tissues. And here, in fact, these immune cells may actually be detrimental, causing end organ damage. And finally, you will see that the balance that we see early on in the immune cells. So very early on, you see lymphopenia. T cells are decreased. B lymphocytes have a relative decrease in numbers, but you see that the mononuclear components, the monocytes and the macrophages, are higher. But over a period of time, what you see is that the T cells get specifically activated, and you start seeing an increase in Th1 and Th17 cells, leading to an overproduction of interleukin-1, interleukin-6, and TNF. And we know that these are target cytokines that we use for treatment. We already had the session on treatment, so all of that was discussed. So these are the cytokines that have been identified to be elevated, and you will notice that most of them are well-known markers of inflammation: IP10, MCP1, TNF-alpha, IL-6, and IL-2. So these are the early laboratory findings. I won't take any time here, but these are things that we know. But for severe disease, we know that there are some components that we can use very early on to identify patients who may go on to severe disease. Lymphopenia and neutrophilia may be one factor, but still one of the most important factors appears to be D-dimer elevation and lymphopenia, again coming to the lymphocyte decrease. Later on, we'll talk about a little bit about how the lymphopenia happens. D-dimers, this is just an example of D-dimer being very closely correlated with mortality in COVID-19. And finally, again, Dr. Arvind already mentioned that one of the earliest findings was that comorbidities are really important when it comes to mortality and severe disease. So with all of these observations, there were very early hypotheses on what is actually happening in the body. How is it that COVID-19 is so different from SARS-CoV-1 and other viral infections? And we have all arms of the immune system being involved here, right from antigen presentation, cellular immunity, and humoral immunity, all being different from what we have known as normal viral responses in the body. One of my earliest, I'm primarily a rheumatologist, so one of my earliest striking things from SARS-CoV-2 presentation was the distribution of the SARS-CoV-2 pneumonia patches. They happen to be very subpleural, and there's a lot of interstitial changes that can happen in these patients, but very severe lung involvement, out of proportion to the kind of X-ray changes that we see. And this was very, very closely mimicking a kind of myositis that we see in our clinics. It is a more recently identified kind of inflammatory myositis, and that myositis it manifests as dermatomyositis because there are dermatological manifestations, but the key thing is that it's associated with an antibody against MDA5. So melanin differentiation antigen 5, and I was thinking, how could it be possible that there is such a striking similarity between these two? And interestingly, this MDA5 associated myositis also does not behave like usual myositis. In MDA5 associated myositis, you can have normal CK levels. You may not have actual muscle weakness, but you have a lot of interstitial lung disease with subpleural patches, as you see in the CT scans here, very similar to what you see with COVID-19. And you can have cytokine storms also with MDA5. And the skin lesions, actually what you see in anti-MDA5 disease is more like a vasculopathy or vasculitic-like lesions, again, similar to what you may see with skin lesions of SARS-CoV-2. And this is just from a case series. I just wanted to show you some of the features that you may see with anti-MDA5. And here are the subpleural opacities that you see with MDA5. You can see in the antelix, you can see nodular lesions, a lot of skin lesions, the typical vasculopathy associated ulcerations that you can see. Another example where you can see a dermatomyositis like periocular rash, you can see, along with the dermatomyositis like rash and along with atypical rashes. So interesting thing is that MDA5 is actually a pattern recognition receptor. So we talked about toll-like receptors, and now earlier on TLR7 was considered to be an important factor that may be determining the pathogenesis of SARS-CoV-2. We all know about toll-like receptors. Toll-like receptors are membrane-bound pattern recognition receptors. You have TLR4 on the surface, then you have all the TLR3, 7, and 6 in the endosomal compartment. So once the virus particles get inside, the virus particles are detected by TLR7, the cell produces a lot of cytokine response, you get rid of the virus, and that's how we are protected by an innate immune mechanism. Now, apart from these membrane-bound pattern recognition receptors, you also have cytoplasmic pattern recognition receptors. RIG1 is well known. Another one I'm sure you all know is STING. And there was a famous case series which came in New England Journal of Medicine of kids developing interferonopathy related to STING. MDA5 is a similar cytoplasmic receptor for viruses that leads to production of interferons. So there was that interesting spark. Oh, here is the connection between perhaps what I'm thinking is, I'm not sure if this is true, but perhaps we now know that the ACE2 distribution is very common in the alveolar spaces, and that may be why the subpleural spaces are getting affected. Perhaps the MDA5 expression is also similarly distributed, leading to a similar pattern of recognition. And now we know that interferons are very, very important for COVID-19, and severe COVID-19 is associated with a relative type 1 interferon deficiency. So here is an example of where MDA5 innate immune responses was earlier on identified as part of SARS-CoV-2. I would extend it to a few other clinical observations. So I was just trying to find out if there have been reports of myositis in SARS-CoV-2 patients. And in fact, some patients with coronavirus infections, COVID-2 infections, can have myositis. It is not a very common presentation. But even more striking is there is a case series of individuals who got vaccinated against SARS-CoV-2 and developed myositis. So again, just showing that perhaps activation of the interferon pathway through MDA5 may be underlying all of these processes. Okay, now we move on to the actual pathogenic processes, and I'll try to finish this very quickly. We don't know exactly what is going on in each individual organ, but there are a lot of studies that have come out that have given us a clue as to how complex the process is. So if you look at the immunogenic processes, there are direct cytopathic effects that have been described. So the virus can directly infect the cell and cause cytopathology, and it can cause pyroptosis with killing of the cells, similar type of process, but here due to a direct viral infection. We know that once the ACE2 clubbing happens with the spike, the ACE2 level, ACE2 gets endocytosed, leading to a relative decrease in ACE2 levels, leading to an overactivation of the renin-angiotensin system, and that can be pathogenic. We talked about the cytokine storm that happens as a result of activation of the innate as well as adaptive immune system. Interestingly, there is a lot of autoinflammation and autoimmune responses that have been triggered as a result of SARS-CoV-2, and I have a slide on that, so I'll leave it for that. One of the other striking manifestations which we have recognized very early on is the coagulopathy. And again, I don't think for an individual patient you can really pinpoint what is behind the coagulopathy, but a number of factors behind coagulopathy have been identified. One would be the exocytosis of procoagulant factors from the endothelial cells. Actual thrombotic microangiopathy may be involved. Virus directly cytopathic effects on the endothelial cells leading to the loss of the smooth endothelial covering. Complement activation mediated as well as cytokine mediated thrombosis may be involved. And again, if you look at the large cohorts, unlike in a lot of viral infections, thrombocytopenia, although can be seen, I would say it is not as common as other viral infections. In fact, you may actually have platelet activation in these cells, in these patients, leading to more of thrombophilic manifestations. So these are the autoimmune manifestations that have been seen, the MIS-C in children, the MIS-A in adults, the Guillain-Barré syndromes, the platelet-related thrombocytopenias. We can have an SLE-like manifestation along as with many other viral infections like EBV. Genetic variations, another important factor that may contribute to the pathogenesis of COVID-19. And along with all of these factors, the primary genetic factors that have been linked are related to ACE2 expression. Obviously, if there is higher ACE2 expression, you have greater viral pathogenic effects. Similar to what we have known that as the virus load is higher, the pathogenesis is higher. So if the ACE2 levels are higher, naturally the pathogenesis will be more severe. And all of these other genetic manifestations that have been identified, including interferon and ABO. It's very interesting. I don't know if you believe in the ABO association, but there have been studies that looked at ABO association, and it looks like type A blood individuals have a slightly higher risk of COVID-19 severity and susceptibility. So this is the title is missing, but this is primarily to indicate that HLH is another manifestation of COVID pathology, and that also can be triggered by activation of the pattern recognition receptors that we have seen. Finally, we move on to the last part, which is the pathology that we see in the COVID lung, and there are significant pathological changes that you see, which you don't expect that much with usual COVID and usual viral infections. I even have experience with a patient that we saw in the ICU, a very young lad, 18, 19-year-old kid, who came in with remote COVID infection and progressively getting worse, with shortness of breath, falling oxygen levels. And then the X-rays are showing almost near complete collapse of the lung. And over a period of a few days, they tried to put him on a ventilator, trying to get positive pressure ventilation. Ended up with barotrauma, pneumomediastinum, and over the next 2 months, this kid progressively got worse, and at the age of 19, ended up with a lung transplant. And what was most striking is that both lungs were just solid masses. No evidence of fibrosis anywhere in the lung. They were just solid masses, and it was so difficult to explain. How is it that the lungs are so collapsed and you're not able to get them open up? There is no significant pneumothorax. There is no significant fibrosis. Repeated CTs didn't show that. So something very, very unusual is happening. And now we have some pathology studies and also mass cytometry studies directly from autopsy lungs that give us a little bit of hint. For example, here you see significant fibrin deposition in the lung. You see significant fibroblast activation and collagen expression in the lung. You see a lot of immune cell infiltrates here, and it's primarily a lymphoplasmacytic infiltrate that you see, and also you can see thrombosis. So all the processes that we have discussed before are happening within the lung tissue itself, of which thrombosis is an important part. That plays a role in the pathogenesis. Apart from the lung, there is DVT that you can see. Patients can end up with peripheral vascular thrombosis leading to gangrene. You can also have neurological manifestations as a result of these thrombotic manifestations. The leading proposed mechanism, as I've mentioned, is still vascular endothelial dysfunction, hyperinflammation, and hypercoagulability. The other mechanism that was proposed earlier on, I didn't really catch a lot of attention from a lot of people, but still I believe there is still some sense in thinking about this. So we know that the renin-angiotensin system, ACE2 plays a significant role in converting the angiotensin 2 to angiotensin 7 and 9 amino acid breakdown products, which are more vasodilatory. So if you have low ACE2 levels, you have a more prothrombotic and vasoconstriction effect. So that makes very good sense in my mind. Okay. The immune abnormalities that you've seen in the lung that are correlated with a bad lung disease, and this comes from dysregulated myeloid cell compartments. And here you can see a study where CyTOF, single cell RNA sequencing, using two techniques, the 10x and the Rhapsody system, and flow cytometry were combined. So a multi-omics kind of a study, and these are more recent studies that have come out, giving us a better idea on what exactly is happening. And you can see that in the milder COVID lung patients, they have active CD14 monocytes, but when it comes to the severe disease, you have emergency myelopoiesis, you actually have neutrophils, a lot of netosis. You have early forms of neutrophils being pumped out of the bone marrow, and these neutrophils, usually neutrophils are helpful for us in protecting us. But when there is emergency myelopoiesis, this early neutrophils may even be immunosuppressive. So instead of protecting us, they are suppressing our own immune system and leading to worse lung disease. And also the monocytes are dysfunctional. They're not functioning properly with cytokine release or with proper antigen presentation. Single cell studies, and again, I won't go into details, but this is just to show that techniques have really helped us in understanding the pathogenesis of COVID-19, as with many other diseases. And in this single cell study, what was done is that lung tissues are broken down, and you can actually study what is happening within each single cell. And as you can read very easily, and I'm not going to go through each of these points, ACE2 expression, and this was what I was saying earlier, ACE2 expression is very closely correlated with the expression of the TMPRSS2 within cells, and you can very closely see that it is found in epithelial cells, it is found in the lining of bronchial cells, and that is why the lung is a primary target for SARS-CoV-2. This data comes from a meta-analysis of 31 lung studies. So it's a very large study looking at 31 studies, and this is what essentially they have found out. So the secretory molecules, the secretory cells, the multiciliated cells, the basal cells in the gut, these are the highest cells expressing ACE2 levels. In the lung, it is the 81, 82 cells, and also the bronchial lining cells that are the highest expressors of ACE2 levels, showing that they are susceptible for SARS-CoV-2. And there are also large atlases of COVID lung now available, and this is just an example to show you. And this is from a rapid autopsy program. Again, this just comes to Mohan and Kundamil sir. We were discussing yesterday how teams can come together and help us study. So this is a rapid autopsy program that was established in the US, in one of the sites in US. And all organs are rapidly collected and snap frozen, and single cell RNA sequencing is done on these samples. And what you see here is an atlas. Each cell can be mapped very closely because of these cells that have been identified. I'll skip this in the interest of time. I wanted to show you one. I don't think I have it. So I just wanted to show you that there were 35 different divisions within that university that came together for that particular study. There were 9 first authors in that paper, and there were 6 last authors who had equal contribution in that paper. So it just shows how collaboration helps to get you into a journal like Cell or Nature these days. And we really have the capacity, we have the numbers, we have the intellectual ability, but it just have to come together to do these kinds of studies. I think in the interest of time, I'll stop there. Thank you.
Thank you, Dr. Nijil, for the excellent discourse on immunology of COVID-19. On want of time, I think we will limit questions to 2. Okay.
That may be possibly due to an asymptomatic infection that he had prior.
That's possible. There are cross-reactive. That was one of the early theories. antigen mediated cytotoxicity, antigen-dependent enhancement, ADE is one of the early reasons for increased mortality in COVID-19. But I don't think that has really stood the test of time. Yes, we have had multiple other coronaviruses in the past, but these IgGs are more specific for SARS-CoV-2. So I'm not sure, is it because of early asymptomatic, because this was seen in very first phases of the pandemic itself. So unless we fail to recognize the pandemic before that. Yeah.
The cause of the lymphopenia and the increased neutrophils, neutrophil rise is just compensatory. Lymphopenia is due to the T cell activation.
So early on you see T lymphopenia and B lymphopenia because of direct viral invasion. Direct viral invasion and pyroptosis. The T cells die because of that. Sir.
If there's a thromboembolism in the US.
I don't think.
We have it at 3 months, and if they have a severe pulmonary embolism, we continue for another 1 or 2 months.
Yeah, I don't think unless it is driven primarily by the comorbidities and other history, I don't think for each individual patient you will have to individualize it. I think the 3 months would be the general one, but it's not applicable to all.
Yes, please.
See, the ACE receptor presence or expression is highest in both the lungs and the kidneys. Yes. But we don't see that much of involvement of the kidneys in COVID as much as the lung. Is there any reason for that?
So earlier on, I've read reports of renal involvement early on, and that was surprising to me because I was thinking, where is the exposure coming from? I think the reason why the lungs are involved is primarily because of the exposure, but of course through bacteremia, viremia, the virus can approach there. I also thought that earlier on the renal involvement is because of more because of either hypotension or mediated by medications. But now we know that direct viral invasion of tubular cells have been documented in autopsy studies. So direct viral involvement can be seen. Now, why is it not that commonly seen? Is it because of the level of expression of ACE2? Perhaps that is one of the reasons. Or is there the immune milieu within the kidneys? Maybe it is not as appropriate as in the lung and in the gut. Similarly, in the gut also, we see a lot of viral cytopathy within the gut as well. Yeah.
So just one thought process. You were saying about anti-MDFI similarities between COVID and anti-MDFI.
Right.
I think one of the connective tissue diseases with a lot of pneumothorax and pneumomediastinum is also MDFI. The pneumothoraxes and the pneumomediastinums, I think, is more common with the MDFI also.
That's correct.
So,
That's correct. Yeah.
So why wasn't immunomodulators other than steroids promoted in spite of it being a thought process of a vasculopathy or a vasculitis?
Yeah. So even in MDA5. It is a highly lethal disease, right? Even now with all the available treatment modalities, in some centers you see 50% or higher mortality for MDFI disease. So even in that disease, immunomodulators are not helpful. So this is purely based on our experience. So I think each disease is different.
Thank you.
I would like to acknowledge the contribution of Nikhil and Nisha. When we conducted webinars during the COVID time, we conducted 15 of them. They were very helpful. They came for some of the webinars. For many, they found us good contributors. So the Trivandrum Medical College Alumni Association would like to acknowledge their contribution during that time.
Thank you very much for the excellent session. Thank you.
We humbly request the chairperson, Dr. Aravind, to hand over our token of appreciation to Dr. Nigel Harun. Delegates, please note, a vehicle of number KL01BY5070 is parked in a way causing traffic inconvenience. We request the owner of the vehicle to remove the same. The number is KL01BY5070.
Now, we'll be having a session on aging rusty pipes, calcium score lipids, and heart diseases. We invite Professor Dr. Venugopal K to chair the session.
Good afternoon to you all. I would like to thank the Alumni Association for having given me this chance to chair this session. There are two functions of the chairperson. One is a more pleasant job of introducing the speaker. The other is to introduce a subject. I'll just touch upon the subject and then go to that more pleasant job subsequently. Doctor, we have atherosclerotic cardiovascular disease or any vascular disease is probably just because the COVID came, the importance of this vascular disease came down a little. But still, it is the leading cause of death all over the world. And we need to understand the pathophysiology and the treatment modalities that are emerging in this field, especially because you find a lot of youngsters suddenly passing away during their gym or their public performances. All this is now generating a lot of interest. So we need to understand the basic mechanisms of why all this is happening and how we can prevent. The next part of this thing is to introduce Dr. Najib, who has been my student for the last 30 years probably. We started together in Alleppey. Then we belonged to the same alumni of the Sri Chitra Institute. I was the second batch. Najib came much later. And the third interesting thing about Najib and me is that we both took the fellowship of the American College of Cardiology, standing next to each other in 2008, 2009. So there are a lot of personal interactions between me and Najib. And he's one of the brightest postgraduates I've ever come across. Not only bright, but he is also an inquisitive nature. The moment you finish a presentation, you find Najib getting up and asking some questions, some of the which as a speaker you may find it difficult to answer. The only other person whom I can compare here is Dr. Thomas Titus. So I think with this introduction, I would now invite Dr. Najib. You can just see his credentials here, and he is currently in Cleveland Clinic looking after the director. He basically switched from clinical cardiology to electrophysiology, and that is his passion. So with all this introduction, let me invite Dr. Najib for your presentation. I'm sure it will be eye-opener. Thank you, Najib.
Thank you very much, sir. You actually really introduced me to cardiology, as you really said. We remember the times that we spent in the ICU of Alleppey Medical College. Thankful for holding my hand in this wonderful field, and thank you for the Trivandrum Medical College Alumni Association. We started thrombolytic therapy here back in 1988. It's a long story at that time. 86 good, and that's the project that we started. It's a long story. Shiva knows it very well. It is always, such a proud moment for me to come back to this august audience. I thank the Alumni Association, Dr. John Panikar, Vasudevan sir, for inviting me and giving this opportunity. So we are talking about this aging rusty pipes. So this is the pipe supply, the plumbing work. We may think that of a third world country, but no. This is actually in Detroit, Michigan, in actually United States. It was a huge controversy how the lead leached into the water and caused problems for lead poisoning in the young people there. This is not too far away. The recent controversy that happened there. Exactly similar kind of thing can happen to our blood vessels. And this is a badly atherosclerotic aorta, as you see. So atherosclerosis is really bad. It can affect all vascular bed of the coronary arteries, of the cerebral arteries, peripheral vasculature. It can affect the aortic valve. It can cause aortic stenosis. So all these things can lead on to a huge disease burden. So as any case, we will start with a classic patient of atherosclerotic vascular disease, past middle age, multiple risk factors presenting with angina and claudication, and got all the classic risk factors, and he cannot tolerate statin because of terrible muscle pains. Physical examination was classic of multiple bruits and diminished pulses. ECG and echo are unremarkable. Lo and behold, the primary care physician has already done a calcium score for this patient. We'll talk whether it is appropriate or not, but he comes with this heavy calcification in the coronary arteries. You can see that this is the left main stem, and this is circumflex, this is the left-handed descending artery, and this orange structure, of course, is the vertebra, and here the densities looks like exactly the same because of the calcium deposition, and the calcium score, if you calculate here, come to close to around 3,000, really high. So, and this was a CT angiogram of the neck vessels. You can see that left common carotid almost completely occluded there, left vertebral occluded there, there is subclavian stenosis, and also right internal carotid has got occlusion there. So it's just basically the circle of Willis is maintained mainly by that one vertebral artery. And this is his peripheral vasculature, and you can see that bifurcation disease and the SFA stenosis, and you can see that almost coming on to Lerish. And this is, of course, in a money shot, you can see a pinhole meatus of the left main stem coronary artery. So this is the classic situation of atherosclerosis. So there is an oxymoron in my heading saying aging rusty pipes. So this is the data from Korean War veterans in the 50s, the autopsy series, with a mean age of 22 years. And you have got more than 3/4 of them has significant atherosclerotic vascular disease in the coronary arteries. And we know that it is an age-old disease. It's very, very old. And these two guys, Virchow and Rokitansky, quarreled quite a bit how and why atherosclerosis occurs, inflammations versus degeneration. Now we know it is mainly inflammation with the lipids playing a very central role. That picture that is shown here is actually a specimen from Rokitansky from the 19th century. They have stained and shown that it is actually inflammatory mediated by immune histochemical stains. So it's a major healthcare burden. Long-term decline in ASCVD has been happening in the Western countries that are stalled. By 2035, half the people will have ASCVD and north of $1 trillion. But more importantly for us, over 80% of the global CVD burden happens in low and middle income countries. This is what, again, yesterday we were sitting around in a round table and talking with Mohan and Sir and the rest of the people. What are the opportunities for research? We have a plenty of opportunity in our population to do this kind of research and find out what exactly make us tick with coronary disease. The management, of course, the lifestyle change is the foundation. Lipid lowering is the cornerstone, along with management of 3 other main risk factors: smoking, hypertension, and diabetes mellitus. So still, I will just focus on lipids. We know the other risk factors and the focus of the day. We moved away from the cholesterol numbers to intensity of statin therapy in 2013 ACCHA guideline, and that has been modified in 2018 and just 2 days ago. The United States Preventive Task Force recommendation just came out day before yesterday. Similarly, it is a little bit, I don't want to go into controversies, but similar. The recommendation is similar. Intimidating picture, but we will just dump it down to 4 statin benefit groups. Number 1, individuals with clinical atherosclerotic cardiovascular disease. They need high-intensity statin therapy, no question. So if somebody has an established disease, high-intensity statin. Number 2, if they don't have ASCVD, then you look at the primary target. That is a bad cholesterol, the LDL. If it is more than or equal to 190, high-intensity statin. If these 2 things are not there, and the person is above 40 and below 75 years of age, then you see whether the person is a diabetic. And the LDL is, is at least modestly elevated above 70, then that person needs statin therapy. And last group is a number 4. That is where you don't have any of the first 3. Then you whip up your smartphone and take this app, the ASCVD Risk Calculator app. You will get it in any of your smartphones and plug in the numbers. The age, sex, and all the risk factors, blood pressure, cholesterol, history of diabetes, history of smoking, and you churn out a number. And that number in this case is 7.6%. As per the current guideline recommendation, with some changes which has been introduced by the USPSTF, I won't go into that. More than 7.5, you should start the patient on a statin, but with a detailed discussion with the patient what you are going to embark on. because mind you, this is going to be a lifelong treatment that you are going to give. This is not a 2-week therapy that you give and then be done with. So the potential risk reduction you have to discuss in detail. We have to talk about what are the side effects that could be there. Other risk factor management is very, very important. You utilize that time to establish a relation with the patient and explain all those things. And still, the decision is not very clear. Then you have other means like calcium score or high sensitivity CRP or angle Beckel index or carotid intermedial thickness. All these things you can utilize if the person's risk profile is just below 7.5. You don't know whether to start statin. You do bring in all the other things into the picture, including family history, and then make a decision in discussion with the patient whether he should be put on a long-term statin therapy or not. So the calcium score is a very objective thing in this tool. We can really know anatomically what is happening. So it should not be done for a 28-year-old female coming to you with a chest pain. There is no point in doing a calcium score. And absolutely there is no point in doing calcium score in the patient I told you. Is multiple risk factors, classic symptom, there is no point in doing calcium score. So you should do calcium score in people who are intermediate risk, you're not very sure, and then you can start the patient on appropriate lipid lowering therapy. And the gradation of calcium score will be, 0 is normal. Of course, below 100 is low risk. 100 to 400 is moderate. Above 400, there is a risk of significant atherosclerotic vascular disease in that person, and you have to be more aggressive with them. Now, take a calcium score separately from the conventional risk factors. So you take about this, again, 65-year-old man who has got a high calcium score but no risk factors. On the other hand, you have got another 65-year-old man who has got multiple risk factors but 0 calcium score. How are they going to fare? And this was actually done as a population study from UCLA, Budoff and all. The basic takeaway is that if the individual has got high calcium score, more than 400, and no risk factors, they had a substantially more mortality rate compared to those with more than 2 risk factors and 0 calcium score. So if you have got risk factors and calcium score, that is the worst. But if you are asking about calcium score versus risk factors, probably no calcium is probably the better indicator. So we have to probably move away from the traditional risk assessment of multiple risk factors alone, but not totally, but this is a one good thought. For example, somebody is coming to you, multiple risk factors, I don't want any statin, so you recommend them based on the pooled cohort equation. But if the person doesn't want it, you can do a calcium score. If it is a middle-aged person and 0 calcium, probably, he may not have very additional benefit from it if the person doesn't want to take statins. So the medications, starting from over 30 years, we have various statins showing benefits. And also statins have shown to be anti-inflammatory by showing benefits in patients with the elevated C-reactive protein. And ezetimibe and hypertriglyceridemia with icosapent and ethyl. And this is a new enzymatic preparation that is bempedoic acid. This is an enzyme, ATP citrate lyase that upstream to the HMG coenzyme A reductase, that is actually statins. All these are newer medications that will help us reduce cholesterol. But whether we have outcome benefit, that is an important question that we have now with ezetimibe only after almost 30 years of no statin, other than statin, we didn't have any other medications actually. So anti-inflammatory drug, canakinumab, is another one that has shown to have some improvement, but it is not being used clinically. I'm just mentioning this because there's a lot of discussion about chelation therapy. I'm just mentioning there is no guideline recommendation for chelation therapy. It has shown some benefit in patients who are diabetic with the prior myocardial infarction, but ACC/AHA has not taken any position. There is a TAG2 trial is going on. Once the results out, only something will be told about that. The most important development that has happened in the past decade in clinical practice of lipid management is PCSK9 inhibitors. This monoclonal antibody, that is Paul Ehrlich, who got the Nobel Prize for immunology. We are talking about immunology here, so you can see on the left-hand side, LDL receptors on the surface of hepatocytes. They actually get degraded by the PCSK9 enzyme. LDL cannot enter, cholesterol goes up, and you inhibit that enzyme, everything looks very good. Excellent results by Fourier trial, that is Evolocumab, Repatha, it is available in India also now. Alirocumab, both these things reduce cholesterol very significantly, and also it reduces outcomes. This is a newer one. This is lipase inhibition, angiopoietin-like 3 factor. So that is called evinacumab. And these trials have now focused on to the real villain in atherosclerotic vascular disease, that is Lp(a). So Lp(a) is the cornerstone and it's a real villain in multiple pathways through thrombogenesis and atherogenesis. It is a very, very highly atherogenetic lipoprotein. It's an LDL moiety attached to ApoA to a disulfide link. Both Repatha and Alirocumab, the PCSK9 inhibitors, reduce the levels of Lp(a), and through which it reduces the outcomes. It is very important for South Asians like us. So there is a lot of trials going on with the nice names like Masala, Sathi, Sath. Why in Asians there is increased risk of atherosclerotic vascular disease in the heart trial by Salim Yusuf, and it was known for a long time from Dr. Inas from 1992. And now ACCHA has come out with a position statement over the couple of years ago, what are the risk factors and how to deal with atherosclerotic risk, especially high in South Asians. And again, focus turns around ApoA. So ApoA, the importance of ApoA is that it is not changed much by our lifestyle, exercise, diet, or nothing. It is closely linked to our genes. So that is the most important thing in the lipid management currently. So the Lpa, the high Lpa, South Asians in many studies have shown have relatively higher Lpa levels compared to the rest of the population. And there are some controversies regarding that. Some people say no. But by and large, the majority opinion is that Lpa is actually probably higher in South Asian population, and which is actually through which it mediates our unique susceptibility to atherosclerotic vascular disease. So this genetic variant study clearly showed that Lpa variants are associated with the high Lp(a), and that increases the risk of coronary disease. This is where youngsters, you are at the beginning of a dawn of a new era here. And I really envy you how you will be practicing medicine coming into the next decade of cardiovascular disease. So this is in 1998, Craig Mello from University of Massachusetts and Andrew Fire from Stanford discovered the short interfering RNA, and they got the Nobel Prize in 2006 for that. And that is already now we have, I used it over the last 3 months, I am using this drug, inclisiran. This is a short interfering RNA which inhibits PCSK9 enzymes and durably reduces cholesterol level. You just one injection in 6 months. So it keeps the cholesterol down. This is another one. This is a different technology. This is an antisense oligonucleotide pelicarsen. This also reduces Lpa, selectively reduces Lpa. Inclisiran reduces LDL and Lpa, but this one reduces Lpa. So another one is olpasiran, another short interfering RNA molecule. It actually just published the phase 1 trial. Already Amgen has announced that phase 2 results are actually very, very promising. So it will soon will be going within a year or two for FDA approval for this one also. The other one from JAMA, that is just 2 months ago, single ascending dose study of short interfering RNA SLN360. So all these molecules can be very, very infrequently given. That's the importance of the compliance. And that is the importance for us because of the Lpa and the South Asian population. And this was actually the biggest of all, winning 2010, the gene editing CRISPR, Emmanuel Charpentier and Jennifer Doudna from UC Berkeley and also from Max Planck Institute in Germany. This is the first time 2 ladies are together getting Nobel Prize in Science for the first time. And this is huge. And the way we practice various diseases will change with this. And we are talking about a heart disease vaccine now. This was a Nature article as a rhetorical question they were asking. But soon, the CRISPR editing showed PCSK9 lowered cholesterol in primates, and now we are taking it in the patients in New Zealand. The study started last week. Even when we are actually flying this high, we have to come down also, like polypill. Actually, we try to use polypill modulating multiple risk factors. This is Dr. Salim Yusuf's study last year. And this polypill, that is initial was in the primary prevention. The secondary prevention study was published yesterday in New England Journal of Medicine, showing benefit in patients with prior myocardial infarction. So, in summary, atherosclerotic vascular disease is essentially an inflammatory disease. And the lifestyle change is the key. There is no getting away from it. So, you are not going to sit in your couch and get some vaccine and escape from it. So, statins are the mainstay, and other agents, PCSK9 is already here, and spectacular genetic manipulations are already emerging, especially targeting LPA. Comprehensive approach is exceedingly important. I will just come back to our patient finally. So this patient, of course, was a very high risk for surgery. He had a balloon and stent into the mainstem, and he's on PCSK9 inhibitors, and he's doing quite well without any stroke or anything, and that one vessel is taking care of his cerebral circulation as well as peripheral vasculature, no problems in 3 years, doing very well. Thank you so much for the opportunity. Thank you very much, sir.
Thank you, Najib, for an excellent presentation and taking us through the various therapeutic options that are available to us now. Earlier, with dyslipidemias, we only had statins, and we never identified even though we identified lipoprotein little a. I think the first time I started hearing about lipoprotein little a was when Dr. Enas came down. The first study that Enas presented, where he showed that the South Asians in the US had a much higher prevalence of coronary artery disease. And that paved the way for this thing. And then he clearly said that lipoprotein little a was the villain. But unfortunately, we never had any drugs specifically targeting lipoprotein little a, and we are only targeting with statins. So I think these are all new developments. The other thing, what you said, is the vaccine. Probably if you can develop a vaccine, that may also go a long way to prevent. What we need to understand is prevention and not treatment is the way forward. Correct. For atherosclerotic vascular disease. There is no other way. I think any questions from the audience, any comments or questions from the audience? Titus?
No. You are right, sir. The ratio of ApoB and ApoAI, that is the ratio. And ApoA in itself is also a strongly atherogenic if you look at the molecular mechanisms, how it acts. It's a clinical association of ApoB and ApoAI ratio that is important. But if you mechanistically, if you look at it, it's ApoA is very, very important. And the vaccine, it's not actually a vaccine. This is just once in a lifetime infusion of CRISPR. That once in a lifetime infusion will actually fix the cholesterol levels. So that's what Shekhar Kadiresan, actually the Verve Therapeutics CEO, he was a cardiologist, Mass General, is proposing. It is why I said this thing, and even though it looks very high funda for us, if we can bring it actually, if we look at the compliance, our population, if you can think about something that we can affordable and give it to the population just once, and it will be huge. So that is where we want our youngsters molecular mechanism to develop, and then we can give it in a affordable fashion to all of us. We start looking, this is one very important question that you're asking, because standardization is extremely important. That is one of the problems that we have here. So I ask all the biochemists here, including my sister, maybe, they should all standardize how you measure LPA. Routinely, it is not measured in the US now. It is almost routinely, at least in the younger people, we do measure LPA routinely. The reason, as I said, there was nothing to do. What do you do after looking at it? There is nothing to do. But now we have. Now, and things will be changing, very dramatically changing.
I think the last comment, yes.
So just one question. Thank you, sir, for that
Yeah.
talk. We are prescribing, a lot of doctors, including me, are prescribing vitamin D left and right without even checking the vitamin D levels. So are
No data for no, absolutely no data. Absolutely no data.
No data that they prospect.
No,
Thank you.
nothing.
Excellent presentation. Thank you very much.
Yeah.
Now my question is that you said on statin therapy is started. It is permanent and lifelong. Suppose I take statin when my cholesterol is 260 or so, and during a course of time, maybe after 6 months, it's coming down to 190, 140. And I what do you think of stopping?
No, the one thing, nothing is written in stone here. I mean, well, statin is meant to be long term, that's correct. But if it is bothering you so much, we can cut back on the dose. We can change it into another statin and then see if it is relieving your symptoms. But the other thing is more important. You are not going to reduce the statin just because your cholesterol dropped. You should not. You should keep on it. And the idea is actually for long term. Keeping cholesterol down for a few months is not going to change your atherosclerotic profile at all. So keep on it. That is what actually 2013 changed. That's why I said we are not looking at the numbers, we are looking at the intensity of statin therapy. That has to be very clear. That is what the task force, that is what they're promoting, is that use intensity of either high intensity or moderate intensity statin. Use that initial, that 4 group I said to start the therapy and then maintain it. Depending upon the patient's tolerability, you may want to change it. That's a different thing, but not based on the cholesterol numbers. You want to, if at all, there are other guidelines to go more higher, adding other things, like all the things I said, but nothing to just pull back on the statin just based on the numbers alone. But based on symptom, you might do. Side effect, you may do. But other than that, just keep on it. That's what it is, yeah.
Lastly, I am a surgeon, but I have seen that mostly we are blaming cholesterol unnecessarily. It is an essential brick of the bodybuilders. And when is the fact that 20% of only diet contributes? The rest is manufactured in liver. So what about all the diet restrictions?
It's a big topic to talk about it. I know where it is coming from, especially the egg controversy and all. But it is very important. One thing I will just tell you: excessive cholesterol. Taking an egg a day, including yolk, it's not a problem. It's not a problem. But the thing is, excessive, it is a problem, and calories are more of a problem.
Exactly.
If you have higher calorie, that will get converted. So the egg controversy, I will just tell this much. If you take an egg a day, that's fine, but don't keep on eating egg. It is bad if you are going to take the egg yolk. Egg white, any amount you can take, no problem. Any amount of egg white you can take, no problems.
Good luck.
I just needed to say that just before concluding, the last sentence is all that Najib talked. I think Sri Shiva Shankaran will agree with me that the target population who should look at is from the age 25 to 35. Because there is no point the older age group going after all this. This is for the younger generation, because if you want to prevent cardiovascular disease or any vascular disease, you please start. Have your lipids checked, your blood pressure checked, and your lifestyle change from the age of 25. Not at the age of 45, 50. You look at Dr. Shiva Shankaran.
Exactly. We missed this talk yesterday.
No, that's true. No, I'm giving a general advice, because we always look at people who come with a established vascular disease. We need to change our ideas. We need to go back earlier and start preventing earlier.
Yeah, exactly.
I have one question. So, Dr. Najib, you said we are moving away from the treat to target approach in terms of LDL numbers. Can it be applied to patients with diabetes? Because our endocrine guidelines still...
That's precisely, and I forgot that Nisha is here. So endocrine guidelines actually are more stricter. So they want it really low. I mean, the multiple high-risk patients, they want the LDL to be below 55. So what I meant to say was, we did not have, what will you give? If you give 80 milligram atorvastatin and still your LDL is high, previously, in 2013, we did not have. Now we have PCSK9. If it is above 70, you give PCSK9 to bring it below 70. For that, it is useful. So use the number to drive it down further. Don't use the number to release the, take off the pedal. That you don't do it. So if it is a high-risk person, use that actually to intensify a lipid-lowering therapy with the ones that that outcomes are changed. The ones that we know are actually the ones I mentioned about. Now, basically, it is LDL reduction by statins plus PCSK9 and little bit maybe ezetimibe and maybe icosapent and DTL. But the big ticket items are these two. And endocrinologists are, it's exceedingly important in diabetics and those with CKD and PAD. Yeah.
The last sentence is the Lipid Association of India. For the Lipid Association of India, the target LDL for high risk, extremely high risk patients is 30 milligram of LDL. It is far lower than what the Americans have said. Correct. So I just wanted to conclude with that. Thank you, Najib, for an excellent session. We all enjoyed it. Thank you.
Thank you. Thank you. I mentioned, yeah. Yeah, yes, yes. Nextly told, yes.
We request the chairperson to hand over the certificate of appreciation to the speaker, Dr. Najib Usman. We request Dr. Matthew Thomas to hand over a certificate of appreciation to the chairperson, Dr. Venugopal K.
Delegates, please note the following vehicles are causing inconvenience to traffic: KL01CU 9766, KL01BJ 2153, KL82 2030, KL01CT 6850, KL01AU 7840.
We are moving on to the next session, Professor Roy Charlie oration. The Professor Roy Charlie Award has been conferred to Professor Thomas Matthew.
What does Professor Roy Charlie mean to Government Medical College Trivandrum? He was an alumni of this. He was an alumni of this college. In fact, when we talked today morning to Professor Pichumani, who is delivering his lecture tomorrow, he was very emotional. He said, because he is coming on Zoom. So he said he very much wanted to come for this convention because Professor Roy Charlie was his roommate. So that is the amount of emotions. That's a degree of emotion Professor Roy Charlie has among his friends and colleagues. Second, our institutions, he was instrumental in having the first renal transplantation along with our orator, Professor Thomas Matthew, in 1986. Later, when we started renal transplant in Trivandrum, for the first 5 cases, he was here to mentor our professors to do that. So that is the amount of involvement Professor Roy Charlie has regarding government medical. And later in 2016, when we conducted an updates in transplantation along with our annual convention, he was very happy to come over and talk to us about outcomes of renal transplantation in various centers. So he compared the outcomes in various centers and gave us an excellent thing. And 2 years ago, he came and received the Distinguished Alumni Award. So that was he was always happy to come back to his alma mater. And so today we are now here to hear his oration in his name.
We invite the Vice Chancellor, Dr. Mohanan Kundumal, Dr. M.K.C. Nair, the chairpersons, Professor Kashi Vishweshwaran and Professor Kim J. Maman onto the dais. We also request Dr. Thomas Matthew to come onto the stage. We humbly request Dr. Mohanan Kundumal to adorn the medallion on Dr. Thomas Matthew. We request Dr. MKC Nair to present the scroll. We now invite the chairpersons, Dr. Kashi Vishweshwaran and Dr. Kim J. Maman, to take the stage. Thank you.
Good afternoon. The memory of Dr. Roy Chally brings in very nostalgic memories, because in the early 1998, when we started transplantation first in Kerala, in Trivandrum Medical College, he was the one who came and mentored and then started the transplantation with his students, who were by the time professors of nephrology, professors of urology. He had been here for about, he used to come on his own even after his retirement, and he refused to take any travel expenses or anything. He just came on his own, and those days we were only having the two types of cars, Ambassador and Fiat, and he used to come in his Ford, driving all the way night, and then he would come and do the transplantation and with a smiling face say, get back. I can never forget his smiling face and his interaction with all the juniors. Professor Roy Chally was born in 1937, I believe in Malaysia. Then he migrated and he did his schooling in Mulanturuthi near Ernakulam, did his MBBS from here 1960, MS also from here, and then MCH Urology in 1968 from All India Institute. I remember him as an undergraduate student for a short while, a few months he was in Kottayam, then he moved over to Calicut, set up the department, which has now become a very important department of urology in Calicut. He was later on in Baby Memorial Hospital, and I feel jealous of Thomas Matthew because he had such an excellent urologist to work with. And Dr. Thomas Matthew, a near senior to me in medical college, he is now senior consultant in nephrology in Baby Memorial, formerly founder and head of the department of nephrology in Medical College Calicut, superintendent of Medical College Calicut. He is awarded a number of fellowships, as you can see from the slide here, FISN, FRCP, and Academic Excellence Award, Best Doctor Award of Kerala. In addition to that, he is a very good speaker, and the topic that he has chosen for this oration is the other side of kidney disease. We know only one side of the kidney disease, that is developing acute nephritis, acute renal failure, and recovering, or chronic kidney disease, going on to dialysis or transplantation. And knowing him very well over the last so many years, we don't know what he is going to really talk about. He is going to talk something surprising, and I would hand over to Kim for a few words. After that, Thomas Matthew will surprise us with this talk. Thank you.
Just a word about Professor Roy Chally. He was my examiner for MCH. And again, when he was president of the Urology Society of India, I was the secretary of the Society of India. I have learned so many things from him. And he has also come and visited me at my institution at Ludhiana. He is one of the greatest teachers this country has seen in urology. And apart from being a good surgeon, a very versatile craftsman, he has also trained so many urologists in Calicut who are adorned good positions all over the country. So he is a teacher of teachers. Coming to Professor Thomas Matthew, he has been trained at PGI, and I think he is the first DM from PGI trained by Professor Chugh. And he is one of the persons who was instrumental in starting renal transplantation along with Professor Roy Chally at Calicut. And Dr. Thomas Matthew is one of the renowned nephrologists in our country. And I've had a special relationship with him because his brother, Dr. Abraham Thomas, who is a plastic surgeon, internationally known plastic surgeon, was my mentor, and I had worked with him. And I have met numerous occasions to meet and interact with Dr. Thomas Matthew. Over to Dr. Thomas Matthew, looking forward to a very brilliant oration.
Thank you. Respected chairpersons, my real colleagues, Dr. Kashi, Dr. Kim, the distinguished guests in the audience, friends. I consider it a privilege and a great honor to have been given the position to do the first Roy Chali oration in this prestigious institution during the Platinum Jubilee celebration. I really thank Dr. Panikkar, Dr. Vasudevan, Dr. Indu for having selected me for this oration. You might wonder as to why I chose this subject of the other side of renal disease. I know this crowd hardly one nephrologist, Dr. Kashi, because speaking about nephrology will go above our head, and you won't appreciate what the intricacies of nephrology if I speak. So I thought I'll talk in general what I have learned in nephrology over the last 50 years in dealing patients. You are doctors, you have ENT specialists, you have cardiologists, you have orthopedicians, you have gynecologists, but invariably you will be seeing patients having kidney disease. But how to look after them? Because it is our job that the kidney disease patients have to be looked after. Now 37% of the population have chronic kidney disease in our state. And the budding people, budding youngsters, more than 20% are diabetics. More than 16% are hypertensive. Invariably, after 10, 15 years, they are all going to have chronic kidney disease. So we should know the other side of chronic kidney disease. I bring you greetings from Calicut. You know, Calicut is, can you switch off the lights, please? Calicut is a city, beautiful, full of halwas and full of biryani. Anybody who has come to Calicut will want to come to Calicut again and again because of biryani. And you have beautiful, the urus built in Bepur, which is exported to the Middle East for the sheikhs to use. So the Calicut has been time immemorial a great city of Kerala, and we are happy we are able to work in this institution with Professor Roy Chali. Now, Professor Roy Chali, as already mentioned, was a legend. He was a gentle giant in the field of urology. As we heard, his basic education was in Malaysia, his parents were there, and then he went on to become tutor in surgery, then assistant professor of surgery, then assistant professor of urology, and developed a department of urology, and retired in 1992. And from 1992 onwards, for almost 32 years, he was working in a private hospital in Calicut. I have retired in 1997, and till the last day of his death, I was along with him. He was my close friend and benefactor, as well as a guide in how to organize a department and how to organize various things in the department. So Calicut Medical College is proud to be the first institution to have renal transplantation, the first center to have renal transplantation, and the first center to have a large dialysis setup for the first time in Kerala state. And Professor Roy Chali developed a full-fledged department of urology and started the postgraduate course in urology, and first transplant, as I mentioned, and outstanding teacher, and he was the last word in urology in our state for a long time. And his hands were like God's own hands, just like we call God's own country. Dr. Roy Chali's hand, the moment he touches the patient becomes, he is better. So that was his reputation in Calicut, in Malabar. Now from Calicut Medical College, we started, along with Dr. Roy Chali's help, the full-fledged dialysis. We started with a very primitive dialysis machine as we got donated from the US. And then we went on to make newer and newer machines. And I am proud and happy to tell you that every nook and corner of our state now has dialysis facilities. Patients with kidney disease don't have to go to Chennai or Madurai or any other place for any treatment. They are available in our own state because of the initial effort which we all have put in. Dr. Kashi has put in his effort in Kottayam and Trivandrum. The people have been there, and we have done lot of work on this so that every nook and corner, a patient with chronic kidney disease gets treatment which started from Calicut. I'm proud to say that. So likewise, the transplantation has gone right from Calicut in 1985, and now everybody does transplant. Every institution has got transplant, and now we are going to do the transplant across ABO barrier. Now, the Professor Roy Chali has to be mentioned again because this is his oration. He has had many orations, including Dr. Raghavachari oration, many awards as eminent doctor of Kerala State, Urology Gold Medal, and so Urology Society's award, and he was examiner in MCH. So suddenly he passed away in 14th of May 2022. May his soul rest in peace, and his legacy let it continue. Now the kidneys are very important organs. I will say it's amazing organs of the body, amazing organs. And it has got very many functions, as we all know, we teach in physiology. And I want to mention to you two things. One is the clotho-protein. Clotho-protein, I will come to that later. For longevity, long life, clotho-protein has to be done. If the kidneys are damaged, the life is shortened. And then the renal tubules. Renal tubules are fantastic, and which we do not know much. You know, Clotho is a goddess. There are 3 goddesses for life, who spins life as far as the Greek mythology is concerned. And Clotho is the person who will cut the life of the individual. The Greeks believed that Clotho will cut. So there is a protein in the kidney coming from the tubules, which is called the clotho-protein, and the protein will help to maintain the stability of the chromosomes so that the telomeres will not shorten fast. That's a new invention, and it has been found out. And then you have the tubules. The tubules of Henle. The tubules of Henle is fantastic, unimaginable functions. The descending limb, the loop, the ascending limb, with collecting all different functions, not yet fully known that whose functions are there. And multiple functions because of the ability of the renal tubules. How God created the tubules, I do not know. Still we do not know the wonder happening in our kidneys every second of the body. How it is concentrating, how it is diluting. 180 liters of urine we would have passed if there were no tubules. 180 liters. Out of the 180 liters, all are reabsorbed, except 1.5 comes out of the urine. The fantastic tubules to be remembered. And now we find that the tubules are made use in the treatment of diabetes. The latest drugs in diabetes, SGL2 receptor blocker, is acting on the tubules to send away all the glucose in the body out into the urine so that the diabetes become all right. Without giving a drug which will act on the insulin or the muscle or anything, this new drug, as we all know right now, dapagliflozin, will prevent the glucose from getting reabsorbed. So fantastic how the nature has been given us information as to how it has to be prevented from getting absorbed. So it's just like looking at the galaxy. The functions of the tubules are fantastic. So many things we do not know, yet more to come. Now, we all know that the serum creatinine is a very dangerous situation. But we should remember that serum creatinine remains normal till the glomerular filtration rate comes to less than 50. So if a person's creatinine is 1.1, 1.2, doesn't mean that he is perfectly normal. He can still be having a chronic kidney disease. That has to be remembered. A creatinine of 1.5 is definitely more than 50% of kidney function lost situation. So patients coming to physicians for consultation from the surgery department saying that this creatinine is slightly high, you must see that if it is slightly high, it is very bad for the individual. The drug has to be monitored and his treatment schedule has to be monitored. So the kidney, as far as is concerned, aging takes place in the kidney as person ages. A person's age, suppose 75, his kidneys are also 75. Suppose the patient has got 20 years of diabetes, you have to add that 20 also. So his age will be 95 as far as the kidney is concerned. If they have got hypertension also, add those years also into the age of the individual. So it's another 20 years. That means more than 100 years for the kidney. The poor kidney is suffering because of diabetes and hypertension. So age is a very bad factor for the kidney. A person with 70 years having a creatinine of 1.7 doesn't mean that he has got a kidney disease, but his kidneys are aged. So you have to adjust the dose of many drugs. So it has to be remembered. So GFR in aging falls down as years go by. Glomerular filtration rate declines with age by approximately 1 ml per minute per square meter, beginning the third decade of life. At 70 years of age, the glomerular filtration is only 40, less than 40. So the kidney in aging becomes so much of structural, microscopic, as well as functional change. One should remember, it is not a disease. It is an effect of aging. It has to be remembered. Now, high creatinine is a problem now. Any patient comes to the hospital, sare, creatinine koodalana. This is what they say, creatinine koodalana. Creatinine can be high because of kidney disease, but without kidney disease. That you have to remember. High protein intake, that some people take 4 to 6 eggs a day, especially those people who go to the gym and bodybuilders, sportsmen. It produces high creatinine. Excess increase of cooked meat, red meat, and intense exercise. Drugs like cimetidine, very common drug. Trimethoprim, again a common drug. Then steroids, all these can increase the creatinine value without a renal disease. Creatinine production in the body is high, so that's not completely removed. And of course, it interferes with lab tests, presence of chromogen in blood like acetone, acetaldehyde, fasting lipemia, hemolysis, all will increase the creatinine. Another important problem with the patients now is microalbumin. They'll say, microalbumin is there. Lab will test and will say microalbumin. It is a forerunner of kidney disease, forerunner of cerebrovascular disease, but without that, microalbumin can also occur. And obesity can produce microalbuminuria. Metabolic syndrome, hypertension, orthostatic proteinuria, all this can lead on and start with the microalbuminuria. But it's a risk for cardiovascular morbidity and renal disease. It indicates pre-diabetic states and predicts an acute respiratory failure in multi-organ failure and overall morbidity in patients in ICU. The ICU patient develops microproteinuria. It predicts that he can go into complete cardiac, renal, as well as respiratory failure. Frothy urine is again another very important problem, frothy urine. Frothy urine could be renal disease, might not be renal disease, but you have to be careful. But frothy urine can happen without kidney disease in a full bladder, and if the person voids very fast. A high-speed urine output will produce froth in the commode. And very concentrated urine also can produce froth. If there is a retrograde ejaculation, it can produce froth in the urine. Early onset of amyloidosis and intake of pyridium, intake of SGL2 receptor blocker. And it may be also a factor in the toilet. The toilet cleaning solution will have some soapy substance in that. If a person passes urine, always there will be froth in the urine. It's not renal disease. The cadmium toxicity, multiple myeloma, phospholipids, foam cells, and patients with cholestasis all can have froth in the urine. Now, another major problem which we are facing every day, every clinician, is obesity. Patient with obesity is a killer. Obesity is a silent killer like hypertension or diabetes. So 30% of the population are obese. It's a complex disease involving an excessive amount of body fat. It's a medical problem that increases the risk of other diseases and health problems in heart disease, diabetes, hypertension, dyslipidemia, certain cancers, metabolic syndrome, and even kidney disease. Body mass index, we all know. Body mass index is high. We have to tell the patient that they have to reduce their weight by diet as well as exercise. The best is to examine the circumference of the stomach at the level of the umbilicus. With more than 90 is bad for the male, and more than 80 is bad for the female. So that has to be remembered. Measurement of the neck is very, very important. The neck circumference is again a marker of chronic kidney disease, chronic liver disease, chronic heart disease. If it is more than 40 centimeters in an adult male or more than 30 in a female is a problem. So obesity is rampant in our population, rampant. And obesity produces so much complications. And the renal problem is very rampant, which we all know. Patients develop focal segmental sclerosis and glomerular sclerosis, and they die. So any patient, whether it's a orthopedic problem or a gynec, if they're obese, we have to tell them about their obesity and tell them that it's going to be dangerous as years go by. So in diabetes, in hypertension, 1 in 3 invariably will go into chronic kidney disease. So diabetes, as we all know, is again a silent killer. Invariably, it reduces the lifespan and produces a problem for all organs of the body, especially the kidneys, blood vessels, and the nervous system. Diet has been very bad in Kerala state of late. Very bad. Very bad in the sense they consume large calories of diet. They eat fish, they eat fish, they eat meat, they take so much of rice. Altogether, the major food item becomes carbohydrate. So because of that, everything goes up, like the lipoproteins, that the cholesterol, everything goes high, and the patient becomes obese, develops atherosclerosis, and the lifespan becomes less and less. So the important thing is to send the message of the food plate in diabetes. Food plate, we all know 50% of vegetables and 25% carbohydrate, 25% protein. This has to be remembered. For patients with diabetes, their blood pressure as well as the blood sugar has to be well controlled. Blood sugar fasting should be definitely less than 100, and the postprandial should be less than 160. BP should be controlled with 2, 3, 4 drugs. It should be less than 130/80. Lipids to be controlled. Uric acid level to be controlled. Patient with hypertension, again, irrespective of what specialty we practice, see that the BP is controlled definitely. Another important factor in chronic kidney disease, which is the other side of the kidney, is hyperuricemia. Very often forgotten, but of late it is given much importance. High uric acid is dangerous to the body, dangerous to the kidneys. So control the uric acid level by diet, protein restriction, exercise, and then give drugs if required. ICU care. Patients with ICU has been found that they invariably go into chronic kidney disease. Why? Because they all go into acute kidney injury, and acute kidney injury is a forerunner of chronic kidney disease. So any patient in ICU should be followed up very carefully so that they should not go into chronic kidney disease. Acute kidney injury to chronic kidney injury is a continuous process. It's a continuous process. You might leave the patient from the ICU, but you might not be following them. After 5, 6 years, they'll go to the nephrologist with CKD. So ICU care has to be very monitored. If there is a renal dysfunction, it has to be followed up. So acute kidney injury goes into chronic injury as a continuous process. So more than 1 in 7 individuals are having chronic kidney disease all over the world. Progresses. And 1 in 5 adults over the age of 65 has chronic kidney disease. And 2 in 5 people who are above the age of 75 also have chronic kidney disease. So the impact of chronic disease is very high, and more than 1 in 7, 1 in 10 people have chronic disease. Age, as already mentioned. Then, very important thing to understand now is that there's a mysterious disease going around all over the world. Mysterious disease. It is occurring in many parts of the world, which is unrelated to known factors like diabetes or hypertension. It affects the young people, middle-aged people living in the temperate climate and the tropical areas. In the tropical areas of the world, there's an unknown disease. It's called CKDU. And in mysterious disease, it's a threat to the health of our world. And it is called CKDU because there is no cause made out. And this kidney disease of unknown or uncertain cause affects the marginalized agricultural workers in US, in Africa, in India, in Ceylon. Well established. It occurs chiefly in Sri Lanka and in Central America. And throughout, the additional spots are there. And in America, it's called mesonephric nephropathy. And in Sri Lanka, it's called Sri Lankan nephropathy. And we have the disease in Tamil Nadu, in Telangana. It is called the Mesoamerican nephropathy. And in Telangana, you have the Sri Lankan nephropathy, then Uddanam nephropathy. We do not know the cause. The people working in farm lands, in agriculture workers, whether it's coming from water or some food item, we do not know. So Uddanam nephropathy. And you have Thodai Mandalam nephropathy near Pondicherry. So much of investigation is going on, but the cause is not known. But it could be environmental factors or it could be lifestyle factors, not yet decided. But should remember that newer and newer diseases are coming into our country. which we do not know why it is so, other than coronavirus. So unusual symptoms of kidney disease of unknown etiology doesn't have hypertension or diabetes. Young people become sick all on a sudden, and the whole family becomes abnormal. So you have the Meso-American nephropathy, you have the nephropathy in Egypt, you have it in African areas, and you have in India, in Punjab it is there, and you have in Sri Lanka, you have in Pondicherry as well as in Telangana. So nephrogenetics is a very important thing to remember. Genetics has become very important in nephrology now. Many diseases which run in family. About 30% of chronic kidney disease patients have a family history. So finding out is it genetic is very important in proper diagnosis and treatment. If it is found to be genetic, there's no need to give all these steroids and other materials. It wouldn't do any good. And if it is genetic, about transplantation, the donor of the same family member should not be a suitable candidate for the transplantation. So genetically, we know that IgA nephropathy, focal segmental sclerosis, steroid-resistant nephrotic syndrome, then Fabry's disease, Alport disease, membranous disease, membranous proliferative disease, all they have genetic background. And find out how its genetic background is. You can get it estimated by the genetic testing test. It's all available now in our market because we have RENA site, kidney gene panel is available, and we have med genome is available. It will tell whether the family member also has the same gene. Then becomes difficult to manage. But unnecessary treatment, unnecessary investigation, unnecessary biopsies can be avoided. So clinical benefits are there in genetic testing. That accurate diagnosis can be made, and proper treatment can be administered, and proper advice can be given to the family regarding the further management of the patient. So another important side speciality in kidney is onconephrology. Onconephrology has come, the kidney disease cancer-related as well as treatment-related. So an American Society of Onconephrology has already started last year. So it's a boon for patients with chronic kidney disease in diabetes, in cancer therapy as well as cancer treatment. So there are so many myths about kidney disease. One should know that myths about kidney disease. Kidney disease is a rare condition. It's not a rare condition. If you feel fine, there is no chance of your kidneys are diseased. No. Because up to 50% of kidney damage, no symptom will be there, no sign will be there. And testing kidney disease is a long and costly process. No. A simple urine examination is sufficient. If you are at risk of kidney disease, there's nothing you can do about it. That's again a false statement. You can definitely look after them. So like that, there are so many myths we should realize and understand. It's all we have learned during the last 50 years of day-to-day patient practice with in collaboration with the urology and nephrology and general physicians and the surgeons. Patients are high risk of kidney disease, above 65 years, obese patients, hypertensive. So there's a new era in chronic kidney disease management. Thank you very much for the patient listening.
We humbly request Dr. K.P. Haridas to present our certificate of appreciation to the chairpersons, Dr. Kashi Vishweshwaran and Dr. Kim J. Mama.
Yes, thank you, Matthew. You really showed the other side of kidney disease, renal disease in general. What I want to emphasize in particular, whatever he mentioned, is if you look at this hall, the front half of the hall is almost, or most of them, except the people sitting in the compere desk, are over 70, and the back hall is less than 20. Anyway, the point is that the dose of drugs that we are going to administer to elderly people must be nearly pediatric dose. The most of the problems that we've come across in the ICU is that old people are admitted and they are given the same dose as an adult. We are not adults. We are almost like children. So that is something that we have to remember. It's a practical point which he has highlighted. Thank you, Thomas Matthew, for a wonderful oration. As it's an oration, there are no questions allowed, and we close the session.
What picture we remember about Professor Roy Chally. We said about 5 cases he was here. Actually, the second case, when he was there, it was those were not it was a double vessel disease, double vessel kidney, and suddenly when it was harvested, it was double vessel. So Roy Charlie sir took the kidney, very calmly went, give me a place where I can work, and settled down to do brain surgery. When he reconnected the two vessels and went on as nothing unusual. That is the greatness of the man. No sign of tension. Very, very simple and quick and fast in his work.
We humbly request Dr. K.P. Haridas to present our certificate of appreciation to the chairpersons, Dr. Kashi Vishweshwaran and Dr. Kim J. Maman. The upcoming session is Dr. V.C. Matthew Roy's session, followed by discussion on medical management of obesity. The session will be chaired by Professor Dr. Aruna R. and Dr. Abhilash Nair. Inviting the chairpersons onto the dais.
Shall we start? Good afternoon and thank you. I am happy and honored to be chairing this session in memory of our beloved teacher, Dr. V.C. Matthew Roy. I belong to one of the last batches of students who were fortunate enough to be taught by him. He was a pioneer of sorts. He was first postgraduate in medicine from Trivandrum Medical College, the first person to start an endocrinology department, the first person to start a diabetic clinic, then first secretary of API Kerala chapter, and also he was the first one to really think about death auditing and presented a paper based on that. In addition to that, he was a ready reckoner. We could always ask him about rare disorders and syndromes and metabolic disorders. An astute clinician. I remember the evening rounds of Dr. Matthew Roy. People used to run to listen to that, and it would carry late into midnight. And it was full of information. And he's one person who was never biased. No gender bias, no bias. Whether it's an undergraduate or a postgraduate, MD medicine or DPNB medicine, medico or non-medico, he was always ready to teach with passion. He's a kind person and a great soul. So he was a benchmark for all the teachers in medicine all over the state, especially and also in Trivandrum Medical College. Coming to the topic today, it's of contemporary relevance, obesity. I'm here to chair a session. On in memory of my teacher, and the person who is speaking is my student. So I'm doubly happy, Nisha. Over to Abhilash for introducing Dr. Nisha.
Thank you, organizers, for inviting me. And actually, it's an honor to be part of this program. The session which I have been invited is also so apt because it is PC Matthew Roy sir who started the department and created a post of lecturer in endocrinology, which later became an assistant professor post, and I am currently working in that. I got employment because of him. And now, regarding the topic, we are all facing this problem of obesity, which how to manage it. It's a real headache for each and every physician, and especially for us in endocrinology. To discuss the topic, we have Dr. Nisha Nigil Haroon, who is an assistant professor of endocrinology at the Northern Ontario School of Medicine. She is a consultant of the Scientific Advisory Council, and she is the recipient of clinical research fellow. She is a clinical research fellow of Women's College Research Institute, Toronto, and recipient of the PSI Graham Farquharson Knowledge Translation Fellowship, and also received the Early Investigator Award in Bone Health from USA. And she has also been selected for the 18th Fellows Forum of Metabolic Bone Diseases in USA, and member of the Journal Editorial Board of International Diabetes and Technology. And she also is very active in social issues relating to our medical graduates living abroad. And she's the co-chair of the annual convention of the Association of Medical Graduates, chairperson of AKMG, and president of the Association of Medical Graduates of Kerala origin in Canada. She is a regular speaker for many of our endocrine conferences in India and in Kerala. And we have also heard her previously in the TMC Alumni Association meetings online during the COVID period. Thank you, ma'am. Please.
Yeah. Thank you very much, Dr. Abhilash and Dr. Aruna Madam, for the kind introduction. And I think Dr. Matthew Thomas left. He's really my mentor and guru in the field of endocrinology. And it is a great honor to be presenting Dr. Roy's oration. And I would like to also thank Dr. John Panikar sir, Vasudevan Poti sir, Indu madam, Lakshmi madam, and everybody from the organizing committee for all their dedication towards the Alumni Association activities. Okay, before we the timer is already running. Anyway, so can we get a show of hands, please? How many of you in the audience have prescribed a weight loss medication? Okay, so we really have, I really have some data to present. Then I think I just saw 4 or 5 hands. So moving on to the slides, most of what I'm presenting will be based on Obesity Canada guidelines. It's a very famous established guidelines endorsed by various endocrine organizations worldwide. So I'll stick to Obesity Canada guidelines, mostly evidence-based. And this is my disclosure. And objectives, so we still have barriers, and we did see my background slides. Actually, they were presented by Professor Thomas Matthew. He had, I guess, like 5 or 6 slides on obesity. So right now, we do have evidence-based therapeutics, so I'll be discussing those agents. And again, our current understanding is that obesity is a chronic, relapsing, multifactorial, and heterogeneous disease. So we'll come to the details of this. Heterogeneity, because we are seeing a heterogeneity in response to weight loss. No matter what intervention we do, this is still a challenge. And again, the cause is multifactorial, as in any disease. So genetic factors, environmental factors, so, and also adipogenic food, calorie-dense diet, which we already discussed this afternoon. Genetic factors, so now we do have a great understanding about the genetic factors. So let's stop blaming patients about their diet and lifestyle. There's more to this. It's not just diet alone, or it's not just exercise alone. And then there are complex neuropathological hormone interactions mediating this disease. So it's more than diet or exercise. And increasingly, a lot of our patients are on medications that can cause weight gain. So when you address treatment or precipitating factors, always look at various medications that can cause weight gain, including SSRIs and antipsychotics and even insulin or sulfonylurea. Looking at Indian data, there are some studies looking at very high prevalence, not surprisingly. Initial data showing that more obesity in urban and educated individuals, but there is this projection coming out, published in PLOS One, saying that the obesity prevalence is exponentially rising. It's another pandemic in the making, which is already happening, and prevalence is exponentially rising.
especially in rural residents and older older Indians, so given the lifespan extension. So, and we all know the metabolic and vascular complications of obesity, but this is one important aspect. There's a recent publication from 2022. Obesity has been attributed as a cause for preventable cancer. So if you look at smoking, alcohol, high BMI comes next, along with other occupational and environmental risk factors. But what are we doing in terms of managing this crisis? Often we ourselves are not educated or equipped. We don't have time to discuss the weight intervention. We just tell patients, go lose some weight, eat a healthy diet, and the conversation ends there. Several reasons, and sometimes we are also facing this crisis called therapeutic inertia. We don't discuss weight management with patients always. We have to come up with specific tailored weight management, and terminology also is very cautious because sometimes there's stigma and embarrassment from patient side. So we have to be cautious when discussing weight. And another crisis that we see is the significant amount of weight regain after any intervention. So I think Dr. Vinod Menon is going to talk about weight loss surgery. Again, I mentioned the barriers. We need to understand these things from patient perspective as well, and address the systemic barriers. Often we see patients are left to navigate a complex landscape of weight loss products and services. We traditionally tend to shy away from social media and are not influencers, but that space is taken up by all sorts of pseudoscience and other healthcare work, or I would say social media influencers, including celebrities, propagating misinformation towards weight loss interventions. And they are often dealt with unrealistic and unsustainable weight loss goals. Again, there is new interest on identifying subtypes of obesity. This is interesting based on the satiety studies, hunger studies, and also gastric emptying studies. So this is why we understand more why a subset of patients do not respond to any kind of intervention, or certain patients respond to only a certain type of intervention. So now we have the ability to understand that subtype classification. Again, treatment is based on medical nutrition therapy, which we are all familiar through guidelines and also through WhatsApp forwards, and then pharmacotherapy, surgery, and physical activity. So I'm going to skip this slide in the interest of time. So there's a lot of advocacy going on to educate physicians and empower them with tools to advocate towards weight loss management. Coming to treatment, we have two aspects of this, weight loss and weight loss maintenance. First part is easy, and we need to have targeted therapies and non-pharmacological interventions that can lead to long-term reduction in calorie intake and long-term adherence to a healthy eating pattern. Benefits in the diabetes world, even with weight loss, like even a 5% weight loss, you see a 0.5 reduction in A1C, 5 millimeter reduction in blood pressure, and improvement in lipid parameters. But if you look at, in general, up to 10% weight loss, we can prevent diabetes, prolong diabetes remission state, and also other metabolic parameters can be improved with weight loss. So cutoffs, we did discuss BMI just now, but remember, in South Asians, the cutoff is much lower. It's not 30, it's 27. And also, we have to look at waist circumference, because most of our patients are not obese. They are based on the BMI of 30. They are obese based on the BMI of 25 to 27 and about 27. So we have to look at different cutoffs. And waist circumference, make sure that we measure or encourage patients to check waist circumference at home so that we can follow these metrics. Now, looking at weight loss interventions, any intervention will work in combination, synergistically, so we have to have medication and lifestyle, plus combined intervention. We just need 5% for meaningful clinical outcomes, but up to 15 to 20% weight reduction can actually cause diabetes remission. Now we are talking about diabetes remission, not cure. So that is possible with the advancements in pharmacotherapy. So I'm going to skip this slide on medical nutrition therapy. Again, main problem is the maintenance of weight loss. So looking at pharmacotherapy, we now have a lot of agents that can alter the set point based on genetic and factors. So we can actually reset the set point. And with pharmacotherapy, patients are also able to adhere to lifestyle intervention. You tell an obese patient to go start a diet, it's not going to happen. They cannot exercise, they cannot walk. BMI is 40. So with pharmacotherapy, they have more energy. There is some weight loss happening. They're encouraged to do more exercise. And compliance with diet and physical activity will improve on pharmacotherapy. So that's an additional benefit. So these are the emerging agents. We are already using a couple of these agents in a big fashion, especially in North America. They are very popular weight loss agents now. There are other newer agents too. So I'm not going to the benefits. So we do have a better understanding of GLP-1 molecules as weight loss medications because they're very popular therapeutic options in diabetes. These are once weekly hormone injections being used very widely. I hardly prescribe insulin now. In fact, we are de-prescribing insulin because of the weight loss and glucose lowering effects of GLP-1 agents. And they have additional vascular protective effects on heart. This is independent of weight lowering and independent of glucose lowering. So you see direct effects on the heart. So, and this is the landscape of treatment of obesity drugs in the US. And we do see a specific drug called setmelanotide, which is for a genetic subvariant of obesity. That's an expensive modality. But in the general population, we are using liraglutide and semaglutide. It is a very popular option, and also naltrexone and bupropion, which is widely available here, I believe, bupropion. And then tirzepatide is a new kid on the block. So other agents in the pipeline, there are several agents being marketed. Obviously, almost 1 billion people in the planet are obese. So we do see a lot of money being pumped into obesity research these days. So I'm going to skip the comparative slides. So I'm going to specifically focus on GLP-1 agents. This is liraglutide or Saxenda, marketed as high-dose liraglutide, 3 milligram. Very potent once-daily medication for weight loss. We do see a good improvement in metabolic parameters, including fatty liver, histopathology resolution, and vascular benefits. But we do have better options now. Who wants to do a daily injection to lose weight? So we have a once-weekly GLP-1 agent, which is semaglutide, again, very popular drug in the diabetes world. The maximum dose is 1 milligram approved for diabetes management, but we are using a 2.4 milligram dose in another fancy name called Wegovy that's approved for weight loss in adults and also pediatric obesity. I think the age cutoff is 12. That's another emerging population crisis, pediatric obesity. So semaglutide once weekly, again, proven weight loss, and proportionately more patients are able to achieve that weight loss goals on semaglutide. And then there have been head-to-head trials comparing all these agents, and out of all the available GLP-1 agents now, semaglutide is more potent, and it's once weekly. Similar tolerability, of course, we often, and if we see patients having exaggerated GI side effects, often I send them for a GI evaluation. And this is not just the drug. Maybe they have hiatus hernia, maybe they have esophagitis. And sometimes a GI evaluation will certainly reassure, and then you can ask the patient to go back on the medication. Don't be discouraged with the GI side effects. Do slow titration. And once we do that, there is better GI tolerability to these medications. So again, all of these drugs have maximum efficacy when used in tandem with intensive behavioral therapy, and the adherence to intensive measures is more on treatment. So we do see combined effect. That's additive for sure. And this is the percentage change. And as I mentioned, proportionately more patients are able to lower the A1C, de-escalate treatment with other agents. I have a lot of patients on monotherapy with semaglutide, managing their diabetes and weight long-term. And we do have long-term safety data. And again, as additional benefit, we do see significant cardiovascular benefits from these agents, including liraglutide and semaglutide. There have been head-to-head trials across the board. We have dulaglutide and also another agent coming up soon. So these are the cardiovascular outcome trials, all showing tremendous cardiovascular risk lowering. This is in addition to other medications, including diabetes medications and statin. Again, another crisis is fatty liver and non-alcoholic fatty liver cirrhosis. So there is a significant histopathological resolution of pathology if initiated early, not when the patient is cirrhotic. So there are weight loss benefits and direct benefits of the drug on NASH. So practice points, liraglutide and semaglutide are currently the 2 GLP-1 agents approved, and higher dosing is needed for non-diabetic weight loss management. So of course, there is a higher incidence of GI side effect, which can be tackled easily with appropriate counseling. Now coming to the second popular agent, this is a therapeutic combination of naltrexone and bupropion. Again, works mainly in the central nervous system. I'm not going to the mechanism of action. Slow titration, again, start with 1 tablet, and then final dosing will be over 4 to 6 weeks. You can do a target dose of 2 tablets twice a day. Very efficient for weight loss, and especially when the patient also has mood disorder, perimenopausal women, postmenopausal women, this is a good option. And also for patients with eating disorder, binge eating, this is is indeed a good option as a weight loss option. And if we don't have the combination, we are also using these medications separately. So you prescribe bupropion separately and naltrexone, so that way the high cost can be mitigated. So that's one option. And again, significant amount of sustained weight loss. So this is trial data, but in real world, we do see more weight loss and good appetite suppression as well. One thing we are also trying to understand is that whether you do GLP-1 treatment for 1 or 2 years, patient cannot afford, or patient has achieved a lot of weight loss, and how do we maintain that? Maybe use one of these agents, maybe 1 or 2 tablets of bupropion naltrexone combination. So this is something we are trying to understand whether that will work long term. A lot of our patients are on SSRIs and other mood pills anyway, so this might be a combination. A sequential treatment is something that we are interested and we are now looking at. And bupropion definitely has a propensity to cause seizures, so we have to look for drug interactions, and also contraindicated when the patient is on opioids. So again, generally good tolerability from real world experience. Mostly patients are able to tolerate these drugs, and also with the weight loss, we can lower the burden of polypharmacy. So that is trial data, again, particularly important in patients with binge eating and other, as I mentioned earlier, there are some subtypes of obesity patients who might particularly benefit from these sort of selective interventions. Another new drug is a once-weekly human amylin analog. This has now been studied in combination with semaglutide, again, once-weekly intervention, so multimodal approach using 2 therapeutic agents once a week. Again, really good. And interestingly, even though the GLP-1 dose is higher, GI tolerability is pretty much comparable, so that's encouraging. We do expect that, when the dose is higher, maybe there's more GI side effect, but that's not the case. The good GI tolerability or stable, depending on how well you titrate it. And then tirzepatide is the latest drug. I think we're going to start using this drug from next year. Double weight loss and double A1C lowering, and we are seeing graphs that are touching 0 in terms of reversibility. This is a very potent anti-diabetic drug to be available soon, marketed by Eli Lilly. So it's a dual incretin agent, GLP-1 GIP agonist, and other triple agonists are also being studied. And this is the trial data from tirzepatide, the dual agent. Trial data is now published. So we do see, in comparison to semaglutide, we are seeing double weight loss, as I mentioned. And this is a meta-analysis comparing the efficacy of various weight loss drugs. And the efficacy-wise, they are all good, but we are not using much of phentermine topiramate because of CNS side effects. So GLP-1 agonists and naltrexone bupropion are the most popular and evidence-based and safe therapeutic options. So I think that's it, and I'm happy to take questions. Yes. Oh. Yeah, SGLT2 agents are being studied, but again, the potency is not as great as the GLP-1, because there you see, so that's why. I mean, yeah. But that's mostly in diabetes, sir, because in the glycosuric action is also because you're losing calories through that altered threshold point. So we don't know if we will see the same amount of weight loss in non-diabetic, because in diabetes, the glycosuric threshold is different, and the SGLT2 inhibitor is actually altering that threshold. So we might not see that amount of weight loss in a non-diabetic individual. We don't know. I mean, that's probably, it is definitely an adjunct treatment for sure, like even in individuals with pre-diabetes, like you said, metformin and SGLT2. Yeah.
I will introduce myself. I am Dr. Basi, completing nearly 50 years as a medical teacher and a medical practitioner, fully accepting the fact that genetic factors contribute to diabetes. I would like to mention a few points. One, when I was a student in the school, in my village, there is a lot of contact with all the public there, walking every day. I have not seen a single person with obesity except one of my classmates' mother. One of my classmates' mother at the school, upper primary school. And I did not know why that person alone was diabetic. I came to know why he was obese. When only I became a medical student. That's the only house where there was a servant. All other houses in my village, there was no servant. And everybody, for purchasing every article, used to walk at least 4 to 5 kilometers every day. Because if you want to purchase fish for us, my mother used to walk 2 kilometers for and 2 kilometers back. And for everything, less than 3 to 4 kilometers, nobody used to go by bus. Because bus you got to wait for 2 hours, 3 hours at a place. And next point I will say that if you are taking, say, 1 cup of tea and a vada extra than what is required per day, it will approximately cost 20 grams of weight gain. Extra calorie other than what is required for the activities. And 20 grams per day calculated into 1 month is 600 grams. Into 1 year is 7.2 kilometers. And for 5 years, it will be 35 kilograms. In other words, if you are taking 1 cup of tea plus 1 vada extra than what is required as additional calorie, in 5 years, you can gain a weight of 35 kilos. That means weight is not obtained over a few months. And next third comment is, I have one patient who was an assistant executive engineer in KSCB, coming from a well-off family, came to me for hypertension. He was obese. Ideal weight about 20 kilograms. 2-3 times I insisted that you must change your weight, reduce your weight by calorie and exercise. And then he refused to come to me. And after 2 years, when I was going for a morning walk, he was coming from the opposite side. Look, I could recognize a person. He has lost 13 kilograms. Then I asked, sir, I told you many times to reduce weight, but you did not reduce even a gram of weight. What has happened? Doctor, I did not come to you. I had a myocardial infarction. And then I went to the cardiologist. Cardiologist said, unless you reduce weight, your life is lost. I think you are Malayali. I think he said, Doctor, Jeevane Pedillata Arakil Unda Doctor. So I was forced to date. I said, did you take any drug? No. Weight loss. I had never prescribed a drug for obesity. So many drugs has come in the past. Many of them have been banned subsequently. And many of these drugs, if you forget about the academic alone and evidence-based alone, and if you come to ground reality, how many of the Keralites with obesity, how many of the Indians with obesity will be able to take semaglutide and liraglutide? And if they are consuming that, I am sure that other members will be suffering from famine. And last comment is, in 2018, BMJ, there was an article saying that about 12% of the Indian population is converted from average group into BPL by medical treatment. And last one more comment, last comment. Just 1 minute, 1 second below. Editor of NEJM for more than a decade, after retirement from NEJM, wrote in the journal that many of the controlled studies are so much manipulated by the drug industry, it is so difficult to believe the result. Maybe maximum 50%. This article which has come. The editor has written, and so many other journals also it has written. Most of the randomized studies, maximum truth is 50%. Including Canada, US, India, everywhere, drug company has got tremendous influence on all the journals, including the so-called opioid receptor. Tremendous amount of money is given to the journals.
So we have a session by Dr. Vinod.
Yeah, sir, regarding the points you mentioned, they are well taken. But definitely we are seeing clear weight loss with all these medications.
Weight loss, liraglutide, I have not prescribed because of the cost.
And your point is also well taken that diet and exercise is the primary thing, and madam has mentioned that we all first go with diet and exercise only when we don't find.
I am not against that.
Yeah.
I was saying second line. You come to the round reality.
It is only second line. All of these are second
line. I think.
Basu sir, I think you made your point.
I
Let us discuss it over coffee or tea.
I think no more questions are allowed.
Morning, I did not talk. Only.
Due apologies to you, sir. No more questions. We are already running out of time. Over to.
So when the Trivandrum Medical College Alumni Association searched for a name to name its medical academy for knowledge transfer, we reached a decision very early. It can be and it should be Professor V.C. Matthew Roy. So we have the V.C. Matthew Roy Medical Academy, which conducted all the 15 webinars during our COVID time.
Yes.
Thank you.
Thank you, Nisha Madam, for that excellent presentation.
We request the chairpersons to hand over a token of appreciation to the speaker, Dr. Nisha Nijal Haroon. We request Dr. Dayananda Babu to present a token of appreciation to the chairpersons, Dr. Aruna R. and Dr. Abhilash Nair.
The last session of the day is the Professor M.A. Akbar session. The chairs are the last but one. The chairs of this event are Dr. K.P. Haridas and Dr. Ajay Kumar. I request the chairs to take the stage. Thank you.
So we named this session after Professor M.A. Akbar, who is dear to all of us. So
Do you expect me to talk something about Dr. Akbar? Yeah. From my mind, actually the best person for this would have been Dr. Vijayan. He's his classmate, but he has been one of my close friends and also colleague in the Calicut Medical College. I joined in 1962, he joined in 1963. And in the surgical department as professors, he was just senior to me actually in PSC. So he became senior. He's a fantastic human being, superhuman, amazing personality, very jovial, friendly with the students. He has contributed several things in the sense, he has written a book on surgery, and he has been a good teacher, and very touchy, very lovable character. And on top of that, I always thought he used to think above religion. That is what I found in him. And fantastic person, that's all what I have to say about him. Dr. Vijayan, would you like to say something? He has been a close friend. Do we have this? Okay, fine. Let us now start off with Dr. Vinod, actually. I wouldn't say Mr. Vinod, FRCS, MS FRCS, and it's a privilege to chair this session. And about him, actually, his uncle, Dr. Madhumohan, I don't know whether he's here, he's a very close friend of mine, and your father was my teacher, and MEP, your uncle, is MEP is your uncle? As well. Yes, he is my classmate, and so many connections. Surgeons are two types, in fact. There are some surgeons are born, some are trained. He is a born surgeon. That he has shown, and he has become one of the top surgeons in England. He is a clinical professor in the University of UHL, that is University College, Coventry and Warwickshire. Yes, Warwickshire. I'm not reading. In fact, that will take more time. So I leave him free, actually. In fact, I asked Dr. Vasudevan as well as Dr. Panikar, why not you give an opportunity for me to talk about obesity and metabolic surgery? I said next time. First time for Dr. Vinod, next time for me. So I'll be talking about my obesity treatment, surgical treatment. I believe that's the only sustainable way to lose, a sustainable thing to lose weight. Sustainable weight loss is attained only by surgery. Not losing 10 kilos or 15 kilos is not going to help at all, absolutely not. And you know the status in Kerala, 20% of the population, or 25 to almost 25% of the population, 1 in 4, 1 in 5 definitely is overweight or obese. We have 1.5 billion people obese in the world, either overweight or obese. We can divide half-half out of the 7.5 billion. We have to be very careful. This has to be taken as a separate specialty, as a single specialty, like cardiology and cardiac surgery. And we are ignoring, physicians and surgeons, everybody is ignoring. We are not aware of what is happening in Kerala. And I see quite a lot of them. In fact, and also about diabetes. The Indian average diabetes is 8%. In Kerala, it is 20%, 25%, 20 to 25%. Same case with obesity. So there is something to go with obesity. Diabetes, that is obesity. Obesity is the main cause of diabetes in our country, or any country for that matter. With these few words, I'll stop and hand over to Dr.
Yeah, over to Dr. Vinod Menon. No, I'll be talking later.
Okay. Thank you.
Please carry on.
Yeah, thank you. Good afternoon, respected chairpersons. Professor Haridas is my teacher, and Professor Ajay Kumar is my good friend and colleague. I'm not naming any of my teachers because I'll miss somebody, but I cannot just not mention Professor Ramushan Nair, who's taught me the art and science of surgery, and amongst them there are several others, ladies and gentlemen. It's a proud privilege to be here today. This institution is special to me. I was born here, I qualified as a doctor, and I trained as a surgeon here. My father, late Professor M.R.S. Menon, worked his entire working life here. He took his last breath here. So this place is really special to me. And my mother and my wife were my fans and my critics. They're both here today. It's the first time in my life they're both here at the same time. So it's a special day for me. And also this session is dedicated to Professor Akbar, who was my teacher. And I learned a lot from him. And there's one thing I especially learned from him is to interpret plain X-rays. Those were the days when we did not have free access to CT scans, but he took us there's a weekly evening radiology class. So my humble respects to Akbar sir too. Nisha did a fantastic talk on the medical management of obesity. It's a complex problem. And I think this is not the Football League of Nations, it's a league of overweight nations. And no particular country can take pride apart from maybe Korea and Japan. Obesity is associated with multiple comorbidities. I'm not going to list them all. There's plenty out there. And what's more important is we've just gone through the COVID pandemic, and there's a well-established relationship between obesity, diabetes, COVID-19, and mortality. And if you look at cancers, and Nisha touched upon this, and I'll show a slide a bit later on. So this affects every single system. And also obesity reduces the life expectancy. So it's a huge, huge problem. We talked about genetic dyes, and this particular paper in PLOS Genetics a couple of years back, the genetic dyes is really supportive of thinner patients because they have very few genetic variants that make them becoming overweight. And people with obesity have an increased number of genetic variants. So there's something about how we are born, where we are born, and our genetics. This particular picture, which appeared in the Lancet about 20 years ago, I believe from a South Asian wedding. And if you can look at both the gentlemen, equal body mass index, but look at the gentleman, the South Asian gentleman, his body fat is 21%. So it's not just the body mass index, there are far more subtle features. The gastrointestinal tract has always been mentioned as a mediator. There are lots of signals. If you look through the stomach, the pancreas, the colon, the 3 bits of the small bowel, they produce a lot of hormones and enzymes which affect the glucose and energy homeostasis, manifesting as obesity and increased body mass index. Coming to my ask of me is to talk about bariatric surgery and the evolution of bariatric surgery. Dr. Edward Mason is considered to be the father of bariatric surgery because he described the Roux-en-Y gastric bypass in 1966. And this operation is still standing 56 years on. He described that operation and he noticed that in patients who had gastrectomy for cancer or for peptic ulcer disease, it cured the, it didn't cure the cancer, it got rid of the cancer, cured the ulcer, peptic ulcer, but most patients lost weight. So it made him think, if you divert the alimentary tract and exclude a certain section of the small bowel, patients will lose weight. This gentleman, he died at the age of 100 during the COVID pandemic. If you look at appendicitis, I mean, the days when Akbar sir, Vijayan sir, and Haridas sir taught me to do appendicectomy, it was an open appendicectomy. And then it became laparoscopic, and now some people do it robotic. But the essence, the appendicectomy has not shifted. Similarly, if you have gallbladder disease, you have a gallbladder removal. Open cholecystectomy, laparoscopic cholecystectomy, robotic cholecystectomy. The essential operation has not shifted. But if you look at bariatric surgery, there's about 25 different operations listed, which means there are different ways in which one could approach the gastrointestinal tract and do all these kind of mediator regulation, which results in weight loss. So there's no one size that fits all. The Swedish obesity subjects trial in 2004 reported on the 10-year results of bariatric surgery. And they found that surgery, which is gastric bypass or sleeve gastrectomy, had much better results in terms of weight loss as compared to controls. The 20-year outcome, particularly looking at the long-term cardiovascular events, found that the weight loss was maintained or rather sustained at 20 years. So it lasts a long time. Selection of surgery, I think Dr. Titus was asking, what's the selection criteria for surgery? And I touched upon the body mass index and how it's not the best descriptor. But for purpose of understanding, the body mass index of more than 40 or more than 35 with 3 particular comorbidities, type 2 diabetes, hypertension, and obstructive sleep apnea. And now that there's a higher incidence, higher interest in diabetes resolution, that threshold is lowered by 2.5 in people like us of Asian origin. And this is the National Institute of Clinical Excellence guidance that we use in the United Kingdom. And I suspect, Nisha, it's not hugely different from what you practice in Canada and the US. And you complete a structured assessment and anesthetic risk and all that. The simplest technique is endoscopic insertion of a gastric balloon. Does not require a general anesthetic, done in the endoscopy suite. You place a balloon into the stomach, there you go, into the stomach and fill it with about 500 ml of saline with a bit of methylene blue. So it makes you have a full feeling as if you've gone to a big Pizza Hut or gone to McDonald's and had a full meal. But this balloon has got to be removed at 12 months and patients can have rebound weight gain. The patients lose 15 to 20 kilograms within that period, and we hope they develop a new eating pattern. Gastric banding was very popular about 10 or 15 years ago. Simple technique, laparoscopic technique, possibly overnight stay in hospital, but it had a few complications, and the weight loss was reasonably modest. So it's given way to, or kind of faded away a bit, and taken over by gastric bypass, which used to be very popular 10 years ago, much higher weight loss, significant and fairly quick resolution of diabetes, but because there were 2 anastomosis, you bypass about 2 of the 5 meters of the small bowel. So food does not get digested or absorbed during the 40% to 50% of the small bowel. And patients lost weight and they ended up being malnourished as well. The single most common operation worldwide currently is this technique called a sleeve gastrectomy, where you remove about 80% of the stomach and convert the rest of the stomach to a narrow tube with a little pouch at the bottom. 2-day hospital stay, 98% laparoscopic surgery, and you get 60 to 70% excess weight loss in good hands. I'll talk about weight regain in a minute. So this is the single most common operation worldwide currently. Mini gastric bypass, I know Professor Ajay Kumar has done a huge experience in that. It's a modification of the Roux-en-Y gastric bypass where you have 1 anastomosis instead of 2. So you create a small gastric pouch and exclude the rest of the stomach and connect the small bowel about 200 centimeters distal to the duodenojejunal flexure. It's got 2 anastomosis instead of 1, reduces the complication rate, and has, Ajay's got lots of experience and he's got excellent outcome in his hands. There are some experimental techniques like the endobarrier, which is a sleeve which is inserted endoscopically, and it excludes the duodenum and the first 30 to 40 centimeters of the small bowel. Exactly the same principle as a bypass, but it's put in endoscopically. This technique has unfortunately faded away. There's been some complications. Just for completion's sake, there's a technique called gastric plication, where you plicate the stomach. Stomach becomes exactly similar to a sleeve gastrectomy, but you don't remove it. You stitch the stomach, like inverting the stomach. The danger is these patients could develop a gastric cancer and go unrecognized. So it's not used that much. There are some centers that use it. In summary, there are several mechanisms that mediate the beneficial effects of surgery. And I'm not going to go through all that. The intestine adapts, there's fat metabolism, bile acid metabolism, duodenal exclusion, the vagal effect. It's not sure what each individual component contributes to it, but all in all, it works and results in significant weight loss. This particular slide is relevant to each and every one of you in the audience. I know even to, Najib talked fantastically well about, cardiovascular risk factors. Ali Aminian from the Cleveland Clinic published this in JAMA. If you look at all-cause mortality, that's controls, that's bariatric and metabolic surgery. There's a significant reduction. The same thing applies for coronary artery disease, for heart failure. And if you go one bit further, even for cerebrovascular disease, nephropathy, we had a fantastic lecture now about the effects on renal disease and obesity. If you have metabolic bariatric surgery, your risk reduces significantly. And similarly, it applies to atrial fibrillation. So this is great outcome following bariatric surgery across all aspects of the body. Particular thing about bariatric surgery and cancer risk, this was published by Phil Shore in the Annals of Surgery. They looked at about 90,000 participants, and there were 2,000 index cancers, but statistically significant reduction in the overall incidence of cancers, and particularly for endometrial cancer, postmenopausal cancer, and colon cancer. So there's a link between overweight, obesity, and cancer, and how bariatric surgery would improve the outcome. What about weight regain? All operations are good and ideally should be successful, but 20% will fail to maintain that meaningful weight loss, and patients ought to be educated. Did the operation fail the patient, or did the patient fail the operation? As clinicians, we would like to believe that it's the patients who failed the operation, but not necessarily. How can you reduce non-compliance from patients? You select your patients carefully, educate them, evaluate them, perform the right operation, and give good long-term follow-up. That's the way to maintain weight loss. However, we know as gastrointestinal surgeons, even if you remove a certain section of the stomach expands, the stomach dilates, the small bowel dilates. There are societal and cultural factors which make us go back to our old eating habits. So there is a certain bit of both. And we all use medications for our patients, prescribed medications, antipsychotics, antidepressants, steroids, antiepileptics, antihistamines. All these contribute to weight regain. Believe it or not, the body weight is aggressively defended like a thermostat controls body temperature. So whatever we do to reduce the body weight, there's a body thermostat which tries to regulate it back to where it originally was. I fully support what Nisha said in her talk, the utility of weight loss medications. Here's a result of a big multi-center trial looking at the role of weight loss medications after bariatric surgery, and there's a statistically significant improvement. So surgery should be complemented with medical treatment, and it's a combination treatment that produces the best outcome. Some of these patients who put on this extra weight would need to have revisional bariatric surgery. It convert a band to a sleeve, a band to a bypass, or a sleeve to a bypass. So revisional surgery is also becoming increasingly common. What is metabolic surgery? We talked about bariatric surgery is for weight loss. What about using the same technique to control diabetes? I'm not meaning curing diabetes, to put diabetes into remission. We all know that one of the most significant advances in medicine in the 20th century was 1921, Banting and Best about insulin, which revolutionized the treatment of diabetes. Certainly treated diabetes, but did not cure diabetes, did not put it into remission. But bariatric surgery, when used for diabetes, called metabolic surgery, puts diabetes into remission. And if you target these patients early on, it can prevent the micro and the macrovascular complications of diabetes. The STAMPEDE trial, again from the United States in 2017, looked at a group of patients with diabetes with medical treatment and surgery. And as the results show, this was published in the New England Journal of Medicine, surgery had a statistically significant advantage in controlling the disease. And there were 11, altogether there were 11 randomized control trials looking at the same question, medications, insulin, all the diabetic medications, and lifestyle versus surgery. It definitely favors surgery. How the surgery works, how the same surgery, metabolic surgery works in resolving diabetes, putting diabetes into remission, is a combination of the surgical effects, the mediators and other mechanisms, and finally its impact on glucose homeostasis. Again, similar to weight regain, a percentage of patients whose diabetes goes into remission, they will relapse. At 2 years, 75% of patients have good resolution. If they go off their insulin, they go off their metformin. But if you follow it up for 10, 12 years, a good percentage of diabetic patients recur, they relapse. That is where I think the role of the medications that Nisha so eloquently pointed out. For example, liraglutide. We're very proud of this study, which came from the United Kingdom, called the Gravitas trial, which looked at the impact of liraglutide in patients with persistent or recurrent type 2 diabetes after metabolic surgery. So the point I'm trying to prove is not just surgery, it's not just medication, it's in combination. The right combination serves patients best. Finally, to finish off, I think we need to look at the outcomes. There is a myth amongst the general population that bariatric surgery, metabolic surgery is extremely unsafe. I think that's got to be dispelled. The United Kingdom National Bariatric Surgery Registry has got 88,000 patients on it, and the mortality rate on those 88,500 patients is 0.004%. Or in other words, bariatric surgery is safer than laparoscopic cholecystectomy, safer than primary coronary artery bypass grafting, safer than a hysterectomy, safer than a single knee or hip joint replacement. And this is the data. And on this screenshot, you see my data from over 1,000 patients. I would not tempt fate, and I would not go into it, but it shows everything, the types of procedures you do, the weight loss, and the length of stay, and everything. It's got excellent outcomes. How do we achieve that? You have this proper infrastructure. You do not compromise on patient safety. And I think that's a key thing. Never deviate from what you do normally. Develop your team, respect your team, nourish your team, and the team works for you. The team, ultimately, it's the patient who benefits, and nurture your team. Look at patient feedback very positively. I mean, this is a complimentary one. Occasionally, you get complaints, and use that to improve your services and to make yourself a better clinician and a better surgeon. We occasionally get complications, and I do as well. And I think if a surgeon ever stands up and says he or she has never had a complication, it can only mean one of two things. Either it's not done enough, or it's not speaking the truth. So we get our complications, and this is one of my own patients who had a sleeve gastrectomy leak, and I leaned on my gastroenterology colleague who worked with me, and we used lots of endoscopic and radiology measures. You can see a stent here, and got the patient through the difficult period. There's a media influence about perception of obesity, and we as responsible clinicians should do our best to dispel that myth. There's a prejudice about, you go into a crowd and you see somebody who is obese, there is always some kind of comments. It'll take a generation for that to move. But we as clinicians should fight the prejudice about obesity, the prejudice about bariatric surgery, and also sometimes about the bariatric surgeon. Technology and innovation, one's got to embrace it very safely. And the robot came 5 or 6 years back, and we use the robot for selectively, but this is me with my mentor, a very experienced surgeon from Portugal. So you've got to introduce new technology very safely and never assume that you are the best at what you do. I came here yesterday, and the first talk I heard was from a psychiatric colleague who talked about work-life balance. And as surgeons or as clinicians, we have a finite life span as a working clinician. It could be 20 years, it could be 25 years. But never forget your wife, your mother, your children. Because at the age, but it comes to a stage when you've got to lay down your tools. And you should never sit back and think. I'm not for a moment saying I've done it best, but you've got to think about it as you progress in your career. So to close off, the future of bariatric and metabolic surgery, these are my thoughts. There's going to be an exponential increase in numbers. The problem is increasing. It's a real pandemic. And we should have a united front against prejudice for both media and social campaigns. If you're a complete surgeon, you should have the whole armamentarium, should be able to offer almost every operation. The safety profile is excellent. And there is no other operation, be it coronary artery bypass grafting, be it brain surgery, no other surgery will attack or target 3 or 4 comorbidities in one stroke. So this is the beauty of this surgery. Patients got to be fully involved in decision making, teaching, training, research, and innovation. Standardize the procedure, enrich your teams, and do everybody to do the same thing. And once again, a focus on outcomes reporting, because there's to dispel the myth of high complication rate. And I would leave you with those final thoughts. Thank you.
Thank you, Dr. Vinod, for the excellent talk. I am really proud to chair the session, and 1 minute at the introduction time I could not talk. So I'm really humbled and honored to chair this session. And Akbar sir was like a father figure for me. He's the one who gave knife to me in my surgical career. It was on a final year. I was a final year student. It was a strike day. PGs and house surgeons were not there. We were only there to help sir. So from that day onwards, I was so close to him. And until his last days, I used to visit him. And it was, even though it was an accidental coincidence, though I'm a bariatric surgeon, it was Akbar sir's session. That makes me very happy. Thank you very much, organizers, Panikar sir and Vasu sir. And one question for you, for the benefit of the surgeons in India. Among the various procedures, which one you find suitable for South Indians? We have 3 popular procedures in Kerala. Yeah. Sleeve, MGB, RYGB.
Yeah. Okay. It's a good question, Ajay. And I think I would even take away the South Indian aspect of that question. Of those 3 procedures, no operation is simple. Every operation's got its small tips and tricks. And I think there's no doubt that of the 3, the Roux-en-Y bigastric bypass is probably the most complex, because it's got it's got potential for more complications, more malnutrition, and also the technique of 2 anastomosis. The sleeve gastrectomy people perceive as a more simple procedure, but you have 6 or 7 long firings of the stapler. And if you're not very good at firing them, or if the patient fails the operation, then the consequences can be disastrous. The single anastomosis gastric bypass, and I know that you're a real master at that, is a great operation, because it combines the benefit of both procedures. It's got a single anastomosis. You're not doing, you're creating a very safe pouch of stomach. And my only concern with the malnutrition, with the malabsorptive operations, is the follow-up, which in the Western world is much more well-defined, and most patients get it consistently. And therefore, the sleeve, in an Indian context, achieves a similar degree of weight loss, but there is less stress on the other group, and there's less chance for the operation to fail from a nutritional perspective. Those are my thoughts. Yeah.
Can I comment on those, actually? There are 2 procedures only I do. That is, the common thing is mini gastric bypass for the last 10 years. This started by Rutledge in 97, but taken up later on. I've been doing it for 10 years. Diabetic remission, obesity with diabetes, mini gastric bypass. Obesity surgery, when you say bariatric surgery, it is weight loss surgery. If you have to cure diabetes, you have to do a bypass of the intestine, because the nutrient chyme reaches the lower ileum faster, so that GLP will be stimulated, and thereby there is stimulation of insulin. So I have almost 120 patients with mini gastric bypass, and 80% of them are cured of diabetes. They have not come back. That is my favorite operation, and that is being commonly done in India mostly. And this is coming down. Sleeve gastrectomy is on the whole coming down, isn't it?
Yes, sir. Even though I am doing MGB, sleeve is the most common procedure in India. The problem with sleeve is weight regain is more, complications are more.
Absolutely, and also Roux-en-Y gastric bypass, 10 years you can wait, because
MGB, as Vinod said, you need strict follow-up, otherwise patient will land up in malnutrition. So we have to have a selection of procedures, not a single procedure. Yeah, that's the most important thing.
And one of the surgeons in Kerala, Dr. Ismail, Mohammed Ismail, he has more than 1,000 odd cases of MTB. Do you know him?
I know.
Yeah, okay. Yeah, that's right. So,
Any questions from the floor?
Yeah, I particularly didn't mention it because there are two operations, the biliopancreatic diversion and the duodenal switch. They are very, they're performed very uncommonly these days because it's a technical difficulty and also the follow-up with the nutrition perspective. And because the sleeve or the mini gastric bypass provides almost similar excess weight loss and comorbidity resolution.
in fact, there is one more surgery called SADI, single anastomosis duodenal bypass, SADI. After sleep, you connect it to the intestine to the duodenum, SADI, single anastomosis duodenal.
Yeah. Yes. No, surgery works. Quite often, that's the role of the medications that Nisha presented. The GLP analogs. So you got to keep them. The diabetic patients have got to have yearly follow-up for their neurological evaluation, the nephrology, and the peripheral neuropathy. And if there is any sign of it coming back, you should use the medications. Is that right, Nisha? Yeah.
What is your BMI for referring to surgeon? When do you refer your patient? Oh, it's different. No. What is your criteria?
It's fairly similar. It's a 40 and 35. Yeah. No. I do a fair bit of robotics, but 95% of my bariatric is laparoscopic. I just mentioned that, so there are new technologies, and you got to innovate safely. Yeah.
Okay, thank you very much.
Excellent. Balloon's really going to take off, Najib. The two reasons. One is the indication for balloon. It's from BMI, at least in the UK, from 27 to 35. Those patients will not fit the criteria for any formal surgery. And also the super obese patient, somebody's got a BMI of 70. And if they have a balloon for 12 months, they will drop their BMI by 12 to 15 points and make them a much better surgical candidate.
And in fact, we are taking those with BMI 32, even 31, with diabetes for mini gastric bypass.
No, I think the balloon is, because, and also I've done 3 or 4 patients put balloons in before they went on to have live-related kidney transplants. So they have a certain threshold for the recipient to have that. So.
Okay.
Thank you. Thank you, sir.
We request the chairpersons to present a certificate of appreciation to the speaker, Dr. Vinod Menon. We request Dr. K.N. Vijayan and Dr. We request Professor K.N. Vijayan and Professor Shivashankaran to present.
Story of my scalpel. I don't know whether you have heard of it.
We request Professor K.N. Vijayan and Professor Shivashankaran to present the token of our appreciation to the chairpersons, Dr. K.P. Haridas and Dr. Ajay Kumar.
I'll request Professor M.K.C. Nair sir to present the Lifetime Achievement Award to Professor Haridas.
The next session is the Professor Krishnan Nair oration. To confer the Professor Krishnan Nair Oration Award, we call upon the chairpersons, Professor C.S. Madhu and Professor Chandra Mohan. Professor Krishnan Nair Oration Award has been conferred to Dr. Cherian Verghese. We invite the former Vice Chancellor, Dr. M.K.C. Nair, to confer the award. And the Vice Chancellor, Dr. Mohanan Kundumal.
Dear colleagues, first of all, I would like to thank the organizing committee for giving me opportunity to chair this session, which is in memoriam to my mentor and teacher, Professor Krishnan Nair sir. He has been my undergraduate and postgraduate teacher, and I had the opportunity to be with him in the Department of Radiotherapy, bar RCC, from 84 to 1991. And some of you may not know, the Department of Radiotherapy, actually the cancer department of Trivandrum Medical College, was situated in the ward number 11, 12, 13 of a Medical College Hospital, in a very pathetic condition, where there were a lot of really advanced cancer patients, and nobody used to care. Especially, we students used to go to these wards during exam time, because very often the cases were selected from those wards. So Krishnan Nair sir, he had the fortune to be deputed to Christie Hospital, Manchester, because of an agreement between Trivandrum Medical College and Christie Hospital. It was all because of Professor Thangavelu, the principal at that time. So he came back after the FRCR qualification and was posted in Kottayam Medical College, and then came back to Trivandrum. And from then onwards, the department took a different shape, and it was one of the most appreciated and recognized training centers for clinical oncology. We all know how difficult it is to organize something in a government setup. As a professor in the government medical college, he could manage to organize that department to a regional cancer center. And I remember the day when the foundation stone was laid by our beloved Chief Minister Karnagaran sir at that time. From then onwards, that institution was brought up by him. He had taken pains to train all his students, subordinates, and we all have to learn from him the methods. He used to invite faculty from UK, USA, etc. on various schemes, and he allowed them to mingle with the faculty, and that is how the technology transfer was executed. Similarly, British Council sponsored so many teaching programs he arranged. And he was one of the persons to get the Padma Shri award, and also he was awarded FRCP London. So Krishnan Nair sir, I would rate him as the best doctor Kerala has produced because of one reason. See, we all know when I joined this college, there was a miniature of a city in the principal's office. And with the able guidance of PKR Virus sir and then Sambashivan sir, the institute was built and supervised by the engineering college faculty, and the big building came. And on a fine morning, Valiyathan sir was given the honors of being the director of that institute. On the other hand, Krishnan Nair sir built it from the scratches, and he organized it into one of the foremost cancer centers in the country. So he has a lot of publications. He brought up cancer research in Regional Cancer Center, the pediatric oncology for the first time in India, community oncology for the first time in India. He started the medical oncology and appointed Dr. V.P. Gangadharan. And above all, the greatest cancer surgeon probably India has produced, Dr. Thomas Cherian. He was appointed and he was sent to UK for training, and that's how the RCC came to what it is today. So I also have the great happiness in seeing my undergraduate junior, Cherian Varghese, to present this talk in memoriam to Professor Krishnan Nair sir. Chandramohan, you want? Okay.
Thank you, Dr. Madhu and chairpersons. Good evening, my teachers, ladies and gentlemen. I think Dr. Madhu has given you a reasonably good idea of what I was trying to say. And I will dedicate this to Dr. M. Krishnan Nair sir, and we'll call it Cancer Control Yesterday, Today, and Tomorrow. So, as we have heard already, even in the previous session, cancer control needs a wide range of options. And just to tell you, if you look at the life history of Dr. M. Krishnan Nair sir, as has been briefly presented, it has been so significant that he could actually take on any topic, not just cancer. Even if it is obesity, I'm sure Dr. Krishnan Nair sir would have spoken. But I think this is all what we need to remember about this person. He has set up the first modern, affordable cancer care center in Kerala's public sector. That is no joke. I've been across the world in WHO. There are very few cancer centers of this status across the world, actually. From these days, we always talk about our professors with the mnemonics of Dr. Joy Phillips sir. So if I look at the mnemonics of M. Krishnan Nair sir, he was always very kind. He's very resourceful. He is an extremely intelligent person who can actually understand quite complex theory very fast. He was very social. If you go to Trivandrum Club any day, you will see how social he is. He was always very happy, even in the midst of a lot of difficulties. If you go through RCC, you will hear his laughter and his smile. He is very nimble, he is adaptable, and he is nurturing, and that is Dr. M. Krishnan Nair sir. So I just wanted to sort of say that how great he was as a human being. So I work at WHO, and we have just produced the WHO report on cancer, which is the latest report. And if you look at that, there is nothing new there. It still says formulate plans, fund priority cancer interventions, build capacity, develop a workforce, partner with communities, and strengthen information systems. This is what Krishnan Nair sir has done from 1980s. As Dr. Madhu has clearly said, he has worked ahead of his time. That is the most important thing. Krishna sir could see into the future almost. You see the Cancer Care for Life, and that is Dr. Miss K.S. Chitra actually sitting there as a young girl there. Cancer Care for Life was such a fantastic insurance that he thought of. If you pay 100 rupees, you can get cancer treatment up to 50,000 rupees in RCC, and 50,000 rupees was a big amount at that time. With most of the epithelial cancers, that was quite feasible. Even now, how good is our Atmanirbhar Bharat with 5 lakhs rupees, we don't know. Because the markets have changed and the prescriptions have changed. But he had the vision to sort of bring in a cancer life insurance at that time, which is still working actually. The people who have contributed 100 rupees are still getting benefits out of that. Another important aspect is the way he actually sort of thought about all the various specialties. Who would think of appointing a dentist in a cancer center? Nobody. Who would think of appointing a palliative care program in a big hospital? Nobody. I go to various cancer hospitals, they are still scared of talking about palliative care. So people are still caught up in very narrow clinical sense of things, whereas Krishna sir could actually see it much broader. In fact, I wrote with sir this paper called Regional Cancer Center Trivandrum, a green park for epidemiological studies. That was the time when Mr. Vijayaraghavan was setting up the techno parks, and we were saying this is a park for epidemiological studies. I recently developed this, how to develop a cancer center with the WHO and the International Atomic Energy Agency, which was just published last year. And the main elements of the thing when I wrote this book was from what Krishna sir has done. So if you look back what some of the key elements in the cancer control in the past, you know that Kerala has one of the highest background radiation in Karnataka. There are only 2 or 3 places in the whole world. One is in Brazil, one is in Kerala, and one other place where people live in naturally high background radiation. So Dr. Krishna sir at that time, with the help of Japanese colleagues and with the Baba Atomic Research Center, carried out a study of 400,000 people with full data, including background radiation, and have shown that very low levels of background radiation have not shown any increase in cancer, which still stands so good actually if you look at global radiological protection. We get into neck node dissection. I think oral cancer and head and neck cancers were so high, patients with neck nodes up to 1 centimeter can receive radical radiotherapeutic management. Was a significant paper which actually got the Indian Surgical Oncology Award at that time. In 1992, Krishna sir could say that what is the survival for stage 1 breast cancer in Kerala in RCC, it is 90%, or for oral cancer. Today, how many cancer hospitals in this state can say that what is our survival rate? Cancer hospitals talk about big machines, big people, big degrees. I have not seen any cancer hospital advertising, we are a great cancer hospital in Kerala, please come and get treated, your breast cancer survival will be 95%. No. They say we have the latest machine, we have the latest person, we have somebody who has come from this country and that country. So I think this actually shows that outcome-oriented interventions are so important in cancer. That is the single most important thing. And I think most of our problem is we get bogged down in process. We talked all about diabetes. What is the control of people who are on treatment for diabetes? Less than 10%. What is the control of people who are on treatment for hypertension? Less than 20%. What is the survival of people with cancer? We don't know now. So I think we have to change our approach, and this is something that sir has shown at that time. When I joined after MD radiotherapy from CMC Vellore in RCC, I was actually put in cancer registry. Nobody would go and sit there and look at medical records at that time. But I think that was such a radical change, and most of these studies actually came out of examining good medical records at that time. Again, RCC had such good medical records, which many hospitals even now don't have. This was my PhD thesis actually. We did the prevalence of human papilloma virus in Kazhakoottam. This was one of the first studies we actually looked at, and about 5 to 6% was the prevalence, and the prevalence was persistent across age groups. If you see in high-income countries, the prevalence goes up to 20%, but it comes back. But it is the persistent HPV that leads to cervical cancer. Remember in 1993 when this study was started, there was not even a thought about HPV becoming a risk factor or a causative factor and a vaccine. Now, HPV is a vaccine for cervical cancer now. Many states, many countries have given. Harold Surhausen got Nobel Prize by showing that HPV infection actually causes cervical cancer. Krishna sir had 339 publications. Imagine, it is not that he is writing 339. 339 faculty members of RCC and other places had a publication that means. That means that is the kind of enabling environment that he provided. But still, what is the problem in cancer? In cancer, I think the main problem is delay. Delay is death in cancer. And for a person to have a suspected lump in the breast, to get a definitive cancer treatment, even in Kerala today, it takes almost 4 to 6 months, because they'll go to 2 pathologists, 3 surgeons, 4 oncologists, and finally, by the time it gets done, it is too late. And in fact, when we developed the Kerala cancer strategy, we actually thought of a Kerala cancer grid, that within 25 kilometers, a person should get a definitive diagnosis, and that will save cancer. And thinking of that, in 2004, Krishna sir set up OncoNet, with which RCC Trivandrum could connect to Kannur and to various other places. And that was the kind of telemedicine that was set up. And in 2021, only Government of India has established the telemedicine practices, and Kerala is also part of that. If you look at India's National Cancer Control Program, which is one of the reasonably good ones from 1975, the main element which changed the initial plan was Krishna sir's 10-year action plan for cancer control in Kerala, which is again shown as one of the WHO strategic documents. I will not get into too much of details, but what is going on in cancer now? First, most important thing is that WHO has said that cervical cancer can be eliminated. Okay? It is not eradicated, it is eliminated, and the threshold is less than 4 per 100,000. So how is that going to be achieved? If 90% of girls are given HPV vaccine, in fact, the latest is that even 1 dose is good enough. 70% of women get cervical cancer screening, at least at the age of 35 and at the age of 45, with an HPV test, not just VAA or pap smear, which are very difficult. And 90% of such women and women with cancer get treated. Then we can bring down the incidence to 4 per 100,000. Trivandrum Cancer Registry has an incidence of 7 or 8 per 100,000, but I think across Kerala it will be much more than that. Plus our lifestyle and our sexual practices, everything is changing. So this is the right time for Kerala to introduce HPV vaccine. I think it is too late if you don't do it. I think Sikkim has, Punjab has, 2-3 other states in India has. Most other countries have already implemented that. So one of the major challenges, so by 2030, we should have a substantial reduction in cervical cancer, which is still one of the most common cancers in women in this part of the world. Breast cancer. Breast cancer is now overtaken as the single most important cancer, even higher than lung cancer across the world. Because of reduction in male smoking, lung cancer has gone down. And again, we really want to have an annual reduction of 2.5% in mortality from breast cancer, which mainly will attribute to early detection and good treatment. Again, cancer treatment has become a fashion of the day. Surgical oncologists, medical oncologists, all are there, but being in cancer for a long time, I can see that most hospitals treat cancer like fashion. What is the fashion today? So I treat it like this. And then 6 months later, somebody else will come and say something else. So I think a very systematic, thorough, protocol-based management with outcome assessment is still lacking, and this is something that Krishna has shown long back that it is possible. The other challenge is about screening. I think it is actually a misconception that everything can be screened and managed. Screening is good, but screening needs a lot of infrastructure and health system capacity to make sure that a woman who is screened is taken up to the logical conclusion of managing the precancerous lesion. Look at this breast cancer mortality curve from the US, 1950 to almost 1975. There is a rapid reduction in mortality incidence ratio. And then after that, after the introduction of mammography screening, there is not much reduction actually. In fact, if at all the reduction is there, that is actually due to tamoxifen, which came as an adjuvant therapy. And the last one that I wanted to mention about the global initiative for childhood cancer, where I think we should at least get a 60% survival for all childhood cancers, which I think again it is possible in Kerala. The current insights are all that you have heard, I think, yesterday about immunotherapy and microbiomes and DNA mutations, which I don't want to get into. And recently you heard that in one of the clinical trials of rectal cancer, all the participants were completely cured of cancer with immunotherapy. So maybe in 20-30 years, cancer will become a disease which still can be managed quite easily if you do a genome-wide analysis. Precision prevention is coming, but I just want to remind the audience that this is the life stages that we are familiar with, right? But is that the one? I would think these are the life stages. Our life stages are in bottles now, right? We start off with, instead of breast milk in artificial feeds, then it is in sugary bottles, then alcohol bottles and IV bottles. The problem is that there is a profit under every bottle. In fact, the fundamental failure of medicine, in my view, is that medicine has become a commodity for sale. And once it's an emotive disease like cancer, it is very easy to sell that. It is very easy to sell because it is such an emotive condition. So I think one has to really look at this. The latest paper from Lancet shows that still smoking alcohol, high body mass index, unsafe sex, and high fasting plasma glucose, etc., are still the highest risk factors for cancer. So what do we think Kerala should do? I think certainly tobacco control should continue, and newer forms of tobacco is coming in. Alcohol is also a substantial cause of cancer. You can see adult colon and rectum cancer is increasing in Kerala. HPV vaccination is a sure shot and should be given to all girls in Kerala. Targeted screening, not just widespread erratic screening, targeted screening should be provided. Protocol-based management with seamless transition. I think a cancer patient is sent from left to right in this state. I think there should be a seamless transition between public, private, and various levels. Financial protection should be thought through because out-of-pocket expenditure is still very high. We also need cancer navigators so that the person actually gets appropriate treatment at the appropriate time, and a state-level cancer registry so that this all gets documented well. Finally, even with all the changes, I think a chat scan is better than a CAT scan. What's a chat scan? You just talk to the person. You chat with the person. I think communication is so critical in cancer, which is missing completely. Instead of high tech, actually it should be a low tech and a high touch therapy. You should actually be in touch with the family of the person with realistic goals and consider that quality is more important than quantity. So I'll stop there. A candle loses nothing by lighting another candle, and that is what Krishna sir has shown. So thank you, sir, and thank you, everyone.
Thank you, Dr. Cherians. It was actually a befitting honor for the great oncologist, Dr. Krishna sir. So let me say some more things about cancer care in Kerala. At present, we should understand there is a paper which is published by Dundona et al. In, I think, in 18. And the Kerala and Meghalaya are the cancer capitals of the country. The maximum numbers of cancer are getting diagnosed here. And if you look at the cancer care treatment, cost of cancer treatment, and recently one of my relatives got diagnosed with breast cancer, early breast cancer, and with confidence she went to the nearest private hospitals where they discussed and explained the cost of the treatment. You know how much? It was 88 lakh rupees. The patient simply ran away and got treatment in a government hospital. So that's a kind of cost of the cancer which is happening nowadays. And if you think about the legacy of Krishna sir, as early as 1980s, he thought about a standalone cancer care with the latest facilities, and it was, I think, one of the 4 centers in cancer, the best 4 centers in India, which one of was RCC. The other was Adayar, then Tata Memorial, Kidwai, and Ahmedabad. So, in 1980, he had a vision and he established a cancer care. But if you think now, how many standalone cancer care with all the facilities, with the multidisciplinary environment and all facilities are in Kerala, you don't see many. And now we can understand, even irrespective of the fact that RCC was established 30 years back, and even now, the major cancer care of Kerala is handled by RCC. There is something sad. If you think of any city in the country, Bangalore has at least 10 dedicated comprehensive cancer care centers in private sector. And Delhi has 20. And in Kerala, so you think about site-specific management of clinic cancers. Where is it happening? In RCC, we some sort of do it with a limited staff strength. But if you think about it, if you need to have a pure breast oncosurgeon and oncoplastic surgeon, is it available in Kerala? No. So it's very shameful for us to look at the pathetic and situation now. And I think Krishna sir should have lived long, so that he could have created many more hospitals in Kerala. And nobody could emulate what he did, or even 100% what he did in cancer care. Really, we're really sad to say that. And I hope that this kind of discussions, thought process should evoke newer and newer ideas, and cancer care in India and Kerala should improve. Thank you very much.
Thank you, sir. We humbly request Dr. Y.A. Nazar to hand over a token of appreciation to the chairpersons, Dr. C.S. Madhu and Dr. Chandra Mohan.
You'll come back. You'll come.
Next, we have a 10-minute break, after which we'll assemble by 5:30 for the...
To remain on the stage. We request the dignitaries to come onto the stage. Mr. Shibu Sridhar, Dr. M.V. Pillai, Sri V.P. Joy IAS, Dr. Asha Thomas IAS, Mrs. Nora Rebecca, Sri K. Kunnikrishnan, Professor K. Mohanan, the Vice Chancellor, Dr. V. Ramankutti, Dr. John Panikar, Principal Dr. Kala Keshavan.
May I invite Mr. Shibu Sridhar. Sri Kunnikrishnan sir. Kunnikrishnan sir. Please come.
This is it. Sorry. You have to speak in English. Okay. Sorry. Gallo online കൊണ്ടുവരേണ്ടപ്പോൾ പറയണം. റെഡിയാണ്. He's ready.
So, shall we?
We now request Mr. Shibu Sridhar to come onto the stage to deliver. We request Mr. Shibu Sridhar to come onto the stage.
So, with the permission of our chief guest, Sri V.P. Joysa, and we are starting the function. This is, the function is mainly meant for the release of the Malayalam translation of the autobiographical book of Professor Robert Gallo. It is originally, the English name is Virus Hunting. In Malayalam, it was translated by Language Institute, and the editor is Mr. Shibu Sridhar, and facilitated by Mr. K. Kunnikrishnan. He was the former additional director of Doordarshan. And now, Professor Robert Gallo will be joining us online. This book is basically on how he was having the study on the, and actually the truth is, Professor Robert Gallo was the person who identified the HIV virus. And we should be really proud that one of his closest assistant or colleague was Dr. Sharangadharan, who was a Malayali from here. And unfortunately, he is not here. And as represented now, Professor Robert Gallo is represented by Miss Nora Rebecca, who is the coordinator for the Global Virology Network. And now, here, this book has probably, I don't know how many languages it was translated, but being definitely, the Malayalam is the first language in India which got the translation, and this was done by, mainly by Mr. K. Kunyikrishnan, and also then edited, and our own Dr. Ramanguti has checked everything in the medical terms. So I welcome all of them, the team who has begun the book, and also let me welcome our Chief Secretary, and we are really honored to see our Chief Secretary, Sri VP Joyce here. So let me welcome him first. And also the recipient will be our Additional Chief Secretary of Health, Sri Miss Asha Thomas, Dr. Asha Thomas, sorry, Dr. Asha Thomas. Welcome, madam. Then we have our Vice Chancellor, Dr. K. Mohanan, and M.E. Pilasar. Actually, everything was coordinated, and this was became possible just because of Dr. M.E. Pilasar, and he will be doing the introduction of the author. I welcome him also, and all the guests from Language Institute and other guests. I welcome all of you, and also the delegates of the Toronto Medical Alumni, Platinum Jubilee Convention. Thank you. And with this, let me, what's the next? So okay. Okay. Now, introducing the author, Professor Robert Gallo, is by Dr. M.B. Pillai. I request sir to introduce to the audience. Thank you.
Good evening, and distinguished scientists, luminaries, administrators, and thought leaders on the days, and the most admirable group of listeners from the students and the faculty of the medical college. It's a great honor for me to take up this challenge of introducing Dr. Robert C. Gallo. He does not need an introduction. He's so world famous that you Google anytime, you can see pages and pages of his biography, which is sterling in character and amazing in his accomplishments. But I just want to highlight two things. Number one, many of you may be under the illusion that the research in medicine is possible only in Western countries because everything is in a bed of roses. Absolutely not. When you read his autobiography, you will realize that to err is human, and the human frailties are everywhere. But they overcome that by a different means. The camaraderie that exists among the scientists, in spite of the competitiveness, the collegiality, the cooperation, and the collaboration is what makes them great. When you read his autobiography, you'll realize that a medical student from my university, Thomas Jefferson University, had a bad experience in childhood. His 5-year-old sister died of acute leukemia. At a time, there was no effective treatment for acute leukemia. The 11-year-old boy, the brother, decided, it's my determination to find out what causes leukemia. He embarked on a study of medicine at Thomas Jefferson University. And after that, he went to University of Chicago, did postdoctoral research into immunology, virology, and those days are the infancy of virology. From there, he went to National Institute of Health and established the Institute of Virology, and he is credited with the discovery of not only HTLV3, which is HIV, but HTLV1, and he was also partially responsible for discovering HTLV2. Now, here is something interesting. He spent about 40 years of his life chasing the cause of the disease that took the life of his younger sister. And finally, he embarked on human T lymphotropic virus 1, which causes a particular type of leukemia. Look at the determination, the devotion, the dedication, and his absolute dynamism. That is one side of Bob Gallo. I was fortunate to know him for the last 25, 30 years, partly because of my association with AKMG. But most importantly, some of his best research colleagues are from Kerala. And one among them has to be remembered here, Dr. Sharangatharan from Alway. And he was instrumental in introducing the ELISA test in HIV disease. He was also partner in discovering HTLV1. Dr. Gallo is not only a scientist, he's a prolific writer with an amazing style of English prose. He's got a poetic mind, which is very, very admirable and very visible in every page of the book which you are going to read. A few years ago, when he asked me to join the senior advisor to the Global Virus Network, and I mentioned this last study, two scientists predicted in 2011 that the major threat for the world existence would be not earthquake, not tsunami, not nuclear war, but epidemics from viral diseases. This is 2011. And look what happened. Nipah, COVID, and monkeypox. And we are at the doorstep of a host of diseases called as the zoonosis coming to human beings from animal world. So this is the scientific side. He is credited with the discovery of IL-2, which completely transformed immunology, credited with the discovery of HIV, HTLV1, and more importantly, he had the wisdom to point out that HTLV1 is endemic in many islands. So when he came to Kerala, he asked me, have you looked for HTLV1 in Trivandrum? I asked him, what makes you think that we have this disease? He said, Sri Lanka has HTLV1. So please be on the lookout. It can cause not only the leukemia, lymphoma, it can also cause a neurological disease called tropical spastic paraplegia. And lo and behold, I asked Dr. Rekha Nair, director of the RCC. They searched for it. Already more than 35 cases of HTLV1-induced lymphoproliferative disorders are picked up in RCC. So basically, the eyes do not see what the mind does not know. And he has such a rich mind of creativity and insight and vision. And that's Robert Gallo. He's a great fan of Kerala, not only because his assistants and associates are from Kerala, he's a great fan of Kerala food. He loves the seafood. Every time he comes here, I take him to his chosen restaurants for the matti curry. He is not only a fan of matti curry, he converted another distinguished virologist, Dr. William Hall from University of Ireland, as a fan of the Kerala seafood. So they both are chasing me for the next opportunity to come here. Okay. So to sum it up, please read the literature, the science, the philosophy, the vision, and the logic in this great book. Now a few words in Malayalam, because basically we are translating that into our mother tongue. Dr. Anders Vaughn, you may bear with me for talking in our mother tongue. മലയാള ഭാഷയിലേക്ക് ഈ ഒരു ഗ്രന്ഥം തർജ്ജമ ചെയ്യാൻ തീരുമാനിച്ചപ്പോൾ ഒരു വലിയ വെല്ലുവിളിയായിരുന്നു. കാരണം ഇത് മുഴുവൻ സാങ്കേതികത നിറഞ്ഞ പദാവലികളാണ്. ഇതിനെ ആരെ ഏൽപ്പിക്കണമെന്ന് എനിക്ക് അറിഞ്ഞൂടാ. ഞാൻ ശ്രീ കുഞ്ഞികൃഷ്ണൻ നിർബന്ധിച്ചാണ് ബാൾട്ടിമോറിലെ ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് ഹ്യൂമൻ വൈറോളജിയിലേക്ക് അയച്ചത്. അദ്ദേഹം ധൈര്യപൂർവ്വം ഏറ്റെടുത്തു. ഞങ്ങൾ ഡോക്ടർ രാമൻകുട്ടിയോട് ആവശ്യപ്പെട്ടു. ഈസ് എ ഡിസ്റ്റിങ്വിഷ്ഡ് സയൻറ്റിസ്റ്റ്, പബ്ലിക് ഹെൽത്ത് എക്സ്പെർട്ട് ആൻഡ് എ ബൈലിംഗ്വൽ എക്സ്പെർട്ട് in narratives. So they both worked hard, and the full credit should go to Mr. Kunjikrishnan, ably assisted by Dr. Ramangutti and supported by our Language Institute. Two things to remember. ഞാൻ നേരത്തെ പറഞ്ഞതുപോലെ ടു എർ ഇസ് ഹ്യൂമൻ എന്ന് പറഞ്ഞതുപോലെ ഈ കഥയിൽ മുഴുവൻ നിങ്ങൾക്ക് കാണാൻ കഴിയുന്ന രണ്ട് കവിവാക്യങ്ങളാണ്. ഒന്ന് കുഞ്ചൻ നമ്പ്യാർ നേരത്തെ പറഞ്ഞു, കുറ്റം കൂടാതുള്ള നരന്മാർ കുറയും ഭൂമിയിൽ എന്നോട് ദാതാ, ലക്ഷം മനുഷ്യർ കൂടുമ്പോൾ അതിൽ ലക്ഷണമുള്ളവർ ഒന്നോ രണ്ടോ. ഈ കഥയിലെ നായകന്മാരെല്ലാം കുറ്റമുള്ളവരായിരുന്നു. ബട്ട് ദേ സക്സീഡഡ്. ചങ്ങമ്പുഴ ഇത് തന്നെ പറഞ്ഞു, കുറ്റപ്പെടുത്തുവാനില്ല കുറ്റപ്പെടുത്തുവാൻ ഒന്നുമില്ല, നാമൊക്കെ എത്രയായാലും മനുഷ്യരല്ലേ. ഈ രണ്ട് കവികൾ പറഞ്ഞതിൻ്റെ അർത്ഥാന്തര വിന്യാസങ്ങളെല്ലാം നിങ്ങൾക്ക് ഈ ഓട്ടോബയോഗ്രഫിയിൽ വായിക്കാം. പിന്നെ മലയാള ഭാഷയ്ക്ക് ഇതിനെ ഉൾക്കൊള്ളാൻ കഴിയുമോ എന്നുള്ള ചോദ്യത്തിന് ഉത്തരം തന്നത് മഹാകവി വള്ളത്തോളായിരുന്നു. അദ്ദേഹത്തിൻ്റെ പ്രശസ്തമായ 4 വരികൾ ഉദ്ധരിച്ചുകൊണ്ട് ഞാൻ ഡോക്ടർ ഗാലോയെ അവതരിപ്പിക്കുന്നു. വള്ളത്തോൾ എഴുതി, ആദിമകാവ്യവും പഞ്ചമവേദവും നീതിപ്പൊരുളും ഉപനിഷത്തും പാടി സ്വകീയരെ കേൾപ്പിച്ച കൈരളി പാടവഹീനയെന്നാർ പറയും. പാടവഹീന അല്ല, ആ കൈരളിയുടെ പാടവം കാണണമെങ്കിൽ മനോഹരമായ ഈ മലയാള തർജ്ജിമ വായിക്കുക. നിങ്ങൾക്കെല്ലാം അഭിവാദനങ്ങൾ. ഡോക്ടർ ഗാലോയ്ക്ക് ഞങ്ങളുടെ നന്ദി കൂടി അറിയിക്കുന്നു. താങ്ക് യു വെരി മച്ച്. നെക്സ്റ്റ് വൺ ഇസ് Jubilee.
Now I invite the translator, Mr. Kunjikrishnan, to address the gathering.
Thank you, Dr. John Panikka. I don't know whether I should speak in English or Malayalam. In any case, Dr. M.V. Pillai, whom I call as Manichetan because he is like a real brother to me, has already introduced the book. It was he who, during one of my trips to Chicago, wanted me to go and meet Dr. Robert Gallo. We went to Baltimore. I was in Chicago. He came to Washington. From Washington, along with him and Dr. Sarngathara, we drove to Baltimore. Dr. Gallo was waiting there. Before that, Dr. MVP had given me a copy of the book and said, you should please read it. He didn't, generally, he probably thinks that I'm a voracious reader. And I have also translated a book, 3 volumes of the book of Dr. Desmond Morris. One of them was a bestseller, which even outdid the fiction way back in 1970. After 10 years, he wrote a companion volume, and then he wrote me a letter. I was working in somewhere else. I must admire the Indian Postal Department. With the 13 or 14 redirections, it ultimately reached me. And then I did the translation of that book also. First one was edited by none other than Mr. M.T. Vasudevan Nair, who assigned me the translation. So Dr. Manichetan had already the 3 volumes. Probably he thought I would do justice to the book. So we went to Baltimore. We spent quite some time with Dr. Gallo, and we had a wonderful association. Then we parted, and he gave me an autographed copy of the book Virus Hunting. Now, there was some suggestion at some quarters that it should not be Virus Veta, the translation. In any case, I affirmed that it is the prerogative of both the translator, editor, and the publisher to find out which is the best word. The book was also by then printed. A few days ago, after I returned from USA, I checked with the English Malayalam dictionary, which is the most authentic document. The other word is Nayat, but I'm sure it was not a fitting word. So we didn't have to change. We decided both Shibu, and I decided not to change it. And I must thank Shibu because he went through every letter of the translation, and he told me when handing over a copy to me that it is one of the best translations into Malayalam that the Language Institute has ever published, a science book, especially of this nature. It was a huge challenge because words were mostly technical, though the English version of the book was very highly readable. When I sat up to translate, I didn't know which words to use. I have done postgraduate education in zoology, and virology was not a subject anywhere in the horizon. Later, when I worked in some other place, both mycoplasma and virology were associated with that institute, words which were associated with that institute. In any case, I'm not going into details. It was a huge and tremendous work, and I'm very proud that Dr. Shibu Sridhar, who has seen so many books, had gone into great details. There are a few mistakes. I myself know that. And I also wanted to thank Dr. Ramanguti from the heart of my hearts, because he corrected, for example, a word called cell line. ഞാനത് മലയാളത്തിൽ കോശരേഖ എന്നായിരുന്നു ആദ്യം ഉപയോഗിച്ചത്. അത് കഴിഞ്ഞ് ഡോക്ടർ പറഞ്ഞു അതല്ല, കോശരീതി. നമ്മൾ ലൈൻ എന്നുള്ളതിന് രേഖ, വരി എന്നൊക്കെ പറയുമല്ലോ. അതൊരു മേജർ അഡ്വൈസ് ആയിരുന്നു, ഒരു മേജർ ചേഞ്ച്. Likewise, there were quite a few other words which he corrected. So I should profusely thank him. I thank you, the Language Institute, for taking. We have spent so much of money on this. It is not easy to publish a book. You have to pay royalty to the author, get the translation rights, and then pay the translator, and also spend huge monies on printing. It's several lakhs, that book's total cost. So it was so kind of Dr. Karthikeyan Nair, who was the director of the Language Institute, when I went to him with this proposal. He actually stood up from his chair and said, so we know you only as director of Doordarshan. I never knew that you had translated Desmond Morris' book. He immediately called Dr. Shibu. He went one step ahead and he affirmed that I would do the translation. He asked me to sign the agreement, even without any formality. So I have no words to thank you. And Dr. Shibu, Manichetan is a family member, so it will be improper to thank him. Thank you everybody for listening to me. I should have spoken in Malayalam, but it's okay. I hope you will bear with me. Thank you very much.
Are you ready for the... Now, before the release by the chief guest, Professor Robert Gallo will be coming in the Zoom. Please.
I wasn't sure. Am I supposed to speak now? Yes, sir. You can speak.
Yes, please.
Okay. Well, first of all, good evening to everyone. And please accept my apologies for not being with you, and my deep appreciation for what you did for me for this book. I personally want to say a special thank you to, obviously, friend, Professor Pillai, a colleague. Your statements related to me that were in English, I wish I could be half the man. So I will use that as an inspiration. I'm really very, very happy. Yes, the book has been translated in many languages, some that you may be surprised, but I don't think I felt a warmer feeling, a better feeling than have it translated into your Malayan language. Yes, my friend Dr. Pillai, Professor Pillai, is right that unfortunate situation right now, having problems with being able to see properly, and this is progressing. We have been great friends for many decades. And yes, he played a major role in the development of the blood test. One minor correction. Professor Pillai mentioned with the ELISA, but it was, yes, we used the ELISA for the blood test. That was well-established kind of technology. There was a need for production of the virus done by another coworker of mine with two of my technicians that we worked towards. That was the ability to produce the virus. You mentioned the phrase cell line. Yes, it was needed, a cell line, a permanently growing cell, that we could have HIV reproduce itself forever, making production of a lot of virus really to be able to give out to the world, but also to be able to make a global blood test. But going back to Dr. Sangadaran, it was a technology that we said was needed to confirm and to be more specific, to take away from false positives, that he was extremely instrumental. And it was the first time in medicine that this technology was brought to the clinic. I speak of a test known as the Western blot. So our test was the ELISA plus the Western blot, taking advantage of our ability to produce a very large amounts of the virus. So that made the blood test kind of breakthrough, which was critical for us to prove HIV was the cause of AIDS. Why? Because usually acute viral diseases are obvious. I wouldn't even call them discoveries. The virus is often dripping off the tongue of an individual. I don't call that discovery, it's obvious. But this was mysterious. There were many ideas for the cause of AIDS, many. And how do you prove this one was causative when there were so many that one could think of that people were infected with? Remember, AIDS patients had so many viruses, so many bacteria. Which one was the cause? It turned out to be none of them, none that were obvious. So if you say, well, you have to find the virus and grow it, but it was extremely difficult because people had very few cells in their blood left by the time they showed up with AIDS. The T cell is where the virus was hiding. The T cell called CD4 T cell. And there were hardly any left when we got blood samples. So the results were highly variable, driving us crazy for quite a period of time. You find it, now you don't, now you do. And our thinking was that for science to progress, you know that you need confirmation, verification by others. And this was going to be a very hard task because people weren't getting blood samples. They weren't even allowed in many institutions out of fear. But in addition to that, the technology was really difficult because the cells with the virus were so few in number, because you would take a sample of blood, one person had hardly any T cells left. So you get negative, positive, negative, 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 and so on. So in many respects, the blood test was a breakthrough, not only for the preservation of the blood supply, but not only for diagnostics. You don't have to wait 5-6 years for the person to show signs of the disease. You know, AIDS takes a while to develop, and you couldn't find it until the person had AIDS. So now we could find it within a couple of weeks. This was really critical in our thinking. But for me, there was another reason that this was critical. Well, if we got therapy, we'd know who to treat. But even before that, how can I convince you that this is the cause of the disease? You're not going to confirm it. You're not going to find this virus, except rarely. So it was really scary. We were scared. We said, nobody's going to believe that this result. But the blood test broke the back of the problem. Everybody can do the blood test in the world. The centers, places, public health places, you could send this technology would be straightforward. So the confirmation came quickly and globally, and that was a big help. And without my colleague from your area, from this region, Sangadaran, I don't know, we would have been stumbling a lot longer, that is for sure. But once again, I want you to know that I've had many colleagues from India none better and none closer to me than Dr. Sangadharan, but I am grateful to the sons and daughters coming out of India that have been a part of my career. I am very grateful for the translator and the publisher. I won't go into pronouncing names. I am afraid that if I don't know well how to say a name that is complex, particularly in Southern India, that I won't do the right job. You know who you are, you know I know you, and I'll do my best to properly pronounce names, but please accept my heartfelt thank yous, my gratitude for what you've done. I want to say and acknowledge colleagues that are there that were mentioned. Nora has a complicated last name too that puts me in trouble. And every time I go to pronounce it, I will be corrected. But she is on the stage with you. Her prior name before marriage to a man from Sri Lanka was easy, Nora Grinnell. Now it's a little more difficult, and she'll say it to you properly. The other colleague who is present is a world-class virologist, Anders Vaughn from Stockholm's Karolinska Institute. Professor Vaughn, professor of virology, is really in general virology, meaning all virology, he's better than me, without any question. He knows more virology broadly than I do. I focused more, for better or for worse, but he really is more of a scholar in virology, and he's a critical component of the Global Virus Network, which leads me towards my ending of these comments to say something about the Global Virus Network. You know that this is something you heard from Professor Pillai, words about the Global Virus Network. Yes, we founded it in 2011. Yes, it's grown now to about, I think it's up to 70 centers in 40 or more countries. But we are extremely happy to have Kerala as part of it. One reason is because your youth of Kerala always, you always come out with strong medicine and its related medical science. But I think this is needed in Kerala to have a center in virology. I think it will be essential for the Global Virus Network to see Kerala as a future leader in many respects. Why? Because of the talent here, yes. Because of the connections you have, yes. And because you have definite problems periodically with viruses, as you know much better than I do. The last time I was taken around and it was pointed out to me that on one end of the subcontinent, towards one side there was dengue, and the other side there was a problem with Zika. And of course, we were getting the problem coming soon of the COVID. And in the background, not so bad, so much in India as some other parts of the world, but there's always HIV, which is still a pandemic, which is already being forgotten about. It's one thing I believe about pandemics. We always forget. And that's one of the reasons, one of many reasons why the Global Virus Network is important. We won't let people forget if we have a really functioning global virus network. So this will be for training future virologists, it will be for advising public health people, it will be for making sure that we don't forget, and it will be making sure there's a network of very competent virologists that cover all types of human disease-causing viruses that are connected, that are collaborated, and that are not shoved into a corner because of a different philosophy, obviously different, not a different religion, or a different political system. The Global Virus Network has centers everywhere you can imagine, including with countries that the Western world might be having difficulties with at the moment. So they are very active members, and we keep in touch with our Chinese colleagues, and yes, Russian colleagues as well. We don't forget them because of political dilemmas, problems, even horrors. So let me close this by saying Oh, I should have said, one of my closest colleagues right now is the clinical director of our institute, where I'm director. The clinical director is Shaim Kotalil. And where does he come from? Kerala. So right now, he's, yeah, I certainly have to say, one of my very closest colleagues, again, Kerala. So I'm really, really extremely happy that this is translation is happening. Yeah, it's a personal story. Yeah, I tell about difficulties I had, including, well, quite insecurity that I had trying to get into science at the beginning of my career. And I think it's important that we acknowledge these truthful things of our weaknesses, and how sometimes success is, it's perseverance, yes. It is dedication, yes. And you have to have certain abilities, sure. You also have to have some good luck. And I had good luck. So I thank you again for being here this evening and for listening to me. And I thank you for everything you've done to make this possible, this evening possible. Thank you. Okay.
Is Dr. Asha Thomas, Sri K. Kunyikrishnan, who is a translator of the book, Dr. John Panikkar, Professor Anders, Dr. Mohanan, Vice Chancellor, Dr. Kala Keshavan, Dr. M.V. Pillai, who is the force behind the translation, and also a colleague of Professor Gallo, Sri Shibu Sridhar from Language Institute, Mrs. Nora Rebecca, coordinator of Global Virus Network, and all other distinguished doctors and alumni of Trivandrum Medical College. I am extremely happy to be associated with this book release function on the occasion of the Trivandrum Medical College Platinum Jubilee Convention. And this distinguished institution in the capital of Kerala has been in the forefront of medical care and medical research. And while it is celebrating its Platinum Jubilee, it is befitting that a book of this nature, which is describing the story of man's engagement with the viruses, the micro entities, is being released today. I am happy that Malayalam is enriched by this translation. Our language is foraying into areas of technical, medical, etc. And while our language is trying to expand its wings, it is definitely a worthy addition to the language that such a distinguished work by Professor Gallo has been translated to Malayalam and made available to all the native readers the exciting story of how viruses and how the hunting or detection and the treatment, etc., of viral diseases have happened during the past few decades. In the title, as we have all seen, is virus veta. It is virus hunting. Of course, there can be some argument about whether the virus is hunting us or whether we are hunting the virus. I think both are happening simultaneously, because in the recent past, the RNA virus, the Cobit, has been hunting humanity, and a substantial population has succumbed to the virus. But at the same time, it is a victory on the part of the human ingenuity that we are able to look at these microorganisms, we are able to study them, we are able to understand them, we are able to take action to contain their onslaught on human civilization. Now, this has been made possible by the researchers and distinguished people by their hard work of the, under the leadership of Professor Gallo and several other researchers have contributed to this human understanding of the viruses. And that exciting story has been brought out by none other than the originator, Professor Gallo, in this book. It makes definitely exciting reading for every reader of Malayalam. And Dr. M.V. Pillai, the book says that it was Dr. M.V. Pillai who has been behind this translation effort. It was he who brought up this subject and then introduced the translator to the professor and got the requisite permissions, etc. And finally, after the effort of maybe a few years, Professor Sri Kunjikrishnan has been able to bring it into in our amidst us in very nice Malayalam language. I congratulate Sri Kunjikrishnan in this effort, because it is not so easy to translate these kind of books into Malayalam. A lot of technical words are there, and of course it is a challenge that he has been able to do it in a very in a very nice manner. I have scanned through the book, and it makes very worthy reading, mixing it with the experiences, even personal experiences of Professor Gallo in the process, along with some technical details and valuable information relating to virology. And as we are all aware, Professor Gallo is he has initiated this global virus network. And we have also in our state have started an institute of virology here to understand this microbiological world of viruses. As we go through this book, we come to know that what I remembered is the saying by Albert Einstein, who mentioned that we can live our life only in two ways. Either everything is a miracle or nothing is a miracle. The world becomes miraculous by looking into, by our awareness of what exists outside our usual sensory world. By means of our ability to peep into the other worlds, we have detected a lot of miracles. And this dictum that the life can be lived only as a miracle becomes evident when one goes through this kind of book. Of course, in the physical world, the same kind of miracles occur. Those people who were searching for electrons, they found that the electron itself is a miracle, though it is the smallest of physical particle or physical component. Initially, the person who found the electron and said that it is a particle got Nobel Prize, J.J. Thomson. After some time, the person, his own son, got Nobel Prize for saying that it is not a particle, it is a wave. And then again, de Broglie got Nobel Prize for finding that it is both a particle and a wave. And ultimately, though we are utilizing electron and making it work to do a lot of equipments, even in medical research, a lot of equipments are run by electron. We are not able to understand what exactly is this particle called electron. Even today, nobody knows what exactly is that. But still, we are able to work with it, and that is definitely wonderful. So is a situation with in the microbiological world. When things become bigger, molecule becomes very much more complex, they act in such a manner that they seem to have some kind of intelligence. Nobody has claimed any intelligence for electron. They are purely amenable to mathematical treatment, probably because they do not have intelligence. But when it comes to very complex molecules, microbiological molecules, they behave as if they have intelligence. That is why probably in the COVID scenario, all these viruses have joined together to fight with the humanity itself. So when they join together, they act as if they have some intelligence. How they get endowed, or do they have any intelligence, or how they get endowed with that kind of behavior, showing collective effort on their side when they deal with the threats, is definitely a matter of philosophical investigation, probably. So the world becomes mysterious, and as Einstein mentioned, the cosmic spiritual experience is a fundamental driving force behind scientific research. Scientific research brings a kind of spiritual experience, whether it is in the cosmic macrocosm or in the microcosm of very minute things. It gives a kind of spiritual experience. Anybody who pursues research brings a spiritual experience, and that spiritual experience is visible when one goes through this book, how these kind of micro molecules are able to act in the manner in which they are acting, how they are able to, change themselves and change their tactics, etc., as if they are endowed with some kind of ability to understand or respond to their environment in a particular manner. So when we go through this Malayalam, of course, the very proper words have been picked up and utilized for bringing out this translation. And it was mentioned by Dr. M.V. Pillai that what the mind does not know, the eyes will not be able to see. But probably the mind will not know what the imagination cannot show. And the imagination will not be able to show something which probably the designer of the entire picture has not destined us to see. മലയാളത്തിൽ ഒരു കവി ഇദ്ദേഹം ഇങ്ങനെ പറയുണ്ടായി, ഉള്ളതായി തോന്നുന്നുവെങ്കിലും ഓമനെ ഇല്ലാത്തതാണ് ഈ പ്രപഞ്ചം, ഇല്ലാത്തതായി തോന്നുമെങ്കിലും ഓമനെ ഉള്ളത് താനീ പ്രപഞ്ചം. സോ ദ വേൾഡ് ഈസ് മിസ്റ്റീരിയസ് ഇൻ ദാറ്റ് മാനർ. സോ ഈ ഇല്ലാത്തതായിട്ടും ഉള്ളതായിട്ടും തോന്നുന്നതിൻ്റെ പിറകിൽ നിർണയം ഈ മഹാമായതൻ പിൻപുറം നിൽപ്പുണ്ട് അദൃശ്യനായി ചിത്രപ്രദർശകൻ, തൻ തിരുഹസ്തത്തിലാണു നാം കാണുമീ യന്ത്രചിത്രത്തിൻ്റെ സൂത്രത്തിരിപ്പുകൾ. ദിസ് ഈസ് വാട്ട് ഹി മെൻഷൻ. ഈ മഹാമായയുടെ പിൻപുറത്ത് ആരാണ്, അതിൻ്റെ ചിത്രപ്രദർശകൻ, ഈ ചിത്രമെല്ലാം കാണിച്ചു തരുന്നത് ആരാണ്? ആ ചിത്രപ്രദർശകൻ്റെ കയ്യിൽ ഈ യന്ത്രചിത്രത്തിൻ്റെ വല്ല സൂത്രത്തിരിപ്പുകളുമുണ്ടോ എന്നതൊക്കെ നമുക്ക് ഈ ഫിലോസഫിക്കലായിട്ട് ആലോചിക്കുന്നവർക്ക് അങ്ങനെയൊക്കെ തോന്നുന്ന രീതിയിലുള്ള ഒരു മിസ്റ്റീരിയസ് ആയിട്ടുള്ള ഒരു വേൾഡ് ആണ് ഈ മൈക്രോബയോളജിക്കൽ വേൾഡ്. ഒരുമിച്ച് humanity has acquired lot of knowledge and more remains unknown always. It is always said that the sphere of knowledge is concentric or inside the sphere of imagination, because imagination is more important than knowledge. Now the sphere of the unknown is still outside, is bigger. So what is known is the smallest sphere in which our consciousness resides. And outside that sphere of knowledge, outside our sphere of consciousness, there is a sphere of imagination which is definitely bigger. We can always imagine more than what we know. And the sphere of the unknown is the biggest. And it is so vast that perhaps we will never be able to cross its boundaries. And maybe we can expand a little bit, but we will never be able to achieve full comprehension of what is unknown. So this fight, the virus veta, the virus hunting continues, and it will continue for the entire times to come. It was Philip it was Alexander, when he was trying to conquer the world, he was very unhappy that most of the world is conquered by my father. So what will I do when I grow up? Definitely those who do research of any kind will understand that there is no ground or reason for such apprehension. The world of the unknown will always be there for us to pursue. And no, humanity in its entire progress, whatever it is, will never be able to achieve entire knowledge of what is the unknown, what is left for understanding. So we are happy again that this book is released. Such a wonderful book has come to Malayalam, and I hope that Bhasha Institute, which has produced this translation, will be able to bring out more such worthy books into Malayalam, and which will bring more enlightened readers to understand these boundaries of what is happening in these boundary areas, both in science, engineering, etc., but at the same time, all other related topics. With these words, I am extremely happy to release this book, and I wish this Platinum Jubilee Medical Convention all success. Thank you.
Thank you very much, sir. So before concluding this function, in the last 1 year, we had lost 3 great legends of medicines who were the alumni of Trivandrum Medical College. So we, on the occasion of this 70th anniversary, we wish to present a posthumous Medical Legends Award to these 3 eminent teachers from Trivandrum Medical College. So the names I shall read. Of course, definitely it is from the seniority onwards I am reading. Professor K. Lelida, everybody must be knowing, our beloved gynecology professor, former professor, and even at the age of, she belonged to 54 batch, 1954 batch. I myself was a student of Lelida Madam. I was in 3rd year, final year, and house residency. And I think recently she had crossed the 1 lakh deliveries. So popular and liked by every person. So her family is here. So I request the family members, Lakshmi, Mala, Parvati, and Mr. Sadishan to come forward, and I request our Chief Secretary and all the other guests to join in presenting this posthumous award. Come straight, please. MKC, can you also please join? Yeah, MKC. Rameshwan sir, also, please. Yeah. Also, let me acknowledge many of the friends. Our Mr. Rajiv Nath, one of the renowned film director, Asad Mopen. So, yeah, in the other. Yes, actually, welcome. Now, our beloved Krishnan Nair sir, the founder of Regional Cancer Center and also the founder president of Trivandrum Medical Alumni Association, a great visionary, a great leader. I request Valsala Chechi under Valsala Chechi, Madam Mrs. Krishnan Nair sir, and sir belonged to 1959 batch, and he is actually the architect of the Regional Cancer Center, which we are seeing on the way. This is one of the biggest cancer hospitals in South India. The third is, of course, none other than our dear Joy Phillips sir. Only recently also he left us. He is one of the most popular medical teacher, general medicine teacher. And so I request Dr. Deva, Joy Phillips, our daughter. She is a medical oncologist in Regional Cancer Center, one of the brilliant product of Toronto Medical College. Deva, mask on. Let me thank all the family members of these teachers being present here. Now, we have a few distinguished alumni here. And the Toronto Medical Alumni Association, and on behalf of this Platinum Jubilee, is honored to present these awards to the following members of the products of Toronto Medical College. Dr. V. Ramankutti, who belongs to 1971 batch. Actually, he is the son of a proud son of our former Chief Minister, Sri Achyuta Menon, and also he was just 1 year junior to me. He is a social, a public health expert, and I request Ramankutti to receive the award from, both of you, Asha, the Chief Secretary and Principal also, please come. And Asha, Dr. Asha, please. Dr. C.S. Madhu. C.S. Madhu is a 1964 batch, 74 batch. And he was the founder secretary of Toronto Medical Alumni Association. He is a former professor of radiotherapy, retired from Kottayam Medical College. Madhu, please. Actually, he is the person who entrusted this association to me nearly 15 years back. I took charge after his tenure. I took charge of the Secretary of Toronto Medical Alumni Association. Thank you. Now, Dr. Samiran. Samiran IAS. Samiran is a 2004 batch alumni, and he is presently the collector of Coimbatore district. And we are extremely honored that a lot of administrators in Indian administrative service are from Toronto Medical College. Yes. Dr. Divya Gobinath, IPS. Oh, sorry. Okay, correct. Dr. Divya Gobinath, please come. She is, again, Indian Police Service. She was formal, even now, she is on leave. Even though she is on leave, she is the Superintendent of Police of Rural Toronto. So we are extremely proud that she is an alumnus of Toronto Medical College. Thank you, Divya. Actually, I'm sorry, and this order, there's a chronological order. There is Dr. Hariumaran Nair, 1979 batch. Dr. Hariumaran Nair? Yeah. He is, again, a professor of radiodiagnosis. Please come, please. Radiodiagnosis, and presently he is the chairman of the Kerala Medical Council. He was dean in Kerala Health University for some time. Now, yeah. Dr. Sheila is here? Sheila Balash? Yeah. Actually, there is another Distinguished Alumnus Award. Unfortunately, Dr. Krishna Manohar. He belongs to 1974 batch, and he is a cardiothoracic surgeon. He is really, right now he is not here. Unfortunately, he could not come because of some minor problem. And he had been doing free service for the last so many years in Satya Sai Baba Institute. He had been going to all the countries. Even last month, he was in, which country it was? Fiji. Fiji, he was doing 2 weeks camps, medical camps, and doing a lot of surgeries there in certain hospitals. So I think because he was out of Kerala, we could not recognize him before. But I request Mrs. Krishna Manohar, Dr. Sheila Balakrishnan, to come forward and receive the award from the Chief Secretary. We have two beloved teachers, Dr. Qasim Abdul Salim. Again, he belongs to 1954 batch. He is one. Actually, for a long time he was in Calicut, and after that he was in UK. He also could not reach here, but on behalf of Abdul Salim sir, I request Dr. Najib Usman, who is again related to him, to receive the award. This is a Lifetime Achievement Award. Actually, Salim sir is a very, very active, one of the best medical teachers of Kerala. And now, my own teacher, Shivachankrapala sir. Actually, he belongs to 1961 batch. He retired as the Director of Medical Education. I request, he was a professor of forensic. Please. So, thank you very much. And now I request the Vice Chancellor, Sri Dr. K. Mohanan, to address and propose the vote of thanks. Thank you.
Good evening, respected Chair of today's function, our Chief Secretary, Sri V.P. Joy, Additional Chief Secretary of Health, Dr. Asha Thomas, invited guest from Sweden, Professor Anders Vaughn, great oncologist, great leader of medical profession, Professor M.V. Pilla, the translator of the wonderful book which we released, Sri K. Kunyikrishnan, the editor of the book, Dr. V. Ramanguti, and the coordinator of Global Virus Network, Ms. Nora Samarnayake, principal of Government Medical College, Trivandrum, Dr. Kala Keshavan, and of course, the leading light behind the entire show, Dr. John Panikar, and eminent teachers, faculty members, my dear friends. Kerala University of Health Sciences is extremely happy to be associated with the release function of this wonderful book of virus, The Chasing of Virus by Robert Gallo, and it is translated amazingly well by Sri Kunyikrishnan. In fact, I came to know about Dr. Sri Kunyikrishnan when I was a student, by reading the book Nagna Vanaran, the book translated by him, The Naked Ape, which was serialized in Madhrubhumi, and it created such a great sensation during those days. And as he has said, that book sold more than the novels. That book sold. And he is a wonderful, amazing translator. And I should thank Professor M.V. Pillai to selecting Sri Kunjakrishnan to make this wonderful translation, and the book is an evidence for that. Today morning, we had a session on viral infections sponsored by Kerala University of Health Sciences. That's why Professor Anders is here. And here I should thank Dr. Asad Moopan. He is the founder of Aster Medicity and the Aster Empire for helping the university to bring these wonderful people to Kerala. Thank you, sir. Thank you so much. Now let me come to my responsibility. Our Chief Secretary has rightly said, മായയുടെ ഈ വലയത്തിൽ നമ്മളിങ്ങനെ ഇരിക്കുകയാണ്. ഈ മായയുടെ ഒരു തീരുമാനം കൊണ്ടായിരിക്കും നമ്മളെല്ലാവരും ഇന്ന് ഇവിടെ വൈകുന്നേരം ഈ പുസ്തകത്തിൻ്റെ കൂടെ ഇരിക്കുന്നത്. തീർച്ചയായിട്ടും ഞാൻ ഇൻഫാക്ട് Chief Secretary has contacted me when I was the Vice Chancellor in the early days, because there was a serious problem with Thrissur Puram. And there was a big fight between the Puram committee and the government. And the university interfered, and Puram happened. So, and for that, I should thank VP Joy for trusting the university, because people, normally people don't trust the university. So those days, he trusted us. Thank you, sir. I thank you for coming here. Asha Thomas, of course, is the distinguished alumni of this college and junior to me, but now the additional chief secretary, and we seek her support and help for various research activities, and I am sure that she will support us. Thank you, Dr. Asha. Anders Vaughn, the legendary clinical virologist, sir, thank you for being here. And M.V. Pillai, sir, in fact, I don't know how to thank him. I will be continuously thanking him. Thank you so much, sir. Thank you for arranging this. And Sri K. Kunjakrishnan for translating this wonderful book. And especially when this, we are in the post-COVID, I don't know whether we can say post-COVID or we are around the post-COVID season. This book is extremely relevant. And I assure you that this book will reach every medical student in Kerala. I will assure you that this book will reach every health professional in Kerala, because they should read this. Then and only then we will know. As it was said, we commit mistakes, but then from those mistakes only we will come to the real truth. So this book, we need this book for marching forward. Dr. V. Ramanguti, my senior, a distinguished alumni, more than that, he is supporting us. Supporting the university in very many ways. Thank you, sir, for being here, and thank you for supporting the university. Ms. Nora Samaranayage, thank you. Thank you for being here and supporting Gallo's talk. And we, in fact, we need your continued support, for we have to do research in the area of virology, and global virus network should be with us. Please be with us. Thank you. Kala Keshavan, of course, the owner of this medical college now, the principal. Thank you, Kala. And John Panikkar, of course, everybody will have to thank him. Thank you, John Panikar, so much. And our great teachers, they have been awarded posthumously, and our great faculty members and our great students. I thank the family members of each of my great teachers for coming here. I thank our distinguished alumni for coming here and accepting the small memento from the Alumni Association. You're all in our own hearts. Thank you very much. And I thank all the distinguished members of this assembly. Thank you very much.
Thank you, dear VC. But one announcement is this book is actual cost is 425. Now it is available as a offer. It is available for 320 rupees. I request all of you to purchase it right now and read it, and probably you can spread it. It is for some time it will be available through the Alumni Association office also, some more days. Tomorrow it will be there in this conference hall, inside the conference hall. And one announcement right now, the cultural program was already started. Today's main event is the Tiny Toms program. So I invite all of you for that and the banquet thereafter. Tomorrow we will be starting the function at sharp 9 o'clock with again one of the great legends of medicine, Dr. Pichmani, who belongs to 1955 batch, I think. He is in USA. He will be talking online. Followed by, there will be there's a public function in which the chief guest is Minister Sri V. Muralidharan, the Minister of State for External Affairs. Dr. Shashi Tharoor is there. Our Transport Ministry is there. Then, of course, Justice Indu Malhotra, she will be the keynote speaker. And we are honoring the former health ministers also, 4-5 health ministers, starting from Vakam Purushottam and VC Kabir, all this. They will be coming. So I invite all of you for that function also. Thereafter, there will be 2-3 orations, and the last meeting, the function will be a panel discussion of liver transplant. Hopefully we will conclude by last will be, there will be a general body of the alumni, and we will conclude by 4 o'clock tomorrow. So I invite all of you, request all of you to join tomorrow morning also, and this cultural evening as well as the banquet. Thank you. English version, yes. Also it is. So why English translation? You are a Malayali. Buy a